in the importance of evidence-based interventions. So it's not only anecdotal. It's not that somebody had done something and got some results. We need definitely evidence-based interventions, and we have got a lot of researchers who have created evidence about obesity management in India. There is no one-size-fits-all solution to obesity, and we need to tailor our approaches to the individual needs and circumstances of our patients who are coming from different geographical locations, different socioeconomic strata. Finally, we believe in the importance of collaboration. The fight against obesity requires a multidisciplinary approach, with everyone working together towards a common goal. By sharing our knowledge, resources, and expertise, we can make a real impact in reducing the prevalence of obesity. I remember in India, starting from the ages of Ayurveda and all old ancient sciences, we were quite restrictive or secretive. And that has to be broken down because we have to be collaborative, because the disease is global and the menace is real in India. So in conclusion, I would like to thank you all for your commitment to this important issue. By working together, I am confident that we can make a difference in creating a healthier society, India and world. Thank you so much.
Thank you, Dr. Nitin. And we will straight away start with the day's proceedings. And I would like to remind the moderators that we do not have a timer, but we would want you to really keep to time because we've already begun a little late. And to take you through the day's proceedings, I call the Master of Ceremonies, Dr. Falguni and Dr. Nazia, to take over the stage.
Hello, good morning. I am Dr. Falguni and welcome you all dignitaries to this auspicious occasion of BAPI. Let's not waste our time. Let's start with the topic obesity, Indian scenario, challenges and reward. I call upon Dr. Jayshree Ghanekar and Dr. Vijay Evle sir to the stage as a moderator.
Very good morning, and first of all, let me congratulate the obesity physician group for taking this initiative and brainstorming on a topic which is of immense public health importance. Before I invite Dr. Sanjay Khare to dwell upon the issue of obesity in children, let me thank that I'm a pediatrician and thank the adult physicians for inviting a pediatric physician amongst the obesity physician group, amongst the pediatric physicians group. But yes, there is a reason. Pediatric obesity is on the rise, and pediatric obesity is the precursor of adult obesity and the non-communicable diseases. If you look at the statistics, there are about 18 to 19 million obese children in India. And if you compare the statistics between the National Family Health Survey, which was carried out in 1516, with one which was carried out in 1920, the prevalence of obesity amongst under 5 children has doubled from 2% to almost 4%. And this is seen across all the socioeconomic strata. If you look at the Lancet article, which is published in January issue this year, the article talks about several children in one of the South Indian, in the southern Delhi government-run public health center, sipping at sugar beverage. So unfortunately, this sugary beverages and unhealthy food stuff is easily accessible, is cheaper than nutritious food, leading to tremendous increase in obesity even in the lower socioeconomic strata. Sadly, it is not a policy priority for the Indian government. There are schemes and programs to tackle malnutrition, but somehow this problem of malnutrition has gone unrecognized. However, let me tell you that Indian Academy of Pediatrics, which is one of the world's largest academy of over 40,000 pediatricians, has formed a task force which includes experts from adolescent medicine, pediatric endocrine, young infant and nutrition, and the non-communicable disease group. And they are coming out with guidelines for management and prevention of pediatric obesity. We are also hosting the first national conclave on pediatric obesity in Mumbai in the month of October. So I'm sure, I thought, let me take this opportunity and sensitize you on the problem of obesity, which runs across all the age group, and what we pediatricians are trying to do about it. With these few words, let me now introduce and welcome Dr. Sanjay Khare to deliver his first talk on the obesity amongst Indians, and I'm sure he would enlighten us with the magnitude of the problem. And please, Dr. Sanjay Khare.
Hi, good morning everybody, and thanks a lot Vijay, Jayashri, old colleagues, old friends of mine. So, Bharat Mata is actually seen to be very dukhi over here, and with a good reason. So the data which I'm going to present right now will absolutely convince all of us that India is not doing too well. Bharat Mata has every reason to be a little unhappy. So the topic of the day is obesity, data challenges and rewards. All right, so friends, first let us shake out of our disillusionment. At this point of time, what do you guys think? What is the largest killing cause in India? Is it malnutrition? Is it wars? Is it earthquakes and famines? Is it malaria, tuberculosis, dengue, HIV? No. The biggest killer at this point of time is Mr. Obesity, and we have ample amount of data which I'll be presenting. Huge amounts of obesity is on the rise, so are the graphs. Now, I'll start with a little bit of international data and then I'll come into Mother India properly. So these are the awesomely gruesome figures all over the world. India, Times of India also had presented this as recently as the 2nd of March in 2023, and the grim prediction is over 50% of the world population is going to be overweight and frankly obese by the time it's 2035. And as we know, a significant part of the world is Indians, so you can imagine how badly we are going to be off. 1 out of 3 women in the city are already overweight or obese, all right? And this is the Indian scenario. We have all this published data from reputed national and international journals, which actually show that the weight is indeed a weighty problem. Whether you call it males or females or adolescents, whichever age group, this is going to be a significant problem. Whether it's urban or rural, whether it is rich or whether it's poor, in whichever part, whichever strata of society, obesity is a burning issue. So why are we so worried about obesity, friends? For the simple reason that obesity is a precursor of almost all diseases known to mankind. You get rid of weight and most of your problems are going to go poof. So at this point of time, something like as august and organization as WHO has already said that obesity is a burning issue, and it is likely that 6 times the deaths are going to be because of obesity than because of any other illnesses known to mankind. Very paradoxically, underweight status is not as dangerous as overweight status. And that is why we have been having articles after articles. We are having organizations after organizations telling us that if we don't do anything right now, we in the future and our descendants are definitely going to be they're going to be in the eye of a metabolic storm. And that's why obesity is the new world disease. The problem is people don't realize how bad obesity is. People think it's only about, not being able to fit into a bikini, not able to wear jeans. The common, like Vijay will agree, "Arey, mera ladka healthy hai. Yeah, I'm a little chubby." It's not that. The thing is, chubbiness, healthiness are all relative terms. They're all bullshit. The thing is, every obese cell is dangerous. It's bloody dangerous. Why? Because it secretes all these sorts of chemicals inside the body. You're going to have chemicals, toxins, hormones, frankly, which are all going to be dangerous. So which are these? These are the chemicals which every adipose tissue is faithfully secreting into your body every millisecond of your existence on planet Earth. So these substances are noxious. What do? They cause inflammation, platelet aggregation, capillary permeability. They increase the susceptibility to infections. They reduce the threshold to health. And that's why every organ, every cell system in the body is going to be chewed up. And it's no surprise at all that at this point of time, 66 illnesses are known to be absolutely intricately associated with obesity. Start from the brain, normal pressure hydrocephalus, depression, obstructive sleep apnea, you go down. You name the system, and obesity has affected that. So that is why we say that it is the mother of all illnesses. I'm just going to rush through that. The particularly most dangerous at this point of time is this. I have seen people come to us with frank cirrhosis because of obesity, and you can't do a damn about it. It's very sorry to see the people just die. We've had so many cases. People don't realize at this point of time, but the employment rates are low, personal happiness is low, personal life is bad with obesity. So these are the sort of illnesses which are absolutely intricately associated with this, and that's why it has been declared as a global epidemic. And this is the amazing fact which a lot of people don't know, that whatever deaths COVID had caused, it is just 3%. Much more than that are going to be caused by Mr. Obesity in the decades to come. And that's why obesity is a global epidemic declared by almost all the organizations known to mankind, the medical faculty, and its public enemy number one. So why are we here? We are here because it's time we kept our ears to the ground, and as Vijay said, peep into the future and find out what we are supposed to do. We are all doctors. What are we going to do as responsible Indians? So, is it something that we are wrong? Kahin pe kuch galti ho raha hai kya? Is it the way we live? What is exactly ailing us? So, in India, we have a very peculiar paradox, don't we? At one end, we have the most underweight people, and at the other spectrum, we have maximum obese people. No country in the world can boast, if it can be called boasting, about this particular episode. And we have got huge amounts of data, whether in the lay press or whether in firm press, that India's obesity has been doubling over the last 10 years or something. So we have all these national health studies, part 1, part 2, part 3. These are very nice organization which gives excellent data, which I'll be talking about in the future. And amongst women, amongst pediatrics, amongst adolescents, we are really zooming across, we are cutting across the borders, we are really expanding, literally so. So even in the college students, even in the school students, and the most important thing, of course, physical activity and aging are the strongest determinants of obesity. So we have to sensitize the public as much as possible. Now, amongst obesity, what is it that I am particularly worried about? Is the abdominal obesity. This fat, which is centralized over here in the tummy, which is the most dangerous. I'm not really worried about obesity in the legs or obesity, fat deposition around the waist or around the hips. It's the abdominal obesity. Why? Because for some peculiar reason, it's that abdominal obesity which really damages a person's life. That is the obesity which causes cirrhosis. That is the obesity which causes cytokine storms. That is the obesity which is associated with hypertension and ischemic heart diseases and infarcts and all that. Does age have anything to do with it? Yes, for the simple reason that at various segments of age, Indians have been putting on weight. Now, we have been seeing that particularly in the middle age. In the middle age, the middle starts expanding. That is to put it in a blank way. So why is it? Either because there is more affluence at this age, ki dimag mein aaya, samne chocolate dikha, purchase it because you have mullah in your pocket. Or it might be because the BMR is going so low that even if you eat a little, you don't burn the calories and you put them on. So the middle-aged people are the ones in India who are really putting on phenomenal amounts of weight. And this is the data right from 15 to 49 maximum, and then towards 30 to 45 is the other peak surge. And look at this. This is shocking. The amount of males and the female obesities. Maximum is from, say, around 35 to 50, that particular age. So what about the gender discrimination? Is there any difference between the two? it's surprisingly, or rather not surprisingly, it's the women in India who are getting more obese as compared to the males. So if you take a survey, identical socio-economic status, identical academic status, academic rural or urban status, is the female of the species who is going to be more obese. What about the affluence aspect of it? Does it have any role to play over here? Well, of course. As would be expected, people who are in the higher economic group are getting more obese. So the more affluent you are, the more obese you are. We have been doing some survey, which I'll be talking about in the next session. But this is not at all surprising. But what is surprising is, I'll be coming to that slide in a little while. So people who either belong to the middle or higher wealth quintile, so entire economy in India was distributed into 5 quintiles, 1, 2, 3, 4, 5. So it's quintile 4 and 5, which is what absolutely high, obscene amounts of obesity, which has been increasing in the last 2 decades. So affluence has definitely something to do with it. Not only that, in fact, I haven't put up the slide over here. This generation's kids are even worse off. Because they were kids, they have been having tabs and mobiles and screens and all sorts of things and McDonald's culture. So we have more amongst they say Indians have been growing fatter over the last 15 years. Now this is the surprising thing which I was talking about. There has been huge amounts of survey. What about laborers? So we are not talking about lower socioeconomic conditions, we are talking about laborers, poor people who don't have anything to eat. So they come from smaller places to bigger places. And these guys, in spite of low socioeconomic condition, in spite of living in slums, this is the population which is growing obscenely obese, even much more than the affluent people. Is it the Vada Pav culture, or is it the Farsan culture? Who the heck knows? Or is it stress? So we are going to come to it. Now this is a very nice slide which has actually distributed India into all sorts of zones. So as to which part of India is the fattest, and as you can see, it's the North India. Now, this is something which is obscenely disturbing, because traditionally, the people in the Far East have always been phenotypically more of Singapore or Malaysia type of people, slim, trim, Koreans. This segment is getting more fat. This map I have been seeing every year, and this particular segment has become fat, which was never the case in the years to come. And this is the age-wise, this is the area-wise distribution. So this is the data. So the thinnest people are from Bihar, and the highest are, of course, from Delhi and from the northern area. So again, over here, we found the same thing. That is the females who were probably more obese as compared to the males. And in the Indian scenario also, we found that maximum thin people were from Jharkhand and Bihar, and the highest proportion are from Puducherry. Surprisingly, again, Puducherry South, we were never expecting people to be so obese. So Dr. V. Mohan was the first one who about 15 years ago came out with an article saying that people from Tamil Nadu are getting fatter. And now we have already seen this review over here. So maybe the low basal metabolic rate. The other thing is, it has been, as a housewife, she feels that, itna sahi bacha hai, why keep it for tomorrow, finish it. So, that grazing sort of thing. India is so badly off, and that's the reason why ICMR has now proposed to get the BMI definition to 23 point something. It used to be 25, 26 at one point of time. So India as a nation has revised the definition of obesity for the simple, and this is the reason why. So we Indians are notorious because we probably have more fat inside us as compared to a same person with the same BMI who's a non-Indian. So a Caucasian person and Indian person, we have much more dangerous fat inside the tummy. So the other healthy guys, they probably have distribution outside, but we guys have it more inside. And that's the reason why we Indians are particularly bad. And now the most dangerous aspect, I'll be coming to it. This is what is going to happen to our future Indians. So this culture, chips and, soft drinks, this was the headline about a couple of months ago. So we already have the second highest number of obese children. This is disputed because the latest data from China has already said that India has overtaken it. I didn't put the data because I didn't have authoritative confirmation, but take it from me that we are already number 1 as far as adolescent obesity is concerned. So again, this I feel is an underestimation. It's really much more than, and of course, screen time. The more the screen time, the worse we are. Look at this data, which is pathetic. 4 and 5. In 1 year, there has been a huge jump in pediatric obesity, and this is the amount of pathetic figures which are expected. So I think it's time all of us really opened our eyes and did something, because we are going to inherit this sort of population in the days to come. Now the thing is, why? Why is it that? Why are we all getting obese? Why India? Why all over the globe? Is it because of the food we eat? Is it because of the pesticides which we are consuming? Is it because of some infrared radiations? Is it because of microwave usage? Is it because of pollution? Who the heck knows? It is screen time, or is it because of reduced oxygen, physical demands? Is it because of easy availability of food? Because Mother Earth has never produced as much food in the last 50 years as it has so far. So maybe the production of food, easy availability, distribution in the whatever, or sleep, most important, we are not sleeping. And of course, there is this thrifty gene hypothesis. So by which it is Barker's theory that we probably are thin to start with in our adolescent period, and then we catch up and we overbound. So this is the amount of calories which we are hogging at this point of time. It's obscene. Is some virus infection affected? Yes, sure. There is, in fact, it has been proved by very much an Indian person called Nikhil Dhurandhar. And he has proposed that there is a virus called adenovirus which actually causes obesity in kids. It has been confirmed. So what are the challenges? Challenges, it's not about medicine. It's enough to cause bankruptcy to our nation. And there is no exaggeration about it. Like I said, obesity is going to affect everything from depression to osteoarthritis to hernias to pancreatitis. So imagine the amount of absenteeism which is going to be happen. And look at this slide. This is more dangerous than the money we are spending on treatment of obesity is going to be much more than what we spend on violence, war, and terrorism. I mean, that's saying something. This is the American data, and I'll give you some Indian data. This is obscene, 301 billion annually the income is this. It is enough to reduce any country to bankruptcy. So these are the American figures. The British figures, the Britishers have actually said that please send your patients for bariatric surgery. Kuch bhi karo, vajan kam karo. Otherwise your NHS, National Health Scheme, is going to get bankrupted. And for India, it's so bad. You know, we can't afford it. Yeah. I mean, the Americans and the Brits, maybe they can, but we can't. So this is the amount of economical challenges. The figures are horrible, and no wonder per capita income is going to be low and low and low. So 2.8 lakh crores a year, this about more than our GDPs, and it's expected to be 2.5 already. Again, this 1% is an underestimation. I spoke to a patient of mine. He says, actually, doc, this figure is 2.8. It's not even 1. I didn't put it because I didn't have athletic data. So suppose we reduce the weight. Is there going to be rewards? Well, yes, there are. So suppose you even reduce a little amount of weight, this is the amount of benefit you are going to get. Just get rid of 5%, not 5 kilos, 5% of your body weight, and you are going to be better off as far as your liver and your kidneys and your beta cells and your sugar control and all is concerned. You get rid of something like 16%, you are going to be free of diabetes. That's diabetes reversal. So this is the most important slide which I have to say at this point of time. At this point of time, what is happening is we have different doctors chopping at different branches. So we have one cardiologist over here, we have one pulmonologist over here, we have an orthopedician over here. But friends, the tree of diseases, the stem is obesity. All of us have to chop the stem down, get that damn tree down. We don't need any other faculty, we don't need any other doctor to get rid of that particular thing. Like I've just shown you, reduce 5%, your blood pressure and diabetes is going to be a thing of the past. And that's why we have proposed this organization. That's precisely why we want this sort of thing to happen. So friends, the world is already bad enough, with population and terrorism and pollution and corruption. Do we want to make it worse with this or this? These are not computer-generated images, boss. These are actual people. This is a guy in Milan, Italy, who's living the way he is at this point of time. This guy. And this is the worst thing, and this is probably the worst. So, Darwin will be turning in his grave, So we have Australopithecus, Ginzenthropus, Homo erectus, Homo sapiens, and now what? Homo picus? Is that the fate of mankind? So, time is running out. It's time for all of us to come together, get our forces together, and let's do something really concrete about battling obesity. Abhi picture baki hai, because I'm going to present some latest data which we, Apollo Hospital and NMMC have done. That data is pathetic. So I'll be presenting that when the honorary chief guest comes over here. Thank you so much.
Thank you, Dr. Khare, for a comprehensive presentation of data, the challenges and the rewards. As we know, it has become an epidemic. Obesity has become an epidemic in 21st century in India. And Indian obesity is increasing like anything as you put the data. If we have time for, if any questions are there from the audience.
let's move on, I think.
Yeah, so if there are no questions, yeah, thank you. Thank you, Dr. Khare.
Thank you, Dr. Vijay Ole sir and Dr. Jayashree Ghanika ma'am. Hello, good morning all of you. I'm Dr. Nazia. Now we are going to proceed with the next topic, obesity, a chronic disease, convincing the patient. So now I'm calling Dr. Bharat Agarwal sir and Dr. Rajesh Patil sir on this stage as a moderator.
Nicely. I'm Dr. Patil. Any disease which is difficult to get treated, after some times we label it as a chronic disease. And this being a very slow rising disease, patient tends to get neglected or they neglect themselves because it is not affecting them immediately. So it is very difficult to convince this type of patient. Let us see what Dr. Sanjay Godbole has to say about it. I welcome him on the stage to deliver his lecture. Thank you.
Yeah. Good morning, everybody. Respected chairpersons, all my friends in the managing committee of BAPI, and the doctors who have chosen to attend this very important topic on obesity. Basically, the topic that is given to me is obesity is a chronic disease, how to convince the patient. What essentially we'll be learning or understanding throughout the day will be the science of the disease, science of bariatrics. What I'll be dealing with is the art of medicine or art of obesity, where we need to convince the patient that this is a disease and we need to consider treating it rather than letting it go or leaving it alone. We know that this is a fundamental problem, and every speaker before me and following me will be talking about the numbers, which are going to be very alarming, and that too, it is going to be something which is giving us time for introspection. Are we living in an obesogenic environment? Is it because of plentiful food? Is it because of large serving portions, lack of activity? It's the reduction in food cost? Or is it the food industry which is dictating our way of life? We need to understand, are we living in an obesogenic environment? We have seen by what Dr. Khare told us is about the alarming numbers in which we are living in. India is obviously not an exception to this epidemic of obesity. In June 2013, the American Medical Association found that obesity is a disease state, and we need to accept that. It's not just sort of a causative factor that you're dealing with, but it is recognized now world over as a disease state. And number of medical societies all over the world have recognized this. Our ICMR was also keen to take a note of it, and we have numbers for labeling somebody as obesity. coming down gradually from the era in which I studied, which was around 30, that we used to take BMI cutoff point, came down to 27 to 25 and coming down further. It is reaching the epidemic proportions, and not only adults but also children and adolescents. I had my couple of DNB students doing research on adolescent obesity, where we had been to various schools and collected data about various activities that they do, the screen time and things, and that was one of the research topics for that. Do we really recognize obesity as a disease? Yeah. All these disease states have been known to be associated with this, and the health-related complications are known to all of us. The Indian scenario, Dr. Sanjay Khare has already talked about. We have seen how childhood obesity is a precursor for something that goes on into the adulthood, various complications which are underlined in the childhood obesity. So we know, we are convinced that this is a disease. We know that it needs prevention, as our president already talked in his presidential address. How do we get our patients to get convinced that this needs to be treated, needs to be attended to? How to convince the patient? That brings me just to recapitulate the Aristotle's 3 pillars of persuasive communication. I know it may be a little boring, maybe it may sound like a PSM subject, but it is necessary. As I said, it's the art. It's something that has to go into the head, it has to be acted upon, and it has to be heartfelt. So the logos, ethos, and pathos, the 3 pillars of persuasive communication, which needs to be followed to the core when we are dealing with obesity and when we deal with patients in our clinic. When we discuss with the patient, we need to define the terms of discussion. Is it a moral issue? Is it an aesthetic issue, which is more so when we are dealing with obesity as a chronic disease? And is it an issue of personal rights and freedom? Like we talked about adolescent obesity, we are dealing with the easy access to the gadgets. So the child considers that mobile phone is a right. It's his freedom to use the mobile phone. It's the freedom to use. He prefers playing football on the mobile rather than playing football on the field. As a clinician, when I sit in the clinic, I have to develop my reasoning. And probably, as I said, the science that I'm talking about is what we are going to imbibe throughout the day, the various deliberations that we have during the day. So I want all of us to develop our supporting reasoning, supporting legs to the table. When I am putting the person across the table, I need to have my reasonings in place. So I need to have the various data, various evidences that, of course, we'll be learning throughout the day. So I have to back up my reasoning with vivid examples. And over here, I remember there used to be a Weight Watchers Club. Of course, it wasn't an entity in India or in Mumbai, but this was one way of convincing the patient that he needs to lose weight. When you are having a Weight Watchers Club, you are trying to look at how best the person can lose weight. So the concept was like this, that a group of individual patients will gather on a particular date every month, and every person of that group will board onto the weighing machine, and the announcer or the physician who's taking charge of it will say, was this person weighing 90 kg last month, he is weighing 89 kgs today, and everybody will clap. If that person says that, the announcer says that this person was weighing 90 kg last month and he is weighing 90 kg today, there won't be any claps. And if it's the other way around, if was weighing 90 kg last month and he's weighing 91 kgs this month, there'll be boos going around. Naturally, the persons who are attending this Weight Watchers Club will feel that I should get claps every time that I board onto the weighing machine and not the boos or not the silence. So naturally, when you have something like this, you need to be very particular or the way you are going to deal with obesity in our clinic. We should make sure that the patients who are sitting in the clinic, they understand my viewpoint. What am I trying to tell them? Why is it necessary to bring down the weight? So find out the facts first and without making any assumptions. So one should know what is the background of the patient, what does he need to do in the first place. For example, if he is diabetic, if I ask him to lose weight, obviously it is going to be helpful to him in order to reduce his medicines. If he is hypertensive, again the same thing. If he is having an overweight issues with osteoarthritis, he loses weight and his mechanical problems also can get sorted out or at least symptomatically better. It is like giving an inch and gain a mile. So every time that he loses a kg, if he gets a word of praise, a word of consolation from me, it goes a long way because it's like gaining a mile. He feels that he has achieved something in the last 1 month of treatment or 3 months of treatment that I am dealing with him. The difference between discussion and arguments, that an argument has escalated past rationality and driven by ego. Now, this is very important. When he says that, okay, this was because I attended a lot of weddings that my weight has increased, I need to accede to something of it rather than, saying that, oh, this is not acceptable and things like that. So maybe one can definitely persuade him to perform a little better during his next visit. So basically, it is giving an inch and gaining the confidence of the patient for a better weight loss. I tell my postgraduate students that in an intensive care unit when you're working, it is like masterly inactivity, but you are a watchful observant. So you need to be confident when you are saying, but you need to be assertive. You need to be master of the situation, observe. That increase in weight is giving rise to a higher BMI 3 months down, higher A1C 3 months down the line is what I need to convey to the patient. I need to assert that, okay, this has negatively influenced his metabolic status, may it be his LDL cholesterol, may it be his A1C or his waistline for that matter. So just believe that is the cause and it needs to be seen in that particular aspect. We need to stay calm. So when I educate my patient, and in fact I had started Sherman, which is the education center for the patients, we educate the patient to that effect. We need to remain calm. We need to accept the reality. We need to listen to the patient attentively and give importance to it, because just scolding the patient is not going to help. It may be a poor way of convincing the patient. You are just trying to say that you are right and he is wrong. He may have his own reasons for being so. We have seen that over a period of time, we need a multidisciplinary approach. It is not just the clinician, a diabetologist who's sitting in the clinic and dealing with it, but we need a nutritionist and an educator who's going to help us in delivering what we need to deliver to the patient in terms of the science, in terms of getting things done from him. And that too at a reduced cost, because these are not the things which are going to cost anything to the patient. So then you are dealing with both art, science and commerce for the individual. What's happening there?
Yeah.
Thank you for a patient hearing. If you have any questions, please go ahead.
Thank you, Dr. Gurpale. It was a wonderful talk. If audience have any questions, please go ahead. I think if there are questions, we can ask in the lunchtime. Yeah, Dr. Neeta, you want to ask.
I was also thinking that convincing a patient, maybe it might help to tell in their own words about how, the hormonal changes happen after weight loss or why a person has become obese. Maybe that will make them understand that it's a chronic disease. So maybe do diabetes education in the same way.
Absolutely. The point is well taken. I mean, what I mentioned was we need to have our facts clear. The science of obesity needs to be cleared. And once we have that basis to a given patient, we need to make him understand what he needs to do. But I take your point that it needs to be told to the patient in those clear terms. Thank you so much.
May I request Dr. Nita Deshpande ma'am to hand over the mementos to our speakers and the moderators.
Keep it far.
I also request Dr. Jayashree Kanekar ma'am to collect the mementos from Dr. Nita Deshpande ma'am. Dr. Bharat Agarwal sir. Dr. Jayashree Kanekar ma'am, please. We'll proceed to the next session. Now I call upon Dr. Bandukwala sir and Dr. Akshay Chalani as a moderator to the topic industry sponsored session. I request Dr. Bandukwala sir to announce the next speaker.
Good morning, all of you. It's really a pleasure to come to this esteemed hospital. And I'm suppose I'm part of BAPI as well. So this is the first CME program and an installation program here. But now the role of Akshay and myself is to moderate a 1 hour session, which is 4 speakers we'll have. And each will be speaking for 15 minutes. I'm sure the esteemed speaker will keep to the time so that we can keep a balance. The previous 2 speakers have set the ball rolling, giving us all the data about the presence of obesity and the Indian scenario. And Dr. Sanjay Godbole also told us how to convince the patient that obesity is a disease process and you need to treat and prevent it. So as a first speaker, we have none other than the man behind this conference, and the secretary of the BAPI. He has already spoken to us on Indian experience on obesity. He comes back and will speak to us on barriers to optimum obesity care. I think it's extremely important and that we understand how to start the process of obesity care. Dr. Sanjay Khare, please.
Right. So now friends, this particular session is going to be more of giving the data, and I've spoken to Vimal also. What we are going to do is we are going to just skim through this presentation. It's very important, but I would like to give more importance upon the discussion which is going to be happening at the end of the things. So not a surprising thing that the leading cause of death at this point of time is non-communicable diseases. So gone is the time when mankind was dying because of plagues and choleras and all those sort of gastroenteritis and neonatal mortality. Now it's the disease of affluence. So as I've already said before, the more obesity you have, the more it's going to contribute to other diseases like ischemic heart diseases and hypertensions and strokes and that sort of things. So the huge amounts of prevalence of obesity in India and the world has already been documented. So what this particular study has done is it has studied something like 7 to 8 countries from the Asia Pacific area, India being one of them. And we have actually seen the data as to how many people are obese, what is the problem, why are people getting obese, why are people not able to shirk off weight. So the whole focus was on this. Not only that, it's very interesting for the simple reason that this sees obesity from 2 perspectives, from the points of view of the patient and from the points of view of us doctors. Are we falling short? Are we not empathetic enough? Or is the patient not doing well enough? So this was the action APAC study, and it was done with the primary intentions of studying the perceptions, attitudes, behaviors, and what are the barriers. So how was it done? So there was something like patients, something like 20,000 people all over India, and there was something like 70 or more doctors all over the country. So these are the people who were actually studied. The patients had their BMI, the age had to be more than 18, the BMI had to be more than 25. And the doctors were also very carefully evaluated. They had to spend at least 50% of the time in direct patient care. So we were clinicians. I mean, they didn't have any backbenchers over there. With a fairly heavy practice of more than 100 patients a month. And a lot of it was, at least 10% of it had to be obesity-centric. And they should have been in practice for at least 2 years. So 2,000 people, 300 doctors all over India, and this was the study done in APAC countries, of which we are presenting the Indian data. All right. So we are going to show you 2 columns. In one column is the patient's perspective, and in the other column is the doctor's perspective as to how you look at the same scenario, and that is how you will understand what the things are. So first is obesity is a chronic disease. Almost both the parties agree, whether the patient or whether the doctor. So now we are going to just skim through this. I would like you to concentrate over here. The essence is more important than the actual statistics. Statistics are not important. This whole study is meant for us to understand why is dealing with obesity so bloody difficult. So I'm going to flash to the sides, but being a scope certified bariatric physician, I tell you some pretty basic stuff. It is so difficult to get rid of even 1 kilo of the weight. Let me tell you. So we have shown slides that, okay, you reduce 5% and your ye ho jayega, reduce 15%, diabetes chala jayega. But is it easy? It is so difficult. More difficult is keeping that damn weight off. So getting rid of 1 kilo and keeping that weight off, both are horrible tasks. So for everybody's consumption, we have to get rid of 7,700 calories to get rid of 1 kilo. All right? In other words, you have to walk for 7 hours to get rid of whatever calories you had with one huge burger and one Coca-Cola bottle. I'm repeating this. You go to a McDonald's, you have one burger and one Coca-Cola bottle. Whatever calories you are putting on, you will need to walk for 7 hours to get rid of that amount of food. So this is just one thing. So that is how difficult it is. It's very easy to fall prey to food, and it is equally difficult to get rid of that. So losing weight is very important. People agree, both the parties, that yeah, बहुत अच्छा है, वजन कम करना पड़ेगा. Yeah, everybody is hunky-dory. But it's so difficult. The cost of obesity, the sheer mehnat that goes into it, it's all so difficult. Now, attitude towards weight loss. Now, this is where the contradictory things are. Doctors have to be more proactive, whereas patients have to ask for help. First, it has to be drilled into their heads that obesity is indeed a dangerous illness. So the lafdas over there, most people don't realize that obesity is so bad. So that's why organizations like us have to come together and say, no, it's bad, you have to better shape up or you are going to be in a problem. So that awareness has to come up for both doctors and for patients also. See that slide. A lot of doctors themselves don't really look very favorably upon obesity practice, So again, a lot of them agree, both the parties, that it's the intake and the output mismatch, which is causing obesity. You want to get rid of weight, it makes more sense to reduce your intake and increase your output. Theoretically, yes, but that's not the whole truth. We now know that there are a huge amounts of other factors over here. I have had so many people who hog away like crazy and they never put on weight. I have had a lot of patients who eat just a little and they put on obscene amounts of weight. So it is a little more than that. As during the day, we will come to that. So obviously, both the things acting that, there's a huge stigma in being obese. So social stigma, physical stigma, getting married, getting job opportunities, getting promotions. There was a huge study which was published in Time magazine, which said that an obese person finds it more difficult to get a job and even more difficult to get a promotion. So huge amounts of psychosocial barriers over here. Discussion of weight. Now this is something which I want to touch upon. Nowadays it is supposed to be politically and socially correct for us to ask the patient first, look, do you want to discuss about weight? Now there's this whole thing about body shaming and all sorts of things. So most obesity societies first make it a point to request the doctor to take the patient's approval before broaching the topic that, Arey, you seem to be overweight, what's the problem? And it's a barrier in our mind. Like I am personally guilty of this. Whenever I see an obese person, I'm prejudiced. He must be a lazy bum, not exercising, hogging away, no self-discipline. But now, after years of obesity practice, I know that poor fellow is a victim. He's a victim. So we have to change our attitudes and we have to be a little more sympathetic. And very surprisingly, most of these people have made multiple attempts in getting rid of the weight. They have never succeeded, poor people. So that's why it's very difficult. So medications, we hardly have any medications at this point of time, but yes, things are going to improve. Things are already improving as will come up in the panel discussion afterwards. A lot of them have barriers about weight reduction medications, the side effects and the possible costs. We'll come to it later on. And of course, we have to motivate them, you have to show them the rosy picture as to what is going to happen if you reduce even a little amount of weight, and that is the best way. So the conclusions are, yes, there is a huge dichotomy between the requirements of the society and between what we doctors are giving to our patients. The sooner we come to a golden point, the better for us and for the society also. Changes have to be on both the sides, for the patients and for the doctors also. That is exactly what this study was trying to project. All right? Thank you so much.
Yeah, Dr. Khare sir, you chose a difficult path and that obviously there are obstacles and barriers. Any questions from the audience for Dr. Khare sir? Panel discussion. And I request Dr. Vimal Pahuja to deliver his talk. He'll be talking on looking closer at appetite regulations. Dr. Vimal is a consultant physician and obesity physician at Powai Hiranandani Hospital. I request Dr. Vimal to just take over.
Thank you very much. So when Neeta gave me this topic, looking closer at appetite regulation, I felt like a metabolic voyeur, looking so close. What should I look close at? But I tried to give a little bit justification because appetite regulation is very important for obesity. This change in the appetite has brought about this entire epidemic of obesity. Appetite is not just the hunger, it's more than the hunger. So this is what I'm going to tell you about in this talk of 10-15 minutes. The learning objectives is to be appreciate that appetite and satiety are determinants of food intake, understand the neurochemical signals governing appetite and satiety, appreciate the role of hypothalamus in integration of all signals to regulate the food intake, and application of knowing appetite regulation in clinical practice. That's very important. So when you look at the normal energy balance, it's a very efficient regulatory system and is very efficiently regulated. The food you eat and energy you expend, it brings about the optimal metabolic status if the pathways, the hypothalamus centers are functioning fine. So this body weight is maintained because of that. Appetite, you should know what is actually appetite. When you have a meal start signal, there are two signals, which is hunger. Hunger is just a need for calories, and appetite is a sensation which mainly results from cognitive input because it expresses the want for specific food. Appetite is just related to palatability. Now, this change in the definition you must appreciate. Cognitive is a cognitive need. Change related to palatability, smell. visual effect of food and its texture and our previous experience of specific food. So deeper, it's much deeper than hunger, which we appreciate. We have a loose term. We use appetite as a hunger, but it's not the same. It's a desire to eat, which can be very overwhelming sometimes for people. Meal stop signal is there, satiation. So this is one signal of satiation, the feeling of fullness that stops a meal. And satiety is a preeminent metabolic feeling since it expresses the interperennial lack of any further desire. So in between meals, you should not eat. That is called satiety in scientific terms. So what is the hunger switch or switch from satiety to hunger? We have two signals, appetite and satiety. So between these two signals, we have a complex neurohormonal pathways which are being set up. And the main integration is done at hypothalamus at the arcuate nucleus. So signals are coming from the periphery, from the adipose tissue, pancreas, gut. All these signals are integrated, processed, and information about whether to switch off the signal of appetite or to switch off the signal of satiety is decided by the hypothalamus. So the peripheral neurohormones are very, very important for satiety and hunger. We must appreciate the role of adipose tissue, which is secreting a leptin. We know the adipose tissue is a dynamic endocrine organ. It causes satiety. However, the satiety role of leptin is still very controversial, but starvation signals, definitely at low levels, it causes starvation. Gut, we have so many other hormones, cholecystokinin, GLP-1, peptide, YY, oxyntomodulin. They all are hormones which will inhibit the hunger. The stomach secretes ghrelin, which stimulates the hunger. Pancreas have insulin and amylin, which inhibit the hunger. So hypothalamus has both hunger and satiety center. You can appreciate the anatomy of hypothalamus for students. You can see here two nucleuses here, lateral hypothalamus and ventromedial nucleus. The lateral hypothalamus is supposed to be a hunger center, and ventromedial hypothalamic nuclei, there's a satiety center. Abutting the two, there is one very important area, which is arcuate nucleus. This is bathed in the blood because there's no blood-brain barrier, and all the signals are coming to the arcuate nucleus. So whenever somebody has to desire to eat, the satiety signal you can see is stimulated. Somebody eats the food, and then the information is relayed to the feeding center. So the satiety center, and the food intake is inhibited. So this is the way hypothalamus is regulating the eating and the stop signal. The deeper into the arcuate nucleus, you can see two important areas called POMC-CART and NPY AGRP regulate signals. These are pro-opiomelanocortin hormones, and then there's a area, and there's a CART area which is cocaine amphetamine regulated transcript. Then there's an NPY area which is neuropeptide Y and agouti related protein. You can see the signals from leptin, insulin, PYY, and GLP-1. Now, whenever the signal comes, it just doesn't inhibit or stimulate. There are two switches. So when you are switching off one switch, you have to switch on the other one. So this happens very simultaneously. So these two things have to go together to actually give the signals of hunger or satiety. So whenever leptin, insulin, or PYY, GLP-1 are stimulating the anorexic areas, the second order neurons are relayed to the hypothalamus. This is a paraventricular nucleus or lateral hypothalamic nuclei. The melanocortin concentrating hormone is released, and it causes a decreased feeding behavior. You can see whenever there is an orexigenic signal, where there is a patient hungry, ghrelin is released, and ghrelin is going to stimulate this area and cause the increased feeding behavior. So this is how the signals are being relayed to the arcuate nucleus, and then the second order neurons are going to decide about the feeding or the satiety. So there is a short-term regulation of body food intake, or there's a long-term regulation of food intake, depending on the hormones which are coming into play. So we'll just see the short-term regulation is done by the ghrelin hormone, which is a hunger signal, and the long-term, the short-term satiety signal comes from chiefly from the CCK, cholecystokinin. The ghrelin is a very important hormone. Ghrelin causes a lot of hunger. If you have eaten something and your ghrelin levels are actually high, after 1 or 2 hours you start feeling hungry. That is the ghrelin for you. So ghrelin is going to stimulate this area of agouti-related protein NPY, which I told you is going to increase the food intake. And cholecystokinin is going to actually, coming from the peripheral signal, is going to stimulate the other area, which is called POMC-CART area, and which is going to also stop the AGRP and PY area, which is going to reduce the food intake. There is a medium-term regulation by peptide YY, which is released from the colon and which suppresses the interprandial the appetite. So between the two meals, there has to be something which has to suppress the appetite, and this is chiefly this hormone, which is PYY, and the plasma concentration of nutrients which are circulating also will decide to suppress the interprandial appetite suppression. So this is PYY, which is going to stimulate the NPY area and reduce the feeding behavior of the individual. So there are two theories for the regulation of food, but because of the nutrients, these are very old theories, but this theory was proposed long back, maybe 50 years back. The glucostatic theory suggests that the glucose levels ultimately control the feeding and satiety centers, and the long-term theory, which is lipostatic theory, proposes that the level of body fat, which is there, regulates the feeding and satiety centers, and discovery of several peptides, which especially leptin and neuropeptide Y, seems to support this theory. And leptin is a very, very important hormone which plays a role in long-term regulation. The glucose itself is a very, very powerful inhibitor of satiety center. Once you have eaten, the glucose increases, it's going to stop the satiety center, and you're going to stop the eating. The lipostatic theory suggests that the amino acids and lipids are going to also regulate the satiety and hunger center, but the feedback or the stimulus seems to be very, very not very strong. Hence, you will not see that much of satiation which will come to the high leptin levels or so. So that's why this theory is supported by the discovery of leptin. But as I said, the role of leptin as a satiation hormone is still controversial, because if you see the people who have high leptin levels still feel hungry, and that the phenomena of leptin resistance comes to the picture because of this. So when you administer leptin to somebody who has got an issue of eating, it is not able to cover or it's not able to treat that patient. Hence, the hunger signals, the starvation signal of the leptin is proved, but the satiation signal role is still controversial from the leptin point of view. Insulin is a very, very powerful regulator of appetite. We all know that insulin is going to stimulate, along with the glucose, insulin is released, the appetite is going to go down along with the GLP-1, which have the receptors at the POMC and CART areas. So these are the chief hormones which are going to control the appetite. We saw everything. The psychological factors do decide, the cultural factors, the food factors, the practices also decide your appetite. But the most important is the obesogenic environment, the palatability, the change in the texture of the food, the taste also has created a lot of issues, and the appetite has gone for berserk. This has to be charged. So the very important resting metabolic rate is also a driver of appetite, because your lean body mass and resting metabolic rate also send the tonic signals to the appetite centers. Whenever there is a demand, there will be the energy intake. So if you have high resting metabolic rate, you may have a little more appetite. That's what it suggests. So the tonic signals for one's right to eat that reflects the body's demand for energy rises from the free fatty mass or resting metabolic rate. And the drive is under tonic inhibition from leptin, whose action reflects the amount of stored energy reserves in the body. This is a very important statement. Leptin regulates most of this tonic signals for the resting metabolic rate. The drive is to eat potentially interrupted, suppressed by episodic signals in the form of peptides that are released from the GI tract and respond to food consumption. This resulting pattern of eating is consequence of the interaction between tonic and episodic physiological signals. Little complicated, but this is how the resting metabolic rate is going to actually stimulate the appetite center depending on your resting metabolic rate. When your resting metabolic rate goes low, probably the signals will also drop and your desire to eat also drops. So this is a very important driver of appetite. And importance of appetite regulation, the last slide, where when we see that when you have the smooth appetite regulation, there is, when the hypothalamus knows the texture of the food, the taste of the food, it knows everything, and it terminates the food intake when the satiation is reached. But when you change the texture of the food, the palatability of the food, the visual effect of the food, what happens, the reward centers come into play, and they are going to stimulate hypothalamus, which leads to prolongation of food intake. For example, we had an ad called Lay's. No one can eat just one. You keep eating, you keep eating. And that is what the appetite regulation is for you. Because the change in the texture of the food, change in the taste of the food stimulates the hypothalamus and the food of the reward center, and the food gets prolonged. People keep eating the same food. So this is where the appetite regulation goes for necessary. So thank you so much for your patient listening. If you have any questions about appetite regulation, you can definitely ask. Thank you so much.
Thank you. Thank you, Dr. Vimal. It was a very difficult topic, appetite regulation. Dr. Vimal is my colleague and probably the best holistic physician this side of the Apollo Hospital, so he has tried his best to give us a holistic view on how to take care, treat appetite, and give us an insight into appetite regulation. Out of all these complex slides which he showed, I carry only one message. And that message is that hormones really play a very, very important role in regulation of appetite. Right? And for obesity, we are paying so much attention to lifestyle changes and bariatric surgery. We should also, I think, play attention to the pharmacotherapy which can affect the hormones. It should not be neglected. I know we have limited options, but if we have this option, we should basically use pharmacotherapy as early as possible. 3 months, 6 months, lifestyle, then start it. I think we should have a very, very holistic approach in all three to take care of obesity. So, open to question answers. I will be afterwards.
Panel.
Okay. Thank you very much, Dr. Vimal. Can I ask Dr. Dikhil to introduce the next speaker?
Yeah. Thank you, Dr. Vimal. Now I request Dr. Nitin Patankar to just deliver his talk on benefits of weight loss on diabetic and cardiovascular risk factors.
So, at the beginning, I'm going to make a very bold statement that up till now, Dr. Sanjay Khare and Dr. Vimal Pahuja has given you a lot of new information, and the speaker after me, Dr. Godbole, is going to give futuristic information about obesity. But my topic is extremely simple. Everybody knows everything. So please be very attentive, because this is the lecture which will promote a lot of questions for panel discussion. Everybody must have practiced what I'm going to speak. So go back, relax, and find out all the lacunae that you found out in your practice, and keep your questions ready, because these experts are going to answer your questions. With this, I'm going to begin my lecture. So, which obesity-related complications do encounter most commonly in patients with obesity? So, greater the risk of developing type 2 diabetes with higher body mass index. Again, as I said, everything is known to everyone, but as the BMI goes beyond 35, you look at the risk of developing complications or type 2 diabetes, it is almost 100%. So, once you develop obesity, beyond that range, type 2 diabetes is inevitable. Similarly, additive risk of type 2 diabetes with obesity and pre-diabetes. So as they say that sometimes 1 plus 1 doesn't become 2, it can become 11. Similarly, when you have just diabetes and pre-diabetes, obesity and pre-diabetes will develop diabetes 17.4 times more commonly than when you have pure obesity or pure pre-diabetes. So that's the multiplicative effect. Thirdly, obesity, pre-diabetes and type 2 diabetes are diseases in continuum. Now, this is how the graph shows. When before the diagnosis, around 4 years before the diagnosis, this is the graph that presents. So these are the post-glucose, fasting glucose, insulin sensitivity. They are almost running parallel. The moment we approach near the diagnosis of diabetes, these start diverging. The type 2 postprandial glucose level starts increasing. Fasting is still as previously. The insulin sensitivity starts going down, and beta cell function initially it may be increased because of overfunctioning. And then when we reach the diagnosis, this is the picture that we get, that the postprandial glucose is very high, fasting glucose is high, insulin sensitivity is down, and beta cell function, as they teach us, that it's 50% down or even more. So obesity is a major determinant for residual CV risk in atherosclerosis. Now, these are the non-modifiable risk factors, which if you have, you cannot do anything, but these are the modifiable risk factors: high blood pressure, high blood lipids, smoking, physical activity, and to all of them add obesity. And this will cause increase in blood pressure, increase in blood glucose, insulin resistance, rise in blood lipids, and this is the most common thing, which is usually common people don't know, that there is inflammation increases, and which leads to atherosclerosis because of endothelial dysfunction, adhesion molecules expression, foam cell formation, and smooth muscle proliferation. Then we have thrombosis, MI, stroke, or PAD. So the link between obesity and CVD, the word continuum is used very commonly. So all these metabolic disorders are in continuum. So when we have obesity, we have adipocyte TG turnover and lipolysis are reduced, and that's why we have reduced lipid turnover. Then we have got adiposity and inflammation, and that's where the whole pathophysiology is said that obese cells are not just inert cells, or they are not cushions, but they are very actively taking part in chemical processes, and they secrete a lot of inflammatory substances like IL-6, TNF-alpha. Then it goes to formation of atherosclerosis, which leads to cardiovascular disease. So this is one continuum. Then the risk of CV events increases with increasing BMI. Again, this for men and women. Dr. Sanjay mentioned that women get more obesity in India, but this is again an international data, and we have seen that hazard ratio about developing obesity when we are following it for long years, the starting BMI, or when we have severe obesity, the chances of developing heart disease are much more. Then systemic inflammation, increased risk of cardiovascular disease and type 2 diabetes. So starting from lean adipocytes to hypertrophic adipocytes. And I had one lecture heard from someone that they were saying that there are some people who have got elastic adipocytes. So this is not a standard term, but they say that these people just develop hypertrophy, but they don't participate into chemical reactions. But usually that is not seen in India. Whenever we have a hypertrophic obesity, we have a lot of inflammatory markers which are secreted. And then we have this systemic inflammation, which is the main cause for all these problems: endothelium, liver, muscle, and kidneys or pancreas. Insulin secretion goes down, and that's why we get CVD and type 2 diabetes. So triad of obesity, type 2 diabetes, and cardiovascular disease. Again, as we see that obesity and CVD are linked, type 2 diabetes and CVD are linked, and obesity and type 2 diabetes are linked. So type 2 diabetes and CVD, they are risk factors. Again, the same thing. These are risk factors for one another, and they keep on promoting one another. This is in India called as Sankrantiचं हळदी कुंकू. एकमेकांना वाटत राहतात आणि अल्टिमेटली यू गेट एव्हरीथिंग टुगेदर. संक्रांतीचं वाण म्हणता येईल याला. So effects of GLP-1. So we are now talking about GLP-1 receptor analogs and semaglutide have a CV and metabolic effects. So effects of GLP-1 and GLP-1 receptor agonist. So what we have is increase in satiety, increase in fullness, decrease in hunger, decrease in prospective food consumption, and decrease in energy intake. What Dr. Vimal was talking about, appetite, hunger, everywhere these GLP-1 receptor analogs work. Then we have got cardiovascular benefits, decrease in systolic blood pressure, decrease in lipids, decrease in inflammation, decrease in atherosclerosis, and MACE, all those 4-point, 3-point MACE, the values are reduced. Then we have got a good glucose regulation by increased insulin secretion and decreasing glucagon secretion, and gastric effects are decreased gastric acid and decreased gastric emptying. So semaglutide, that is a GLP-1 receptor agonist, has 94% homology to human GLP-1, then reduced in body weight and improved glucose metabolism and lipid profile, has an anti-inflammatory and anti-atherosclerotic effects. Almost all the risk factors that we were talking about, this molecule works on all of them and associated with CV benefits and type 2 diabetes. So GLP-1 receptor analogs harness the effects of GLP-1 for the therapeutic use. Now we will talk about only these two things. We have got oral tablets of semaglutide in 3, 7, 14 milligrams, oral daily dose, and we have got SC injections of liraglutide. But these are the things which are not approved for weight management, but these are approved for type 2 diabetes, but these two are available in India. So focus for this session is on oral tablets of semaglutide. So oral semaglutide evidence. So Pioneer 1 study, this is the changes in HbA1c. Obviously, this is placebo and 3, 7, 14 milligrams of semaglutide orally, and this is a change that can occur. Oral semaglutide evidence, again Pioneer 1, change in body weight. Again you see placebo 3, 7 and 14 milligram, there is a decrease in body weight. Oral semaglutide evidence about systolic blood pressure, and with monotherapy for 26 weeks with empagliflozin versus empagliflozin at 52 weeks, and we will find a lot of benefits. Now here again the question will be answered by the expert panel that when we are giving 14 milligrams at 26 weeks, why there is a slight less amount of benefit. Oral semaglutide evidence, again it is for total cholesterol, LDL cholesterol, triglycerides and HDL cholesterol. So GLP-1 receptor analog harness the effects of GLP-1 for the therapeutic use. Again, as I have shown, the oral tablet. Okay, injection semaglutide 2.4 milligram, improvement in body weight. Again, weight management with intensive behavioral therapy, sustained weight management and weight management in type 2 diabetes. We get benefits across all the sections, and at 68 weeks, the benefits still remain, because we usually see any intervention, the benefits will last for 3 to 6 months, and then again it comes back. But this remains for 68 weeks. Again, injection semaglutide 2.5 milligrams, improvement in cardiovascular risk factors. Again, waist circumference going down, systolic blood pressure going down, diastolic blood pressure going down, and C-reactive protein going down. Again, the same thing, HbA1c, fasting plasma glucose, fasting serum insulin and triglycerides. Everywhere you will see a lot of benefits, while placebo treatment will have a reverse effect. So GLP-1 receptor CVOT revealed beneficial CV effects in persons with obesity or persons with diabetes, the MACE, CV death, all-cause mortality, fatal or non-fatal MI, then heart failure and renal endpoints. Everywhere the GLP-1 receptor analogs have shown multiple benefits. So now what are unmet CV needs in obesity? CVD is a leading cause of death worldwide. Obesity is an important risk factor for CVD. Despite contemporary evidence-based therapies, people with obesity remain an increased risk of events, and that's why BAPI has been formed, that what we can do. And as Indians are known to have more diabetes, more cardiovascular risk, so we are looking at these kind of molecules and many others which we'll be talking later. So weight loss improves CV risk, improves blood glucose control and diabetes, reduces interference of long-term CV mortality. But in obese, so far, the evidence has been very inconclusive, and that is the unmet need for therapies to prevent CV risk with obesity. So effects and MOA of semaglutide, appetite regulation and weight loss, and metabolic and CV benefits. So these are the things, as I said, everyone knows everything about this. So you think what happens in your practice, there may be small things that are lingering in your mind, And this is the best place and best people available to ask all those questions. Thank you.
Thank you very much, Dr. Nitin. Dr. Nitin is a crusader, for nutrition and obesity in Thane. And I think one of the most initial person who took up obesity as a disease process. And I think the next, Dr. Godbole is there? Yeah. So the next presentation is by Dr. Shriram Godbole. He is going to talk on redefining obesity care. Dr. Godbole.
Thank you, Dr. Bandukwala, and thank you, BAPI, for this opportunity. I think much of the discussion on obesity management revolves around lifestyle modification. And I think so long as we continue to do that, we are doomed to fail. This is like saying that I will treat diabetes, I will treat cardiovascular disease simply by lifestyle modification. It's impossible. We need to understand that obesity is not the choice of the individual concerned. It's a chronic disease. It's a disease which has a very complex pathophysiology, including genetic, environmental, metabolic, lifestyle, and behavioral factors. And therefore, if we only were to concentrate on lifestyle modification, we will never succeed in our fight against obesity. And therefore, please realize, just like most people with diabetes need pharmacotherapy, obesity is also a chronic disease, and most obese patients actually merit pharmacotherapy. The problem was that till very recently, there were no very safe, effective agents for the treatment of obesity, but I think that picture has changed and continues to change. So why do people living with obesity need pharmacotherapy? The first thing is, of course, obesity is a chronic disease, it's a progressive disease, it's a relapsing disease. It's a disease that's essentially centered in the brain. It's influenced by a complex interaction between the genes that you have inherited and the environment that you're living in. People have said it's a global pandemic. It has a severe impact on mortality and morbidity. But the important thing is, everyone or every obese individual doesn't have to really go on to an ideal weight, to negate that morbidity. Even if you lose about 10 to 15% of your current weight and maintain it, very important, then I think a lot of morbidity or mortality can be avoided. Problem is, lifestyle modification does not reduce weight by 10 to 15%. And all the previously available medications also at best would reduce your weight by 5 to 8%. None would reduce it by 15% plus. But now things are changing. So weight loss is always difficult to achieve. It's even more difficult, or I would say it's impossible to maintain. And why is that so? Because the body is designed to gain weight. The body is designed to prevent weight loss. The brain is geared so as to put on weight. And so when a person starts dieting, lifestyle modification, and tries to lose weight, what happens? The body undergoes a metabolic adaptation, what is called adaptive thermogenesis, wherein the resting metabolic rate actually slows down. The calorie expenditure actually reduces, and over a period of time, certain hormones which were mentioned in the previous lecture, which are important for hunger, like ghrelin, actually increase as the person continues to diet, and actually satiety-producing hormones like insulin, GLP-1, leptin, CCK, peptide, YY, etc., actually start decreasing, which is why a person hits a plateau, and very often there's a tug of war between the person and the body ultimately wins, and you go back to the weight that you started from. That's the whole frustrating aspect about therapy, and therefore pharmacotherapies, which cause sustained, effective weight loss and which are at the same time safe. You remember sibutramine and lorcaserin fell down on the wayside because they were not safe. So you need safe, effective, sustainable therapies
in order to effectively counter obesity. And currently, these are the pharmacological options which are available for weight management. You have, in India, what is approved currently is Orlistat. That is the only thing that works by a different mechanism, that's energy wastage. And in my view, it's money wastage as well, if you ask me. Taking Orlistat, it's not just the fat that goes down the drain, but I think a lot of your money also goes down the drain, literally speaking. Okay? So what is available in India? What is received approval actually, but not available, is semaglutide 2.4 milligrams. And the reason why it's not available is that the worldwide demand is so huge that the company cannot keep pace with the manufacture of semaglutide. If you have listened to the recent Oscars, there was a comment which the lady made that so many in the audience are looking thin and trim and fit. Are you on Ozempic? Is what she asked, okay? Ozempic is nothing but semaglutide 2.4 milligram, approved in India, not available because you simply can't keep pace with the demand that is there globally. So these two things are available. This, according to me, is a pretty waste of money. This is available, approved but not available. Liraglutide 1.2, 1.8 is available, but it's not licensed for obesity. What's licensed is 3 milligrams, but it's not approved, okay, in India. And then these two agents, again, are not approved. So, frankly speaking, you only have Orlistat, which is available. And to tell you the truth, I used liraglutide also off-label, okay? But I also use oral semaglutide off-label for obesity because for want of anything better. But maybe within a year's time, we'll get semaglutide. So semaglutide is basically the backbone, is the native GLP-1, and you make certain modifications to prevent degradation by DPP4 enzyme and to see that the spacer, you require it to join that native GLP-1 to an albumin to reduce the clearance and so that it continues to work. With the result is that the half-life is about 1 week, and therefore you can inject this once a week. Okay, it's a weekly injection, and now we are used to weekly injections. And then, as was mentioned, it acts at the center. It acts on the brain. It acts on the centers in the brain which are to do with appetite and satiety. So it acts on the hypothalamus and the hindbrain, the area postrema and the nucleus tractus solitarius. And the end result is that there's a reduction in the energy intake, a reduction in the appetite, and particularly there's an aversion for carbohydrate-rich and fat-rich foods, actually. So you go for less carbohydrate and less fatty foods when you start taking semaglutide, and there are a lot of pleiotropic, metabolic, cardiovascular effects, and of course, end result, of course, is body weight reduction. Now, what's the difference between semaglutide and liraglutide? So when you inject a radio-labeled semaglutide, where does it go into the brain? Like liraglutide, it is expressed in those parts of the brain which have a GLP-1 receptor. So you will have it expressed in the hypothalamus and the hindbrain, okay, just like liraglutide. But unlike liraglutide, semaglutide also concentrates in those regions of the brain which actually do not have a GLP-1 receptor, such as all these areas, the central nucleus of the amygdala, the parabrachial nucleus. They don't have GLP-1 receptors, but semaglutide is expressed there when you inject radio-labeled semaglutide. And these pathways are actually important for stopping your meal once you feel satiated. You know, that signal of stopping, that comes through those pathways where the GLP-1 receptors are not expressed. Now, semaglutide 2.4 milligram, this is a trial, a phase 1 study, which was done in about 40 patients over 20 weeks versus placebo. And then they also looked at various aspects. They had questionnaires and they had various, scores to sort of score your appetite. So with semaglutide 2.4 milligrams, your hunger reduces, your prospective food consumption, your desire, your craving for savory foods, your desire for sweet foods goes down, and the person starts feeling satiated and full and wouldn't like to eat more. So this is what happens to the energy intake. You can see that the energy intake is reduced by about 40% at the end of 20 weeks, and the change in body weight at the end of week 20 is a very impressive, exceeding 10 kilos of weight. So there's a 35% or a 40% lower overall mean intake, energy intake with once a weekly semaglutide 2.4 milligram, and the body weight, as I said, decreased by 10.5 kgs. Now, you have different formulations of semaglutide. What's available in India, of course, is oral semaglutide, okay, 7, 3, 7, and 14. But there are studies with oral semaglutide, 25 milligrams. I don't know how it will be easy to tolerate that. So this is what's available in India. Injection semaglutide, 1 milligram for diabetes, not available in India. So what's being studied for obesity and probably will be launched very soon, hopefully, is 2.4 milligram once a week for obesity, okay? Now, this underwent a whole series of drug development program that is called as a STEP program. And there are several STEP programs, but the important ones are the STEP 1 to 5 programs. And especially in the first STEP 1, 3, and 4 trials, 50% of patients with obesity achieve a weight loss of more than 15% from the baseline, which is something unheard of with the prior pharmacotherapy. So this is a very comprehensive STEP program. I'm not going to go into. The program includes studies which are only devoted to people with diabetes, people just with obesity, without diabetes, people with or without cardiovascular disease, regional studies, studies in certain continents like China and Hong Kong and Taiwan and so on. So what happens in STEP studies? Now this study, the STEP 4 actually is, what they did was all patients were put on semaglutide for the first 20 weeks. And after that, of course, you got weight loss. But then patients were randomized to either continue the semaglutide from week 20 to week 68 or to go on to a placebo. So right from 0 to 68 weeks, you got a 17.4% of reduction in the body weight. And when the patients continued on semaglutide, okay, after week 20, they had a further reduction of approximately 8%. But when you stopped it and went to the placebo, then you got a weight gain. Very often people ask, how long should I continue this medicine? Can I stop it once I reduce the weight? I'm telling you, what a silly question, actually. Of course, there are no silly questions. There are only silly answers. How can you expect a drug to act when you stop it? It's as simple as that. If you want the drug to act, you have to continue to take it. You can't hope to stop the medicine and expect the drug to act. No drug does that except possibly vaccines, okay? So no other drug does that. You have to continue the drug if you want its effect. So this is the sort of weight loss that you get with 15%, 17% weight loss that you get with injectable semaglutide. So this was the STEP 2 trial, STEP 5 trial, where actually the drug was continued for 2 years. And what you got at the end, about minus 17.5% weight loss at the end of 2 years. So the important thing is it should continue to work, not just stop working at the end of 6 months or 1 year, and then you get a sort of a hockey stick-like, figure. It's not like that. And of course, there are a whole lot of other effects. This weight loss that you get is actually central weight loss. So there's a reduction in the waist circumference, and you don't lose lean mass, okay? You lose fat mass. Of course, there's an improvement in glucose metabolism. Essentially, semaglutide is an anti-diabetic drug and a lot of pleiotropic effect on the cardiovascular risk factors. Safety profile, yes, you would expect, like nausea, diarrhea, which according to me, there's no treatment for diarrhea related to GLP-1 receptor agonists. Vomiting, constipation, most of these things, at least in the studies, are pretty transient early on. You have to counsel the patient beforehand, and usually they disappear with the passage of time. But I have my reservation about that. How many people will tolerate that dose of 2.4 milligram in India remains to be seen. Now you have other things in the pipeline. You can also combine semaglutide 2.4 milligram with an amylin analog called cagrilintide, and you can combine the two. So that is called CagriSema, and there are type 2 studies going on with CagriSema, and the combination of cagrilintide and semaglutide actually seems to do better, as you can see in the study. This is CagriSema, this is semaglutide, and this is cagrilintide. So if you combine the two, the baseline A1C reduction and the weight reduction is better with the combination than with the individual drugs taken singly. And this is a very exciting molecule, not just a GLP-1 receptor agonist. Now you have a dual GIP GLP-1 receptor agonist in the form of tirzepatide. God knows when it will come. It's approved in US for diabetes, and fast track approval is expected in the next 1.5 or 2 years for weight. Okay, I think this is also going to be a blockbuster like Ozempic. And Of course, it induces the glucose-dependent insulin secretion through both the mechanisms, and because of the GIP-1 agonism, possibly nausea is reduced with this particular molecule. And with this 72-week trial, this is called SURMOUNT trials in obesity, you get, if you have a 5 milligram and a 10 milligram dose, then you find that in the 15 milligram treatment arm, the difference is 20% weight loss, okay, 20% weight loss. And the mean weight reduction is, in an absolute value, is 24 kgs at 72 weeks. So to summarize, you just cannot do with lifestyle modification. It's just beating up the wrong bush, if you say. So you need pharmacotherapies that combine the weight loss efficacy, the long-term safety, weight loss maintenance, and reduce complications, which are so very important in obesity care. And GLP-1 receptors, excellent clinical evidence as anti-obesity medicines to fulfill the current unmet needs. And the latest anti-obesity medication in our treatment armamentarium is semaglutide, with an evidence of up to 17% weight reduction from all the STEP trials. Thank you so much for your patient listening. Thank you.
Thank you very much, Dr. Godbole, for an apt finale to this particular session. It's very heartening to know that so many pharmacological agents are available to us for obesity and weight control, and hopefully one day it will replace surgery as a mainstay management of obesity. So we conclude, both of us conclude this particular session and ask Dr. Vimal Pahuja to take over for discussion on obesity management.
Next is the panel discussion. The moderator will be Dr. Vimal Pahuja, sir. So now I invite Dr. Vimal, sir.
So, may I have all the speakers of the previous session, Dr. Nitin Patankar, Dr. Srirang Godbole, Dr. Sanjay Khare. Where is he? Dr. Sanjay Khare? Where is he?
You want to sit?
No, no. I'll stand, no problem.
Who else is here?
Dr. Sanjay.
Sanjay is gone out.
We have one mic on this one, I think. So, after this session, any audience questions or anybody has any questions? Ketan has, Dr. Ketan Pakle. Yes, one mic is there.
So, yeah, it's working. Thanks. So, sir, we have many patients across for the obesity, but what all things and what arguments needs to happen between a patient and a doctor to convince that obesity is actually a disease and it needs to be treated here? It's better that the experts give the answer for this, so it will be very easy for us to deal with the patients then.
So I think the first important thing is to make the person and his family members realize that obesity is something which the person has got not out of what he has done or not done. It's not the person's fault necessarily. Many times there is a lot of shaming of the individual, even by family members and friends. I think that should stop. Obesity is a disease. It's not the person whom you blame. Just like you don't blame the diabetic person for his diabetes, you don't blame the hypertensive patient for his hypertension, you can't blame an obese person for his obesity. There are a lot of complex factors that are involved, and this is something that I think needs to be explained to the patient and the family members. Very often I find in a family, if there are 3 or 4 children and one of them is obese, the child who is obese is made a target. He's constantly hounded. The entire discussion of the family centers only around the obesity of that particular child, made to feel like a victim, and that actually has a negative impact on the child's psychology, and in fact the person will continue to then eat and stop doing what he was probably trying to do. So I think it's very important to explain the nature of obesity and the complexity of the obesity, and avoid using terms which are demeaning and to have empathy for the patient. And this, I think, needs to be taught right from medical schools. We need to tell our medical students to use respectful language and to be empathetic when you deal with patients with obesity. And then you have to tell them the limitations of what to expect from a given lifestyle modification, how much to expect. People say, I want to lose 10 kgs, 15 kgs, that sort of a thing. So you first ask them their expectation. They'll probably give you a whole figure. So when they give you a whole figure, my policy is don't give me whole figures. We talk in terms of percentage. So talk in terms of percentage. And then when they find that what they have been expecting is unrealistic, so your expectations have to be realistic, and you have to explain to them, you don't need to go back to your ideal weight, to negate the negative impact of obesity. Lose 5%. Give figures or give targets that are achievable and which can be maintained. 5% is something which is maybe achievable after a lot of effort, but it's probably very difficult even to maintain 5% weight loss with the best of efforts. So if it is their expectation is more than 5%, then you tell them no, you have to know what to expect from each sort of therapy that you are planning, like lifestyle modification or pharmacotherapy or bariatric surgery or whatever it is. So tell them about the expectation and what realistic expectations they should have. I think that's the way to, some of the ways.
Yeah, Ketan, I would like to add one more point to this. When I was doing the psychology courses, they were mentioning that when you talk of health, the health cannot be a goal. That is a very paradoxical statement. But if you have a larger goals in life, where health is really beneficial, then there are chances that people attaining health are much better. The same principle applies to obesity, which I practice. That if you lose 5%, 10% weight, whatever weight loss you achieve, what you are going to do with that weight? If that weight, maintaining that weight is going to give you some larger goal or pleasure or something, then that goal becomes attainable and maintainable. So when the discussion happens with the patients and relatives, this point has to be focused, that how you are going to use that lower weight to further your life. So that is a different perspective of how to discuss with patients.
Yeah, from where Dr. Godbole spoke, I just want to take off from there. You said that body shaming and all of that is there a lot. But now we find that there is a new brigade that has come out, which is actually glorifying weight. There is this, that be in love with your body. And there are a lot of influencers on Insta and all the social media that keep on saying that it's love your body, it's okay if you're fat. And those kind of things. So that is actually, body shaming is one end of the spectrum, but glorifying weight, that is the other end of the spectrum. To that end, I would actually, I don't know how many of you have seen this movie called Double XL. I was actually quite horrified looking at that movie because it glorifies eating to such a large extent that that's okay. You are what you are and those kind of things. So how do you draw the balance?
So according to me, glorification of obesity is a reaction to body shaming, because people who are at the receiving end of body shaming now say,
absolutely,
go heck, BOLS to you. I'm going to remain what I am. This is because they have been shamed constantly and probably discriminated against.
Yes.
And therefore, that's a reaction to that. So obviously, you have to have a balanced view. And therefore, I believe if you spread the science of obesity in a manner that is comprehensible to the lay public, educate the common public, medical students, doctors, paramedical people also, and social media, so many of jokes on fat people. I mean, fat jokes are not funny. So you have to stand up wherever you find there is discrimination or shaming of people, because that causes the reaction of glorification of obesity, which is of course not to be done.
So another very important thing, Oscar Wilde had said, there's a difference between knowing a thing and realizing it. So Ketan, the question you asked was straightforward. A person who comes to me who's overweight, he knows that he's not in the pink of health. He knows he's overweight. So what my job is to basically gently take him by the lapels and show him, look boss, this is where you are at this point of time, this is where the statistics are, this is your genetic tree, these are the diseases you already have, and these are the problems you are likely to land up into. Be factual with that person, show him the pros and the cons, motivate that person to losing weight, use medications wherever possible, whenever possible, lifestyle modification. But I feel that's most important. That is the road. But first is make that person aware that these are the statistics and these are the possibilities. And my experience, most people are logical and they are rational, so they are going to understand and they are probably going to comply. And as Sridhar said, it's a hell of a job to get rid of even a single kilo, forget about 5% or 10%. And even it's more of a chore to keep that weight loss off. Regaining the past weight is very, very, very easy so just matter of interest for all the audience. There used to be this program, Biggest Losers in America. So they used to catch people who weighed like 250, 300 kilograms and all that and subject them to some 8 months of grueling weight loss. And that used to be televised. And the person who lost maximum amount of weight was given thousands of dollars. So people used to line up for that, people used to win. But वापस क्या हुआ? A depressingly large, significant percentage of those people put on weight again. In fact, almost something like 85 to 90% people put on weight again. Because that is the nature of this disease. So that perspective has to be understood.
So very relevant points given by our speakers. Very importantly, that we have a new organization, upcoming organization. So there's a question? Yeah. Okay.
Hello. Yeah. Thank you so much for the excellent lecture. So in one of the presentation, you said that after a certain point of time, there would be a plateau because there would be upsurge of the hormones. And then again, since the body is made that way that you regain weight, how do we deal with that problem? When that plateau has reached, what do we do at that point of time?
Pharmacotherapy. I mean, that's the thing. I mean,
No, so pharmacotherapy is already on. Patient is on diet and exercise.
even with pharmacotherapy, you will reach a plateau.
Right.
With everything, you will reach a plateau. You just cannot have the body continuing to lose weight, indefinitely. That never happens. Not expected to happen. Don't expect it to happen. So the plateau will come much earlier with lifestyle modification. It will come later with pharmacotherapy. It will probably come little later with bariatric surgery. But somewhere, as you know, even with bariatric surgery, you can still gain a little weight. So people tell me, when I tell them about bariatric surgery, oh, but so-and-so gained weight, So I tell them, if he lost 30 kgs and he gained 5 kgs, what would you say? Would you still say he gained weight or would you say he lost weight, So you have to keep things in perspective. Everything has a plateau.
So the technical answer for your question is it's called shouldering. It's a known fact. Whenever you achieve a weight loss, the weight loss comes down. It doesn't keep on going down. That's not how its science works. There is a shouldering. So after about 6 weeks of a precipitous drop of weight, there is a shouldering. You're going to get stuck on this weight for about 3, 4, 5 weeks. Be at it. Don't give up. The body readjusts and again there's a little drop. Again there's going to be a shouldering. So the weight loss is not like this. It's going to be like this. The shouldering effect. So just be after the patient. Don't lose hope. Be perseverant. There will be a continuous weight loss. But that shouldering effect is known. That is how the body copes up. It's called thermogenesis. And there's a huge lot of evolutionary science which for some reason the body fights weight loss by making more fat. It's an interplay between leptin and all other sort of chemicals. That's how environment is rigged.
There's one more point I'd like to add, that when you're trying to treat the patient, you're not trying to treat the weight. We are trying to treat the obesity as a disease. Whatever weight the patient has lost, he has to just to maintain it. Pharmacotherapy will help the patient to maintain along with lifestyle changes. So we have to keep in mind that we are not treating the weight. This weight should keep going down. Even if you lost 15%, 10% of your weight, just keep that weight loss there so that you will be free of the diseases. That's what we are dealing with here. Yeah. The perspective.
The weight loss that has been shown in either the pioneer or the step trials, etc., is it only amongst responders, or is it also taking into account the responders? And what is the percentage of non-responders?
So this is the mean body weight that is seen, weight loss reduction is seen, which I showed the data, is for the mean. Of course, there would be non-responders. So I would say the level of non-responders would be lesser and lesser as you use 2.4 milligrams of cagrisema or tirzepatide. The non-responders are really few, less than 5%, or maybe just 2%, that's all. Everyone would possibly lose some weight or the other. For example, in one of the studies, the SURMOUNT studies with tirzepatide, 25% lost weight akin to bariatric surgery. Now, everyone is not going to lose that. So you will have maybe 5% of people who will respond lesser than what most people would, which is to be expected because we are not machines. We are humans. So humans have their varieties, so everyone is going to respond differently. So that you always should caution your patient. You might be one of the non-responders. I don't know. This is what happens to most people. If you tell them, then they won't have unrealistic expectations. And one of the things which I want to point out, when we talk of complications of obesity, we think of cardiovascular, we think of diabetes. To my mind, the most common complication of obesity is depression. Virtually every person with obesity, to some extent, would be depressed, either about their weight, or maybe they crave for food secondarily to depression. Depression very often, stimulates craving. And I find most people, not just with obesity, but even with diabetes, are actually chronically depressed if you ask them. So that is something which physicians, we are not accustomed to psychological evaluation of a patient, but we should learn that. And I think we should practice that to the extent that is possible.
That's very rightly said, sir. And we know the practical patients. I have a patient who has got husband body shaming the wife. Wife is on depressive medications, 3-4 medications, still not getting out of this. So this is a very common practice which we see. Dr. Nitin wants to add something.
One question about Dr. Neeta, and the doctor asked the question that once you go into a plateau, the focus should be on body composition change. So you can keep still losing body fat and can gain muscle mass or bone mass. So for which different programs are available. And secondly, as Dr. Godbole was saying, that depression and abdominal girth are interlinked. So if you are depressed, your abdominal girth increases, and if you try to control your abdominal girth, even depression goes down. So it is said that if you lose 1 kg and 1 centimeter of abdominal girth, the chances of getting depression is much lesser. So we should be focusing on transverse abdominis and oblique muscles when we are planning an exercise prescription for obesity, and that can tackle the problem of early plateau.
Yeah, so thank you so much for this lucid answers. I just wanted to bring
Archana and Pradeep have
have a question.
Wanted to know if I become a member of a BAPI, whether will we get a regular update of the recent advances in the management of the obesity?
You are supposed to answer.
No, first is actually basically I wanted about the antidepressant drug or any anti-psychological, because they causes the weight gain. So if the person, if we put on some antidepressant because of the person is having the comorbidities, so whether we should...
so Archana, I would prefer to answer the second question first for selfish reasons. So yes, please become members of BAPI. You are going to get all the possible updates and all the possible breakthroughs. Please don't worry about it. Now, very unfortunately, most psychoactive medications are going to put on weight. Most of them. As far as depression is concerned, you talk about tricyclic antidepressants, huge amounts of weight gain. All the anti-psychiatric medications, they are going to put on. Escitalopram, yes. Your anti-anxiety, sertraline, all of these, in fact, even common sedatives are going to put on weight. So it's a no-go situation. Pharmacotherapy for weight loss is not really indicated at this point of time. But having said that, let me tell you one thing, and my practical experience from this side of the table. A person lose even, say, 2 to 3% of body weight. The waistline goes down, the spring in the walk improves, the confidence improves. This guy starts getting accolades from the society, tu patla dikh raha hai. That is the biggest antidepressant ever known to mankind. Let me tell you, once people get that positive feedback, they are so stimulated into giving it their best. So my experience, once they start on this particular positive note, they always start getting better and better and better. So if you are asking about pharmacotherapy in obesity, answer is a big no, not indicated, not been recommended by any society. But this itself works as a shot in the arm.
I will just extend this answer. Practically what we do when we have a patient who is depressed and on medications, we liaise with the psychiatrist. And there are some drugs which will cause more weight gain. There are some drugs which cause less weight gain. And there are some drugs which are neutral. We try to do the most drugs which are neutral for the patient. So that's how we try to cut off that weight. Like suppose antipsychotic drugs, aripiprazole is a weight neutral drug or doesn't cause weight gain. So we try to see that whether we can balance the depression with the drugs which will not cause weight gain. This is a practical thing which we do. Liaise with the psychiatrist, speak to them on the phone and tell them whether we can do this. Yeah.
So I also believe it's not just about drugs. So if you interview the family members, you will realize very often that much of the family discussion at dinner time or at other times centers around the weight of a particular individual. So especially when it's an adolescent or a child who's obese, I tell their parents to stop discussion about obesity. Just stop it there and don't shame the child. So when that happens, I've seen children crying before me because that is what was happening in their families. And when their parents realize that, they stop doing that and actually constructively try to help the child lose the weight or the adolescent to lose weight. That itself, is a big antidepressant.
Sir, one question from
can I
some. Before,
ask one question? Sanjay, you said abdominal obesity is bad. Now, is it weight loss in kgs more important or in inches? And is there any treatment modality which differs in that, whether weight loss?
Yeah, thanks, Subhash. I was waiting for somebody to ask me that. So the first thing, inch loss and weight loss are intricately associated with each other. Whenever you have one, there is going to be the other. There's no doubt about it. As Srirang said, the minute, or I think Nitin said, even if there is a cessation or a plateau or a shouldering of weight, if the person keeps losing around the waist, I am ever so happy. Even an inch loss is as important or as rewarding as a weight loss. Now, I have seen a lot of idiots prescribe or say we have those weight loss massage machines, and this is not a joke. I've seen it. I've come people to me with burns. They go to some quacks over there, and those massage things are pressed upon the abdomen and on the thighs, and they are told that after 6 or 7 sessions that liquid patla ho jayega, charbi nikal jayega, you're going to lose weight. It is so stupid. It never happens. You want to lose weight over the abdomen, it is a function or a ratio of a generalized weight loss. Localized weight loss is not known, it's not going to happen, excepting probably plastic surgery.
I would like to answer this in a different way, because usually the abdominal exercises which are done, they are involving rectus abdominis. And rectus abdominis, it becomes stronger, then it is attached to zipisternum and pubis. And it becomes stronger, your abdominal size actually increases. And you have to combine exercises with transverse abdominis and obliquus, then the rectus is flattened. And there are studies which are going on which work on topology of abdomen. Topology of abdomen means how the abdominal points are related. And if the abdomen starts becoming flatter, all the plexuses, nerve plexuses and blood plexuses, their direction changes, the blood flow to the organ changes, and that can give benefits. So when we are losing weight, exercise prescription is the most important thing along with diet and pharmacotherapy. And if we attain that, then your question is rightly addressed.
Thank you, sir. My next question to you, sir, regarding diabetes. Diabetes and obesity very closely related. So natural history of diabetes, if you'll see, there is always 10 years before diabetes or pre-diabetes, there is weight gain which has started. So is there all obesity or weight gain, or they are precursor of the diabetes?
Yeah, so very often it's the case of common soil where the risk of diabetes actually starts several decades probably before it's actually diagnosed or picked up. And much of it in the initial stages, when insulin secretion is probably even more than what is there in the normal person, is to overcome that insulin resistance as a result of weight gain. Yes, so you can have several years of weight gain. The body is trying to overcome that resistance by secreting more insulin. Then there's a tipping point when the body can secrete no more. And that is the time you will find that there's diabetes. So that's the classical explanation. Though, of course, Indians are also known to have low insulin secretion from the beginning. So it's a very complex thing, diabetes. But yes, what you say is correct. Diabetes diagnosis is very often preceded by years of weight gain. And then the person finally is picked up as a diabetic.
Thank you, sir.
Another answer to this is, there is, when you look at the Roy Taylor's twin cycle hypothesis, he is mentioning about fat threshold of liver. So beyond a certain limit, when the fat starts accumulating in liver, there is a sudden rise in SGOT, SGPT, and that is the precursor for developing early diabetes. So if you keep on looking at these 4 scores, SGOT, SGPT levels, platelet counts, and fatty liver. If you can keep that in check, you can, I won't say prevent diabetes, but you can delay the onset of diabetes and maybe changing the metabolic profile of that patient. So that can be one of the lookouts for us when a person starts gaining weight. So even if he gains weight and his liver is kept clean, then the chances of developing diabetes may be little lesser.
There's one more thing. Once the person gets diabetes and his sugars go sky high, he will lose weight, okay, because of the high sugars. And when you bring down the high sugars to normal, he will again gain weight. So people say, no, I'm used to that weight. I want that weight to happen. So you have to explain the difference between healthy weight loss and unhealthy weight loss. This also happens in Graves' disease of the thyroid. When thyrotoxic patients lose weight, and when I start treating them, they say, oh no, doctor, I'm putting on weight. I don't want to do that. I want to go back to the weight I was. But that was the time when they were thyrotoxic. So you have to explain the difference between healthy weight loss and unhealthy weight loss as well.
First of all, thank you so much. First of all, thank you so much for initiating this such a wonderful movement against obesity. I am a GP. Basically, we GP witness lot many patients growing in their weight. And once they reaches to the stage of obesity, then we are helpless. So I request BAPI people to initiate a thought process into the general practitioners network, which are the first contact person with the any patient. Secondly, just sir said that we should emphasize into the weight loss and healthy weight loss, because social media is creating such a big bawal in the field of diet. Suddenly person realizes that I want to lose the diet and he stops eating the one meal and he is happy in losing the 5 kg weight in a month, but he is not understanding where he is getting the nutritionally deficient. So such kind of things should be emphasized in our movement. And the last one is that we should have the strong social media wing where we can spread the scientific and proper messages into the social media, because social media is now taking over lot many people's brain.
So I'll just extend from here that as a responsible organization, President and Secretary, what will be your views on a quackery which is spreading on weight loss and everything? And second thing, as you said, how we should spread the movement. And third thing is the obesity practice in decade will be seen as the major practice after the anti-obesity medications which are in the pipeline. What do you think about the obesity field in the future? What will be our BAPI's views? Because we have to have our own views on this, very strong views.
Yeah. So I really thank you for asking this question or giving this suggestion, because you are the first contact point for anyone who comes for any condition, and you can pick up obesity, that the person is gaining weight, because you know the family from childhood to as they grow. So what we are planning to do is 3 ways. One is, like, we may be having 1 or 2 conferences in a year, but majorly our focus will be on social media, where authentic evidence-based information dissemination is our target. That we will be doing that, and for which we will be forming a BAPI group and maybe subgroups where people are interested into something. Second thing is, when we are planning these conferences, before that, we will be collecting the new evidence that comes into that period of time, and that will be disseminated through the social media. And third thing, we will be having our website where people can join, people can see the information, and basically people can ask questions. And we'll be keeping like 3 groups. That is what we are planning. One is for treating doctors. One is for general public who want to have authentic information. Because as you said that WhatsApp and Facebook, so that gives so much information, but it is so much mixed with misinformation. So that can be sieved together through BAPI. So basically BAPI was formed with that aim, that we should be treating obesity systematically and scientifically. So your suggestion is very well accepted, and we will contact you. You just give your reference and we'll be definitely contacting you.
Thank you so much.
If I can make a suggestion to BAPI, I request you to have a media cell and a legal cell. I think obesity is one condition where disinformation and quackery is the most rampant. So with the media cell, we can have capsules, information capsules in the local languages, of what is obesity and what's the scientific, information on obesity, and the legal cell to initiate legal proceedings against people who practice quackery, disinformation, and actually, defrauding people of money in the hope, of causing them to lose weight. So there should be a legal cell as well.
I've seen huge amounts of boo-boos there. People are being given diuretics. People are given thyroid medications. People are giving chameleon oil. People are squeezed. Physically they are bumped to get rid of obesity. All sorts of stupid things are going on. So I agree with Srirang. Yes, we have to do that. Now to answer the part B of your question, something, metabolic medicine is the most important faculty I feel in the next decade. So this knowledge is coming up. And a lot of hospitals are actually encouraging obesity. Santosh Marathi is the CEO, and he's been so supportive, He's given us a carte blanche. So I think Hiranandani has also been, Hiranandani entire 6th floor is going to be renovated, and it's going to be made into an obesity and a metabolic center. Vimal is the leader of that.
We are having a residency program for the weight loss as well.
So people are now waking up to the fact that the most important threat to face mankind is obesity. And the pharmacotherapy is now going to come in leaps and bounds. So imagine in 1994, we just had one anti-diabetic medication and one insulin, and today we are spoiled for choice. Now in the days, right now we have already got semaglutide, and how many medicines are in the pipeline? As he's already said, we have a amylin dye and a combination of semaglutide. We have tirzepatide, which is a GLP and glucagon receptor combined. We are going to have another excellent molecule called bimagrumab, which is a monoclonal antibody which works against obesity, sparing the muscle. On top of that, we have ghrelin antagonists, we have leptin agonists, we have medications which work on the POMC pathway, we have medications which are going to be used as intranasal polypeptide YY stimulants. Sky is the limit. We have selective beta-3 agonists. All of them are on the pipeline. In the next 3 or 4 maybe years or something, my prediction, we are going to be spoiled for choice. Yes. And once we get the molecules in our hands, it's an established faculty.
Yeah, I would add Dr. Srirang's suggestion that in Thane, where I practice, there is a group of speech therapists, and they have got a legal cell. And somebody who is not trained as a speech therapist was promoting herself as a speech therapist, and they started a legal action against that lady and asked her to stop. And that time I was surprised that we have so many organizations, API, IMA, but we have never taken any action against quackery. We don't go and have a legal action. So your suggestion is fantastic. But we should have that courage, because most of the times when I talk with the doctors, they say, "Kyun lafde mein padne ka hai? Jo kuch karne ka hai, karne do unko." There are so many patients. So that attitude, I think we have to change, because it is our, what you can say, ethical and moral responsibility to stop quackery. So that step we have to take.
So I think there's one more question from the audience. I think this is the last question, and after the.
Thank you for the good session today, sir. But I have 2 questions. I want to know about your opinion about how people come to us in OPD and they ask about that, doctor, I don't want to take medicine because like pharmacotherapy for obesity, weight loss, because they have side effects. But are we okay going with the Herbalife products and the protein products, protein powders which we get for weight loss and all, Medislim and other things are there. So that is one opinion I want to know from your side. And secondly, sir, we are talking about semaglutide or other medications. They are not so very cheap medications, first of all. I practice personally at a Karjat level. Patients are not very willing to spend that much on weight loss. So how do you want us to approach to those patients? Because, sir, sitting at Navi Mumbai, Thane, South Bombay, it's very easy for patients to convince, sometime I feel. But at the lower strata people or people who are at the rural level, how do we convince them about such medications?
Let's extend my question to this, that if you tell them to go for cardiac stents and all, 4 lakhs, 5 lakhs, they are ready to spend that much of money. But if you tell them to spend on the primary prevention, there's no such mentality to spend money on the primary prevention or reduce the weight or treat obesity. How we change this mentality? This is very important. this has to be sensitized throughout the society that this is very most important than putting the stents in your body and spending money on the stents.
I can give you one small example. If you are using glutathione as an antioxidant in diabetes, because it's an intracellular antioxidant, has got beneficial effects. People are not ready to pay, say, around 1,800 rupees for 30 capsules. But the same capsule is sold at 3,500 rupees as a fairness agent. And the same person is easily buying that. So you have to position it not as a weight loss medication, but if you can say that this will prevent your cardiac disease. As Vimal was saying, it can prevent a stent. Right. So one stent is 2.5 lakh rupees. So in obesity practice, I think the storytelling becomes a very important part. That how you communicate with the patient and how you project obesity. So that will change this attitude. And secondly, you are asking about Herbalife and all those things. They are basically MLMs. So you can always position that Herbalife, whatever contents are there, you can buy one dabba and then you can show what are the ethical, medically say promoted proteins are there and you can show. So, but usually people who fall for MLMs, they want to cheat their friends and get their money back. So we have to just exclude them because you cannot do anything about them because they want to recover their money. So they are out of our bounds.
Okay, last question. After that, we have a lunch break.
What is the role of intermittent fasting in decreasing weight and keeping the weight constant?
See, the bottom line is you stop eating, you're going to lose weight. So, for example, if I were to deport you to Somalia and stop your eating, you would lose weight. There's no doubt about it. So, intermittent fasting is definitely to cut your caloric intake. The question is, how do you manage that within the previews of your own comfortable house in Mumbai or something? So, intermittent fasting is good, but I would go a step further and say that sustained reduction of intake makes much more sense than intermittent fasting and all that. So, if you can position something over here that I'll be satisfied with lesser amounts of food, you can do it. Let me tell you. In fact, there's a session in the latter part of the day which actually tells you how to coach your own mind through it. It's not very difficult. You can do it. Obesity is an impulse eating disorder. You are eating much more than what your body needs. Simple. So whenever you have a mismatch between satiety and appetite and intake, nature has its own set works. I need these many calories for my functioning, but we tend to overcome it. And then the obesity starts putting on. So if you reposition, recalibrate your set point, you can achieve that.
So as far as cost is concerned, you must explain to the patient, there's a price to be paid for taking semaglutide and there's a price to be paid for not taking semaglutide. If you don't take semaglutide, you're likely to have increasing obesity, you're likely to have diabetes, you're likely to have cardiovascular disease, you'll end up with an infarction, you'll end up in the ICU. So don't consider only the cost of the medication. Consider the cost that you might incur if you do not take this medication. Consider the long-term costs and not just the drug costs. And secondly, never prejudge a patient's financial background on the basis of his appearance. I'll tell you a very interesting story, and that's the end. This is a story, a real-life story of Dr. K.B. Grant, who is the founder of Ruby Hall in Pune. And the legendary neurologist Dr. R.S. Wadia was in his youth, and he was attending to a patient in his neurology OPD. And the patient came from a rural background, looked very poor, and Dr. Wadia was trying to help him out, saying, things are very expensive, and he was talking about cost of therapy. And Dr. Grant happened to peep into the OPD, and he, found this conversation going on. So Dr. Grant asked Dr. Wadia, do you know whom you're speaking to? So Dr. Wadia said, no, I don't know. Who is this person? So Dr. Grant told him, this person has enough cash just now in his pocket to purchase the entire Ruby Hall. And who was he? He was Vittal Rao Vikhe Patil. Okay? So he was like in his ordinary clothes, rural background. Dr. Wadia thought he's a poor person. So that's not the case. Don't go by appearance. Don't take financial decisions of your patients on their behalf. You place the facts, you place the cost. Let the patient decide whether they can afford or not.
So thank you so much for very interesting answers. And since the ghrelin levels is building up, peptide YY is going down. Let's have a lunch, and then we'll come back for the installation and inauguration ceremony. Thank you so much.
I request all the speakers and moderator to collect their momentums from Dr. Richard Deshpande ma'am. Okay, so it's a request to get back like after 20 minutes once the lunch is over for next topics.
Dr. Modi? Dr. Modi, yes, Dr. Please come. Modi sir. थोड़ा सा आगे थोड़ा आगे चलते हैं तो ज्यादा ही Inter committee.
राजश्री सोल से सारी अब
A very good afternoon to all from myself, Dr. Manisha, and our team present here from Apollo Hospital, Navi Mumbai. It has been a rich, informative first half with the obesity physician group who have really enlightened us on the way obesity affects our health as well as our relationships. A very warm welcome from the team present here to our Municipal Commissioner of Navi Mumbai, Mr. Rajesh Narvekar, sir. I would take this opportunity to welcome our dignitaries and request them to come to stage for lamp lighting. Dr. Sanjay Khare, Mr. Rajesh Narvekar, Dr. Nitin Patakar, Dr. Vimal Pahuja, sir. Would request the dignitaries to take the seat. would request Dr. Sanjay to hand over the bouquet to Mr. Rajesh. Request Dr. Nazia to hand over the bouquet to Dr. Nitin Patankar. Request Dr. Falguni to hand over the bouquet to Dr. Vimal Pahuja, sir. Request Dr. Nazia to hand over the bouquet to Dr. Sanjay Khare. Would request Dr. Sanjay Khare to proceed with the data presentation of BAPI.
Slideshow. Good afternoon, everybody. So this is a very small presentation, barely it will take 5.5 to 6 minutes. So first is a hearty welcome to our beloved Commissioner, Mr. Rajesh Narvikar, NMMC. So the only thing is, I wanted to impress upon this. Ask not what the country has done for you. Ask what you have done for the country. And so sorry to say, but most of us, in spite of having heavy practice, is not really interested in original research, are we? So that is the reason why me and my colleagues in Apollo were really stimulated into doing something good, into garnering good original data in such a way that we further the cause of obesity. So first is, I must say my utmost thanks to authorities from Apollo and of course from NMMC. I will be failing in my duty if I were not to acknowledge the efforts of Mr. Sunil Lad, Mr. Shirish, and the minute I was shown into Mr. Rajesh's cabin, he was so supportive. He says, no, just go ahead with do it. So one letter he signed within 5.5 to 6 minutes, and we have started doing this original research. So the power of encouragement is like a booster to all of us. Thank you so much, sir. Thank you so much. And of course, like magic, the entire bureaucracy got handled. We had a lot of support from NMMC. We had a lot of support from Apollo, especially Apollo. They have literally opened all the doors to me. They said, just go do some original research. And we were blessed to have a fantastic team over here. So we have my juniors over here, my students who are in the background, the IT people, the statisticians, the actual people who did this survey for us. So again, a deep gratitude. Now, this is work in progress. So we were aiming at a data of 5,000 people. We have succeeded in getting data of 1,200 people at this point of time. It's barely been about 45 to 50 days so far. So what we did was, we asked a series of questions. We asked 45 questions in all, 52 questions to people living in Navi Mumbai, and we calculated equal male and females equal from 15 to 20, 20 to 25 age category, right up to 75 to 80 age category, equally distributed. There was no statistical bias. Our statistician vouched for it. So the data was statistically accurate at least. And the questions we asked was fairly straightforward. Age, sex, state you belong from, marital status, what is the height, level of education, family history, etc. Now, the first thing is about the amount of affiliations or the illnesses which are already there in Navi Mumbai. And this is a faithful reproduction of people over here, huge amounts of ailments, heading the list of which is diabetes, blood pressure, cholesterol, obesity, tension, headaches, paralysis. This is a general spectrum, nothing new about it. Surprisingly, most of the people in Navi Mumbai are job-oriented. Very few are self-employed. I was a little surprised about it because I always thought that this is a city of self-employment. So most of them are in job, a lot of them are students, few of them are self-employed. Highest level of education, and I'm so happy over here that most of these people were graduates. Okay, so I think Navi Mumbai is rising up in hierarchy. And this is a statistically unbiased view from 15 to 20, all the age groups have been categorized. Now the first bombshell look at the amount of obesity. Can I have a pointer over here? So look at the amount of obesity. So this is underweight category, this is normal age, and everything more than this is in the overweight and high category index. So barely we have 370 people who are either underweight or who are normal weight, and the whopping majority is overweight. Whopping majority, of which obesity more than class 4 is also rampant over here. So is class 2 and class 3. So this is the latest data, and which is a shocker. Not that we didn't know it, we knew it, but we have realized it now as to just how bad obesity in Navi Mumbai is. And let me tell you, obesity, Navi Mumbai is nothing but a faithful reflection of people from all over India, because we've had people from all over India. So now, this visceral fat is the amount of fat which is in the insides of your body, in the liver, in the heart, in the spleen, in the marrow. And this is the dangerous fat. So this dangerous visceral fat is obscenely high, as you can see. And this is not a good forerunner at all, which means that this visceral fat is very likely to get translated into strokes, paralysis, malignancies, depression, etc. So males and females are almost the same, and as expected, the gap between the males and the female obesity is now inching closer. All right. So then we have these sort of measurements, abdominal height, weight charts and all that. And the waist upon hip ratio of males and females is pretty bad. So you can see over here, this moderate and high risk, this moderate and high risk. A whopping amount of people are going into the high risk category. Ask them about whether they exercise regularly, and as expected, most of them do not. A whopping majority of people do not exercise, and among people who do exercise, I really have my doubts whether they really exercise or not, because the technical definition of exercise is something different and the social impression of exercise is totally different. So amongst people who do exercise, it's once a week or twice a week, which is pathetic. It's of no use. So for all technical purposes, I'll probably say that 90% people have no equation with exercises. Amongst the people who said that exercises, something as innocuous as walking. Now, walking is not really going to bestow health upon you, but that's it. So now this is another shocker as to how many hours of sleep do you get. And look at this. This is pathetic. So less than 5 hours is 43, 5 to 7 hours is 616, more than 8 hours is a pathetic minimum. Now, as everybody knows, nature wants a human being to sleep for at least 8 hours a day, and यहाँ पे देखो, almost everybody is out of that thing. So the sleep deprivation is tremendous over here. This is another shocker which we have realized. At what time do you sleep? See, from 11 to 1, 1 to 3 is the bulk over here. So which is so sorry, which means that our entire circadian rhythm is inching upwards. No wonder it's getting translated into bad obesities. So the entire circadian rhythm is going for a toss. As everybody knows, the melatonin is being overdriven, the stress hormones are overrepresented, and I'm sure that is one of the main reasons as to why obesity is on the rise. The amount of sleep which we are getting is probably bad. Snoring. So a couple of decades ago, people would have laughed at ever asking this question, but now we know that snoring is bad. And as per this survey, quite a lot of people snore, and quite a lot of people are heavy snorers to the extent that their partners are complaining, quite a lot of it. Surprisingly, a lot of people said that they are happy with the amount of sleep. This is a subjective opinion, I really don't know, but this is it. So this is about the next few things, and there was this data about the amount of soft drinks which you have in a week. So actually we don't have the official data, but apparently the result is pretty bad. A lot of them have a lot of candies, a lot of off-the-shelf food, and a lot of soft drinks. Now, this is again not surprising. We don't see people smoking nowadays as much as we used to. And this is exactly corroborated over here, that smoking has definitely taken a nosedive, and I'm rather happy about it. Alcohol also, a lot of them said that they don't have alcohol, a few of them said they do. Surprisingly, amongst the people who have alcohol, a lot of them have much more than what is socially acceptable. So, binge drinking, or probably a little more than what is expected, is the norm over here. So again, not very surprising about it. Now look at this. How many times a week do you eat outside or you call for Swiggy? Obscene. Obscene. Now this figure would have been laughable about a couple of years ago, and now it's a norm. I have got kids in my lane where I stay, and they are so affluent in typing up Zomatos and Swiggies, ye bulao, wo bulao. So one of my neighbors says कि उसको बाबा black sheep नहीं आएगा, but Swiggy आएगा उसको. So Swiggy and Zomato food intake is very high. The worst possible news is this: the screen time. The amount of screen time which you are getting, people. I mean, we knew that it was bad, but we have quantified as to exactly how bad. So we divided the screen time into 3 things: mobile, television, and PC, laptop, tab, the other sort of things. So look at this particular data. So huge amounts of time in seeing television, huge amounts of time seeing in laptop, plus mobile. Now see this mobile data. Now what we are going to do is, we are going to sit with our statistician and we are going to do the cross references as to amongst people who are obese, how many of them have been seeing mobiles, or amongst people who see mobiles, how many times eat outside. So all that cross data is now yet expected. So that is very exciting. So this data, along with NMMC, we are going to publish in 2 international journals which we already are in talks with. But this is something which has never been done before, and this is a real shocker. This is just the tip of the iceberg. Like I said, this is only 800 to 1,200 people. Even now as we speak, my team is doing work in Mindspace and amongst all the other people. NMMC, a lot of them have already been covered, and we'll probably be covering the police people and the CIDCO people in the next few weeks. So people who did my survey, and I must say thanks to Ameya and Rishikesh over there, they did my students, they did a real good job. So for this, they replied high as to how many people see mobile and how many people are having television exposure. High, and they say it is obscenely high. We just can't quantify it. It's that high. So when you combine mobiles and TV and tabs, it's also high. Same over here. So they answered more than 10 hours for screen exposure. Now, the last 2 slides which are going to make Mr. Narvekar very happy. The quality of happiness, personal and professional in Navi Mumbai, amazingly high. So something like 78 to 80% people said that they are very happy with themselves professionally based in Navi Mumbai and personally also. So this is just few glimpses. I just wanted to show Dr. Mr. Narvekar that this is what we are doing, and this is just a work in progress. And these guys in NMMC have made Navi Mumbai the second and the third cleanest city in India for something like 3 to 4 years constantly. And I'm a proud resident of Navi Mumbai. So now, Mr. Narvekar, I would like to request you to join forces with us in Apollo, with BAPI, and with all the doctors, so that we can even extend this research further and make Navi Mumbai the healthiest place in India. All right? Thank you so much. Manisha?
I would request Dr. Bandukwala sir to come on stage and introduce the office bearers of BAPI. Okay. We will just be playing video of BAPI for a few minutes, and then we'll take up in Dr. Bandukwala sir.
Audio.
I would request you. Yeah.
Pin. We are waiting for the pin to come. That will announce. Pin. Yeah. Okay. It's my great pleasure here to announce the office bearer of BAPI according to the chronological order. The president of BAPI is Dr. Nitin Patankar.
Thank you.
Dr. Vimal Pahuja, the second pin is for me. So I will ask. Dr. Sanjay Khare, Secretary. Dr. Vimal Pahuja, Vice President of BAPI. Dr. Ketan Pakhale, Joint Secretary. Dr. Sanjay Godbole, Treasurer. Dr. Rajesh Patil, Joint Treasurer. Dr. Neeta Deshpande, Scientific Chair. Dr. Nitin Kapoor, Academics and Research.
And our patron and advisor, Dr. Bandukwala.
Thank you all. Yeah. So a brief introduction of our chief guest today, Mr. Rajesh Narvekar, sir. Sir is an IAS 2009 batch with MA in History, and as an IAS officer, he has held various important positions affecting key projects and administrative decisions. Now holding position as Municipal Commissioner, Navi Mumbai Municipal Corporation from October 2022. Sir has received various awards for outstanding performance in Swachh Bharat mission of Government of India. Sir has also been awarded Best District Election Officer by Election Commission of India for conducting smooth and fair elections of Lok Sabha and Vidhan Sabha in 2019. Sir has also been awarded as Honorable Governor of Maharashtra Award for dedicated service during COVID period. I would request Mr. Rajesh Narvekar sir to come on stage and have addressing the gathering, sir.
Good afternoon, everyone. It is a great pleasure to be here today for this event organized by Association of Merit, BAPS, I think. So actually, I recollect a couple of months back, Dr. Khare had come to me and he was very concerned about this obesity, and he said we want to conduct some survey in Navi Mumbai Municipal Corporation area, and for that he wanted some support from Navi Mumbai Municipal Corporation. So I liked the idea. I said okay, and days and months passed. I was also, that thing escaped from my mind, and suddenly a couple of weeks back he came to me with some important results, and we discussed for almost half an hour with the result, and the result was really not surprising, but really it was a worrisome type of, because the obesity and behavioral things the now people are living is Navi Mumbai, not only in Navi Mumbai, in all the cities. So it's a matter of concern. And he then said ki we are organizing one conference. So I promised him that I will also attend. Meantime, after seeing the survey results, what I did, that I got myself medically checked last week in Apollo. And surprisingly, those all negative results, those are, in fact, I thought these are my results only. Because normally I sleep at around 1 a.m., then less than 8 hours sleep, then a lot of time spent on computer and mobile, iPad. So many of the symptoms. So I thought ki I will also get myself checked in Apollo. And last week when I checked, so that time after seeing the result, I realized that now I got promoted and now I am not overweight. I am into category of obesity. So one more promotion I got after coming to Navi Mumbai. So actually, this is not a laughable thing, but this is a matter of serious concern. The many things which he observed, which myself and you all must be observing in your families. I recollect before this COVID period, this Swiggy was not a day-to-day activity related to our family. That time before COVID, if the family want to spend some time together, so they will go on Friday or Saturday evening in a restaurant and they will spend an hour or 2 hours with your wife, children, and that's all. But after this COVID, because of Swiggy and Zomato, the new thing has reached our home, which I am also observing since last a couple of months. So when we, all of us sit together in a dining table, so my son said, please don't serve me. My Swiggy packet is just reaching in 5 minutes. So he is on the table with me, but not eating food which I am eating, homemade food. So that is, I think, another bad impact of COVID, I guess. Because as we see, the basic, the reason for this obesity is, one of the reason is outside food. That is very important, fast food or outside food. And yesterday, when I was going through some of the sites giving information of obesity, the results are quite alarming. In India also, the situation is not good. As Dr. Patankar said, now it is a time that administration and medical fraternity should come together and work on this. It will require a lot of survey, a lot of input from Apollo side or your association. But Navi Mumbai Corporation will definitely extend our full support because we consider that just giving infrastructure and beautiful roads and cleanliness is not the only role of corporation, but the citizen of Navi Mumbai should also have a beautiful life and healthy life. I'm very happy because in the survey, the 78 to 80% people have expressed their views that their happiness index is much more in Navi Mumbai Municipal Corporation area. So that is one of the encouraging thing for our institution, because we from our side say a lot of things about ourselves, that my city is beautiful, my citizen is very happy. But this is coming something from the third party audit like thing. And I'm very happy for that and very thankful to Dr. Khare and his team for bringing this thing to the notice. But on this occasion, on today's occasion, I ensure that Navi Mumbai Municipal Corporation Administration and your association and your doctor medical fraternity, we will work together, joining hands in hand, and we will come out with some good solution that will help the Navi Mumbai citizen to have a wonderful and beautiful life in this city. Thank you very much.
Thank you, Mr. Navekar. I would now request Dr. Patankar for his presidential address and vote of thanks, sir.
So first of all, let me thank Mr. Narvekar for accepting invitation and sparing some time and coming here. And I know him since he was in Thane, and he has done some spectacular work in Thane during COVID times. And as he has promised, and he is a man of his own words, so definitely Dr. Sanjay, will be a big asset, and his guidance will be really helpful for growing BAPI and Apollo. And I'm really thankful for all those people who are attending this conference, and welcome all. And let's join hands and work to rectify what Sanjay has found in his survey. And sir, wherever he will go, I think this will be carried to all the cities. And I am sure sir will be like staying in Navi Mumbai for at least 3 years. So we get ample time to get a big database here, and we will implement all over India. Thank you so much.
Thanks a lot, and it's a big word of gratitude to Manisha, our graceful hostess. Ever since I've joined Apollo, I've always looked upon Manisha as a female Santa Claus, you know. One word and it gets delivered. Thank you so much, Manisha. Thank you so much.
Welcome back. Let's go to our next session, Calm with Metabolic Syndrome. I call upon the moderator, Dr. Bimal Pahuja, and speaker, Dr. Ketan Pakle.
So the next topic for deliberation is from Dr. Ketan Pakle. He is going to speak about calm with metabolic syndrome. As we know, the metabolic syndrome is a very important entity from the Indian perspective. If you know the data, 1 out of 4 or 5 people will have metabolic syndrome. And this metabolic syndrome is heavily linked to cardiovascular disease and diabetes. So how to manage, how to diagnose, how to prevent, he's going to speak all about this in this talk. Welcome, Dr. Ketan.
Can you just start this, please? Thank you so much, Dr. Vimal, for the introduction and giving me the opportunity to present in front of you all and take the notice of metabolic syndrome. We are at a bariatric conference, obesity conference. So as a joint secretary, I would just like to, before starting my presentation, I would like to keep a notice for everyone. It is BAPI, that's BAPI, and the full form is Association of Bariatric Physicians International. So we have to go with, because it has been registered there. Now I'm feeling much better because it has been clarified. So I'll go further now with my talk. It is Calm with Metabolic Syndrome, and it is about collaborative action in lifestyle disease management. So what do you think looking at this baby? What do you feel? Is a cute baby? Yes, most of them will think it's a cute baby, but I would say that it is most of the things which I have learned and we have been hearing is a khate pite ghar ka baby. Okay, so what happens with this? The studies have demonstrated that excessive nutrition, lack of physical activity and lifestyle becomes a major cause for metabolic syndrome, obesity and diabetes later in the childhood. And lifestyle modification for today, what we have to understand is for a happier and a healthier life tomorrow. Because not just in India, but all over the world, the healthcare officers and the governments are actually realizing, as we saw our commissioner sir was here and even he took into a notice about that, realizing the need of change of the lifestyle today. So what is metabolic syndrome? Basically, it is a constellation of interconnected physiological, biochemical, clinical, and metabolic factors which directly increases the risk of cardiovascular diseases, insulin resistance, and major cause of the mortality. But what happens, our body metabolic pathway has provided energy to the tissues in times of our survival, and it even conserves the energy in the food deprivation way. There is surplus of the food. When there is surplus of the money and salary, we become happy. But what happens with this? It surplus of the food along with the physical activity or very low physical activity, the excess nutrition stores, and it is a significant way where the dysmetabolism occurs and the metabolic functions are disrupted here. And we got the prevalence of metabolic syndrome, and globally it has stated that the prevalence is up to 84%, and as per the IDF, which has estimated it is around 25%. So significant association is there with majorly higher socioeconomic status, sedentary lifestyle, high BMI, and the factors like genetic background, activities, diet, smoking, and family history are contributing to this metabolic syndrome. So the diagnostic criteria, as we started the presentation, we talk about metabolic syndrome. So what do we actually diagnose with it? We all have the patients of type 2 diabetes, hypertension, dyslipidemia, and even high blood pressure, so hypertension. But when any 5 of these, when 3 are present, we label them as metabolic syndrome. So we write the diagnosis of type 2 diabetes, or we label as systemic hypertension, but we feel we should write as metabolic syndrome because these clusters of diseases itself is having majority of the metabolic disorders where the quality of the life of a person gets hampered here. And causes, as we all know, after the aging, hormonal imbalance, genetic predisposition, and even cortisol in the chronic stage plays a major cause for metabolic syndrome. As we see, the risk factors are increasing with this, like sugars, pro-thrombotic stage, oxidative stage. There are certain drugs and environmental toxicants. So yesterday, the environmental thing is also about the obesogenic. So yesterday, when we were having lunch together with Dr. Vimal, we thought of we should go for a buffet. But then he said, no, this is one of the environmental obesogenic part which will play for obesity, so we went for a la carte. So these are type of environmental factors which really plays important role, which promotes metabolic syndrome. And because of this, the 2-fold increase in cardiovascular diseases, 5-fold times in insulin resistance, and even stroke with this. Apart from this, one small just a session, what according to you, which are the highest patients who have shown highest rate of mortality here? Obesity, genetics, dyslipidemia, or environmental factors? I'm sure, what is your call on this? I'm sure everyone sees obesity because we are in that conference. But if we stand in another conference also in gynec or in pediatrics or anywhere, our answer won't change here because obesity is actually major cause for the highest rate of mortality. So pathophysiology, overall pathophysiology of metabolic syndrome, it is triggering pathway for visceral adipose tissues, high calorie intake, and the essential players for metabolic syndrome here includes insulin resistance, some neurohormonal activation, and chronic inflammation as well, subsequently develops the metabolic syndrome and the cause of mortality here. If we talk about just pathophysiology of abdominal obesity, which is causing metabolic syndrome, as we have calorie intake, it turns into adipose tissue hyperplasia, and there is reduced blood supply, which is leading to hypoxia. When this occurring of hypoxia is occurring, there is macrophage infiltration, necrosis, and secretion of adipocytokines, which is leading to localized inflammation. When there is localized inflammation, it multiplies in thousands and lakhs, which is leading to overall systemic inflammation here. Apart from this, even if we see in insulin resistance, which is leading to metabolic syndrome, there are free fatty acid which increases because of insulin resistance. It reduces the glucose uptake in the muscle, and hence the visceral fat majorly contributes to the insulin resistance than subcutaneous fat here. Even when there are high levels of free fat acids, and it promotes triglycerides transfers from VLDL to LDL, and the clearance of HDL goes down and the concentration of HDL goes up here. So there is another pathology where dyslipidemia is promoted here, and alteration in lipoproteins concentration causes atherogenic dyslipidemia in metabolic syndrome as well. Again, coming to the hypertension, I'm just tapping all the diagnostic criteria and making you in short how the pathology runs behind every disease. So imagine when all these diseases, when put down together as wholesome syndrome, how scary the situation would be. So insulin resistance would be capillary. When there is insulin resistance, there would be capillary rarefaction, vasoconstriction, and even there is increase in the hypertension. So role of adipose tissues here, of course, hormones, the peptides, and inflammatory cytokines. These adipokines plays a very important role for the pathophysiology of insulin resistance. And the favorite hormone is my leptin, because it is directly proportional to obesity and body fat levels as well. This promotes pro-inflammatory immune response, and higher peptin levels increases the cardiovascular risk and inflammation. Same occurs with the adiponectin hormone, where it increases the insulin resistance. There are several neurohormonal pathways, again, which increase the development of metabolic syndrome. Same is with the role of chronic inflammation. And when we know this all pathophysiology, there should be some management for it. So today we are talking about the CALM with metabolic syndrome, that is collaborative action in lifestyle management. And here, when we are talking why it is so important to tap this disease, because it is non-communicable disease, it is a global threat on the verge of becoming pandemic, and India stand actually in top 3, where I guess in the recent presentation I was talking to Nitin sir and Nitin Kapoor sir, he told that we have already reached in the top first. We are ahead of China now, where we will be having most diabetic patient here. So we are in the top now, and the goals here to tackle this management is, the primary goal is to reduce the risk of cardiovascular disease and prevent insulin resistance here. And very important, this has to be tapped with the individualized management. The blanket therapy could not be applied for everyone, but attitudinal change, I would like to take a mark on this. Attitudinal change and behavioral patterns changes is very important, apart from diet, exercises, where lifestyle coaching plays a very important role. On the panel discussion, we actually had a discussion, apart from this metabolic syndrome, there are many patients with obesity who are into depression. So these patients require actually behavioral changes, and they need good amount of time to understand the seriousness of this disease. Life's Essential 8, it is coming from the desk of American Diabetic Association, which they have put that Life's Essential 8 plays very important role here. Apart from physical activity, diet, checking of your sugars, weight and blood pressure, smoking, and adequate sleep and patterns really plays an important role. We have heard of circadian rhythm as well, and this plays a very important role for our metabolism, and this Life's Essential 8 should be catered for all of us here. So interprofessional team is required, where a physician, dietitian, your lifestyle coach, and even the pharmacist plays a role, because it's an entire team. We see many miscommunication between the pharmacists and the doctors, and there are dosages which have been given different, and we do not get good amount of results then. So it is completely interprofessional team. Talking about some part of diet, we are into the obesity conference. I would just take you for quick slides of diet, 3 to 4 slides. It is about the Mediterranean diet. It is a high fat and low carbohydrate diet pattern. It is a plant-based diet, again beneficial for all type of cardiovascular disease, the type 2 diabetes mellitus and metabolic syndrome. Then we have DASH diet. We all know DASH diet, we talk about hypertension, but it is a best strategy to treat blood pressure, and it should be reduced in the sodium, but it should be rich in fibers, potassium and magnesium and calcium as well. We have another plant-based diet where it is low energy density with high fiber content, and restriction of animal-derived food should be reduced here. Then we have low carbohydrate and very low carbohydrate diets. Again, reduction in total calorie intake with the reduction of the carbohydrate diets is analyzed here. But it has to work further, more studies required, because there are lack of healthy food intake which has been observed here. We do not consume the vegetables, fruits and whole grains, which are actually important, but it has to be analyzed more here. But again, this diet could be helpful for lowering the risk of development of chronic diseases. Low fat diet, and then we have high protein diet. Again, it leads to greater weight loss and cardiovascular improvements. There is something called as Nordic diet as well. It is characterized by high content of whole grain, high fiber products such as rye, barley, oat, rice, vegetables and fruits and nuts. When this has been promoted. Again, blood pressures and dyslipidemia has been catered off. Then somebody asked about the intermittent fasting, and Dr. Khare sir has already given a wonderful answer for this. It cannot be a blanket and everyone can follow for intermittent diet. It depends upon your behavior pattern, your profession, and the way you are living. Then you can go for the intermittent fasting then. Then we have conditions like obesity, hypertension, dyslipidemia, and insulin resistance as a common conditions of metabolic syndrome. But I would like to take a note and make you notice that unfavorable diets like saturated and trans fatty acid and sugar sweetened beverages like cold drinks and the coffees and the tea what we have with the sugar are a major unfavorable diet which leads to all these chronic diseases. Micronutrients like antioxidant plays a very important role here because it prevents the oxidative stress and the oxidative damage has been reduced. Healthy weight management, we need to understand again, for a healthy weight management, holistic choices and the patients and counseling for the patients is the key. Physical activity plays a very important role. It is not only about going for walking, jogging and doing exercise in the gym. Even when we are sitting here for last 1.5 hours, we stand and sit back again is also considered one of the very small activity and exercise, because these small changes would really be helpful if you are a doctor, professional, banker or corporate person who are having office desk job, can actually stand for some time in an hour, stretch your body, you will be more focused to do the work and you will be more flexible to concentrate on your work as well. Advantages is amazing. Why I'm saying? Because exercises and adipose tissues goes hand in hand. Increase in adiponectin levels, improving cytokine profile, and inflammatory markers like TNF alpha and IL-6 also catered. Exercise and metabolism of glucose and lipids also plays a very important role because it activates AMP kinase, which improves the fat oxidation. Exercise and blood pressures again plays an important role because when you reduce around 3 to 9%, there was discussion about 5 to 10%, you reduce the fat at that level, and we see the marvelous result because your blood pressure of systolic hypertension goes down by almost 3 mmHg of your mercury. So this has been helpful because I have a very young guy who was 22-year-old. When he came to the clinic, he was having this central obesity, and we didn't started him on the medication, but lifestyle changes was done for him, as we see here, and even just small changes in his parameters of body composition, he was reduced the visceral fat, regulated his blood pressure, and currently on long-term follow-up also he has not started with the blood medications. So pharmacotherapy is again one of the things. As we are short of time, I would like to wrap up my presentation soon. Take-home message is prevention. As we all know, prevention is better than cure. And finally, we are not late. It's time to change our body. Get your blood reports done. And it's a motivation because health is not about the weight you lose. It is about the quality of life you is. Get moving and make a right substitute for your food and listen to the music of your body. We are there to help you out. Very last important thing. We have recently suffered with COVID-19 pandemic, but real pandemic is actually inside our clinic in our OPD. We need to tap those things and we can take care of it here. Thank you so much.
Excellent talk, Dr. Ketan. And I think the most important message is to start measuring the waist circumferences. If you see the 8 of 10 OPDs on 7, you will not see the people measuring the waist circumferences. There is a major criteria to diagnose somebody with metabolic syndrome. That is number one. And most importantly, the exercise part is very important. People still go for walks, and walks are not going to be solving the problem. So we have to refer them to exercise physicians for good endurance under supervision, and we are not doing that. So it requires a lot of multidisciplinary effort from everybody. It is not a silo practice, or it's not a silo person who is going to tackle metabolic syndrome. And the era of multidisciplinary team and multidisciplinary team approach is here. We have to welcome it, and we have to understand that metabolic syndrome can be only tackled if you join forces together, not having egos, keep egos aside and refer to each other so that we help the patient better. Thank you so much. If any questions from the audience, we'll take the questions.
Now I invite Dr. Nitin Kapoor sir to give the mementos to Dr. Chetan, Vimal Pahuja sir and Ketan sir. So the next is debate, fat but fit is possible, by Dr. Nivedita Maulik and S.V. Kulkarni.
Good afternoon. We are entering into a paradox of the whole concept of obesity. And a person no other than Dr. Sanjay Khare and Dr. Nitin Kapoor will be debating against each other whether fat is fit or not. And I'm really happy to share chair with Dr. Nivedita Maulik, such a senior physician, HOD of Medicine Department in DY Patel Medical College. Sanjay, so you are the first to start.
Yes.
But the problem with Sanjay is he talks too fast. Okay, you try to talk which everybody can understand.
That's unfair bias because the judge has started on a negative note. I think this is conflict of interest. Can I have my slides, please?
Whilst you start, I think congratulations to all the new members of the newly formed organization, and it's a starting day for you all, so wishing you all the best. And I'm here today for two of the people. One is Ketan, is where I'm working now, and Vimal is where he was when I was working earlier.
That is fit.
And personally, congratulations again to Dr. everyone in the team.
नाही त्याच आहे माझी कुठे
By the time the technical things are getting set up, I will like to ask the pre-debate opinion of my people on left side. Do you believe that fat people can be really fit? Yes or no? Yes. Raise your hands if you say no. Nita says no. Okay. Huh? No. Obviously on the right side, Nitin? No, you are on the other side. So you change the side. Yes.
So good afternoon, everybody. You are all gentlemen of juries, over here. So for the last many sessions, a lot of speakers, including me, have insinuated that all of us are obese, all of you are obese. So over the next 10 minutes, I'm going to convince all of you and the esteemed judges that all this is bullshit. Fat is nothing but overhyped nonsense. So here we have this person, Sir Winston Churchill. So this Sir Winston Churchill was the only person who was between Adolf Hitler and between a free India, a free world. So Britain had actually appointed 4 physicians to Sir Winston Churchill over 6 to 7 decades of his public life. And he said that we want you to be hit, we want you to be fit. Sir Winston, stop hogging so much, you are so plump, you are obese. You smoke, you drink, you don't exercise enough. So Sir Winston Churchill said, just chill, man. I'm not going to reduce weight. I am happy. I am really physically, I am okay. I'm doing my work. I'm mentally fit. I'm keeping the Nazis away. I'm keeping the Britons away. What's your problem? So why am I showing Sir Winston Churchill? The answer will come in the last slide. Okay. So one of the reasons was Sir Winston Churchill had tremendous faith in another British person of his, and that was in the theory of evolution, the one propagated by Sir Charles Darwin. So man has been evolving in stages, right? So this is what the early person was. He had to really batter bitter colds. And what was the only solution for him? To get fat. So fat for him was one of the most essential commodities at that point of time. What are the health benefits of fat? Important role in storing energy, that is so important. And we know that A, D, E and K solubles of vitamins are useless without fat. These are phytochemicals. The dietary fats satisfy appetite. Dietary fats provide essential fatty acids. And most importantly, they help us in keeping warm. It protects the body from trauma. In a way, every time you put on little amounts of weight, you are actually putting a penny in your piggy bank. It is saving account, all right? This is evolution. This is not Hankam. This is not mind things. So just like a man lost his tail during evolution for the betterment of human species, we are evolving at all points of time. Does that make us bad? Not necessarily. So at this point of time, most kids wear glasses. What are we going to do about it? This is the way the world is going. It is evolution, it is change, it is something not necessarily evil. We are changing. We lost tail, we have gained spectacles, not necessarily bad. We are losing hair. Why? It's tending to say it's because of chemicals and pollution, but it can also be because we don't need hair anymore. The world is warmer, we don't need hair. The canines are getting shorter, friends. Previously, the canines were massive. So, a friend of, in fact, the dean of D.Y. Patil Medical College, the dentist, he told me that the incisors are getting shrunken. It used to be 20 millimeters, barely 3 decades away, and now it is down to 11 centimeters only. Why? Because this is all evolution. Kids are getting smarter, we are getting more evolved, we are getting more aware. Does that make us bad? In the same way, if we are a little plump, does that make us bad? Not necessarily so. Who says? This is nature. But we have some, disturbed people over here who go overboard, who go hysteric. Don't get fat, don't get plump. Fat is the biggest evil known to mankind. What rubbish. Look, I'm not stupid enough to say we are going to condone gross obesity, but we have a person who's plump and who's bloody fit. What's wrong with people? Why do they want to judge people like that? If we have a person who's fit and who's exercising meticulously, what's bad about it? Which brings us to this established thing called the fat paradox. We have known that people have been going blue in their face trying to say, no, fat is bad. But I have robust data which show actually that it is paradoxical. That if you are a little plump, you are actually getting tremendous benefits out of it. And the next couple of slides is going to establish this point beyond doubt. This is what the Wikipedia says, that this paradox was first found in people who have cardiovascular diseases, and much to their horror and to their amusement, the scientists actually realized that if you're a little fat, you augur better on the scale of survival. So, the first thing is, are we really doing justice to this whole rubbish business of BMI and obesity? Who are we to classify somebody as obese? Are our parameters normal? Arnold Schwarzenegger is 6 foot 1 inch. He weighs 118 kilograms. By the book, his definition of BMI is 37.5. Only an idiot would call Arnold Schwarzenegger fat. But this is the definition. So if you and I were to have a BMI of little on the higher side, does that make us obese? No way. So it is important to break down these conventional, parochial body maladies and do everything. So the thing is, if I am a little plump, so what? It is evolution. As long as I'm fit, I'm able to do my day-to-day work carefully. I'm happy mentally, physically, spiritually. Who the heck are these BAPI people to tell me, shut up and don't eat low? What rubbish is this? So we are going to have all things considered. I am not going to talk only science, friends. I am going to talk about a broad way life. We are going to talk about literature. We are going to talk about history. Let's start with literature first. Robin Hood. A very important character was Friar Tuck, who was obese. These books, we have all grown up reading these books, right? Jupiter Jones, who was the brain, he was plump. So what about David Blyton? 3 investigators. Frederick Totterville, he was fatty. He was called fatty. He was the brains. Why go? Look at this marvelous blockbuster of a movie, Godfather, in which it has been said that in older Sicily, people used to look upon people who were important as man with the belly. So a man with the belly was the dada of the place, and he was the one who was the cheerleader. And yet we have this witch hunting about obesity. Where is the clinical experience? Where is it? We have huge amounts of things saying that obesity or BMI paradox. So obesity paradox is a lesson to be learned for the simple reason that there is a huge amount of addition in the way people with obesity actually tend to do in life. So we have a condition called metabolically healthic obese. Why not? MHO, it's a known concept. So there are few concepts about diagnosing MHO. The biochemical parameters should be okay. there should be low amounts of fat in the visceral organs and more in the periphery, and there has to be expandability of subcutaneous adipose tissue. There have to be preserved insulin sensitivity and beta cell function. And if all this is okay and the person is a little overweight, what the heck, I'm not bothered about it. So we are not worried about BMI. We are not worried about the names on the scales. What I'm more worried about is your parameter okay? Are you happy? Are you fit? You're not obviously disturbed. So what's the problem? And look at this beautiful data, which actually shows that people who have a BMI of 25 to 29 have a better life expectancy. Can you believe it? So let's talk about organs to organs. Let's talk about cardiovascular system. It is a known thing that people with myocardial dysfunction, congestive cardiac failure, people with after bypass do better. People who have a higher BMI, they actually do better. So same over here, the lifestyle and the quality of life is significantly not as bad as people who are so-called normal weight. What does brain say? It could actually protect against dementia. We have a lot of papers which actually show that people who have strokes either have lesser amount of strokes in quality, quantity, and the outcome is much better. Survival benefit of obese after stroke is much low. What about happiness? In Marathi, there's a kahavat, hasa ani lathava. Isn't it true? So look, we have huge amounts of scientific data that people laugh better who are a little on the chubbier side. People are happier actually. And people are actually happier with themselves, so some literatures. What about conditions like rheumatoid arthritis? Actually, there are protective factors which show that obese people do well. Their amounts of NSAIDs are lesser. The radiological damage is much lesser. Huge amounts of paraphernalia, which I'll just rush through, which show that people with RA and who are obese are actually better off compared to their skinny, thinny counterparts. What about periodontal diseases? We know that there is huge amounts of protective effect against periodontal diseases also. And of course, I'm saving the last for the best. What about critical care? This is a shocker. Friends, you're going to be amazed after this. Actually, there is maximum survival benefit in those who are critically ill. People who are little obese, people who are little chubby, they have a much lesser hazard ratio. And there have actually seen that there is a paradoxical benefit with obesity in regard to septicemia. All right. And I'm going to repeat this slide. In conclusion, our results suggest that the obesity paradox may also be suitable for survivors of critically ill patients. This is the expression. Yes, I told you so. What about COPD, which shows that obesity was associated with reduced mortality at the end of 1 year? Cachexia is the worst possible prognostication for COPD. What do the nephrologists say? It's a very peculiar thing that obese people tend to have more CKD, but amongst those who have CKD and who are obese, they fare much better. What about malignancies? In the same way, obese people have a higher incidence of kidney cancer, but they are also more likely to survive the disease. Obesity and lung cancer, much better outcomes. What about this study? We were going pink in our faces talking about pediatric obesity. This test actually shows that people who are chubby, in fact, somebody was asking me about adolescent and pre-pubertal obesity. So these people are not necessarily worse off. You make them exercise, they are not as bad as others. So the concept of metabolically healthy obesity should be used to control. And now I'm going to talk about this rubbish which is going on at this point of time. You shame people into negative self-imaging that you have to have a BMI of 25, you have to fit into a size 2K, these things. So being underweight actually has similar negative effects as compared to being obese. Body shaming and all sorts of quackery which is associated because of this particular media hype. You know, who says that we have to be this amount of things? And friends, all of you are trying to convince me that obesity is bad. I push medications and then what happens? Off the shelf, sibutramine, withdrawn within a couple of days. What about this, Belvic? You know, we have prescribed medications and it was so stupid that suddenly the people come and tell us, no, stop writing. The patients come and tell us, what are you doing, doc? It's there on the net. I said, is it? So this is the sort of things which we are going through. So we are all prey to this fake news and the sky is falling and the brainwashing which is going on. Metabolic healthy obesity is a concept. Obesity paradox is a reality. Which brings us back to this guy. So the state of England had put 4 physicians to look after Sir Winston Churchill and they all died. One in 50, one in 60, one in 70s. This old guy lived till the age of 90, happily smoking in his bed and says life is beautiful. Need I say any more? I rest my case.
Thank you, Sanjay. Actually, he didn't put any remarks from ChatGPT. That was what I was expecting. And thanks for taking down the memory lanes of history and geography. Nitin, it's your turn.
Thank you so much. And can I have my slides? So I must say that my slides have no philosophy, no history, no cartoons, no fiction. It's based on evidence. We talk of science, and that's what I would do in the next 10 minutes or so. So, can you just project it?
The screen is not syncing.
Right. So the job that I'll do in the next 10 minutes is if somebody is fat, can they be fit? And I would say the answer is no. And I think scientifically looking at this whole concept of fat but fit needs to have several small puzzles, several small pieces of a big jigsaw puzzle that need to be connected to get to the big picture of whether this phenotype is actually possible. And I'll take you through each one of these in very short 10 minutes and started with the definition. Dr. Sanjay Khare said that metabolically healthy obesity should be used. Well, first of all, we should know what is metabolically healthy obesity and what is the definition. I think in our clinical practice, every day we get patients who come in front of us and sitting, and we are diagnosing obesity. Either we classify them as normal weight, overweight, obese, or morbidly obese. We also know that in the Indian setting, we have people who may have high body fat even despite normal weight. But today's focus is on people who are so-called obese, but said to be metabolically fit. So what is this phenotype? What is the definition? Well, there are several criteria. This is one of them. But a very interesting study that was published in Endocrine Reviews, which I would say was one of the best endocrine journals in the world, Impact Factors 20. When we look at the different criteria for diagnosis of metabolically healthy obesity, in this huge NAINS database, they use one criteria, you have 40% prevalence, another criteria, 20% prevalence. So friends, if you don't even have a proper diagnostic criteria for a disease, how can we first of all rely on that? That's my first point. The second point, again, Dr. Sanjay very well said that if it's fat, it's okay. Metabolically, the person is normal, no insulin resistance. But if that person is fat, we've been talking about psychological impacts of obesity. We've been talking about the mechanical impacts of obesity. How do we handle that? When you look at different obesity guidelines over the last 1 decade, all of them have changed by just not looking at the patient through a metabolic lens. Look at the patient as a whole. This is the Canadian Medical Association guidelines, one of the most comprehensive in the world, published in August 2020, again focusing on health-related quality of life. The Indian guidelines published last year, both by the Endocrine Society and by the RSSDI. I think all of us as physicians do look at metabolic health, but that's not the end of it. A patient with obesity, we need to look at the mechanical problems. We need to look at the mental problems. So if we've been talking about patients who may be fat, metabolically fit, are they going to have less eve teasing? Will they have less stigma? This is a study from our center where we look at that patients who walk into our clinic have a very high level of stigma associated. The stigma is associated with suicidal levels. But this is irrespective of their metabolic problems. So we cannot prevent the psychological aspects of obesity. Another study from our center where we look at the prevalence of psychological problems, and this was iterated in the morning, that patients with obesity have significant psychological impact. So even if you're metabolically healthy and you're going to kill yourself with a suicide, it doesn't help. What about mechanical problems? So if the patient is overweight, are the knees going to bear that weight easily? Probably no. The bones, a fracture, a fragility fracture in a patient who's got severe obesity, how will it heal? Even if you're metabolically healthy, it will not heal. The mortality and the fracture healing is much, much less. So friends, it's just not important only to focus on metabolic health. Obesity is a much bigger picture. We need to look at the mechanical aspects and the mental aspects, which are equally important. Hitting the nail right on the head. We're talking about metabolically healthy people, and we're talking of cardiovascular mortality. I think there cannot be a bigger study than this. 3.5 million men and women, published in American Journal of Cardiology, follow-up of over 5 years. Just look at the odds of having a stroke, the odds of having a heart failure, the odds of having a congestive heart disease. 2 times higher risk than people who are normal weight. So are we not fooling our patients by saying, okay, it's fat, it's fine? They have a 2 times, 1.96 is the odds ratio for heart failure. 1.49 is the odds ratio for CHD. So friends, 3.9 million followed up for 5 years, clear, startling data telling us that yes, metabolically healthy obesity is not considered to be healthy. And there's several papers. In interest of time, I'm not going to go through each of them. What is the Indian reality? The theme for our conference today, It is talking about the realities in the Indian setting. This is a cohort study from Kerala where we're looking at people with obesity. How many of us so-called fit in a definition of metabolically healthy obesity? Leave aside the mechanical and the mental problems. Just about 4.8%. It's a matter of time. This is another cohort study. We've looked at mother-daughter pairs. They are mothers, postmenopausal women, and their daughters who are married and settled elsewhere. And when you try and look at their body fat, I think it's just a matter of time. These so-called metabolically healthy women who have daughters who look healthy, in due course, they are going to become unhealthy. And I think that's what most long-term data on this concept tells us. People keep yo-yoing unless you provide a good definitive treatment for obesity, like in this case, a bariatric surgery done. Otherwise, they will keep yo-yoing. We all know that yo-yo dieting is not good. Another very interesting paper is Metabolically Healthy Obese Phenotype, Irrelevant Artifact for the Public Health. What does it say? It tells us that this is just a stage before getting unhealthy obesity. So this is just a transition. The way in diabetes, we say people are normal, having normal blood glucose levels, people have diabetes, in between we have pre-diabetes. This is just a stage of transition, and unfortunately we as South Asians zoom into a metabolically unhealthy obesity. I would say this is an opportunity to identify these patients and treat them before they become more unhealthy. So I think the last slide, so what is the way forward? I think most recent guidelines today talk about looking at obesity not just through the metabolic lens, looking at the patient as a whole, looking at them with their quality of life, their mental and the mechanical aspects, and I think a lot of data herein. So I think fitting all these small different parts of a puzzle, we're talking about a phenotype, fat but fit. We don't even have a good diagnostic criteria for that. We're ignoring the other effects, which are the mental and mechanical, which are equally or more important. We looked at long-term data with respect to cardiovascular safety. We failed there. We're looking at data from Indian reality. What we realize on long-term follow-up, these are just patients who are in interim phase, who are going to become metabolically unhealthy in due course. Might as well look at this as a window of opportunity and treat them. I'll stop here. Thank you.
So thanks, Dr. Kapoor, for highlighting each component and giving us scientific data. So Dr. Khare, would you like to rebut? Give him 2 minutes?
Yeah, 2 minutes.
5 minutes.
I'll finish it in just one sentence.
Yes.
I'm glad to be wrong, and I'm glad that he's right. Obviously. It was a no-brainer, actually. It was just for the heck of it, you know. So good. Congratulations. May the better man win. Thank you so much.
So Dr. Khare, do you think we are still evolving?
Yes. There's no doubt. On a serious note, yes. There's no doubt about it.
Means we're going to become more obese.
That's what we are all evolving. And that's why I'm fit.
Sanjay is the proponent of this type of people, no? खाते पीते घर का लड़का है तो थोड़ा मोटा रहेगा. हमारे घर के सब लोग डबल हड्डी के हैं. And you told about Hasani Lattava, Zadia Radia. Means Zadia is happy, Radia is always creating problem. But you have given some good insights. And thank you. Sanjay, for you, I have stayed here today. And it is a wonderful event. I'm meeting so many good old friends. And we need to propagate this science of obesity to real primary care, not only physicians, but even at the family physicians level.
Thank you so much.
Thank you.
No, my opponent has agreed that the science wins. So stop here. Yes, I think overall it is just a phase from being metabolically healthy to completely metabolically unhealthy. This is just a transition phase, and I think we should look at it as a window of opportunity.
So you think we should start intervening right at the childhood
Definitely
or the adolescent or?
At each aspect, if we do find people who are overweight or obese for their given stature, and looking at it from a more holistic purpose, like looking at their mechanical complications and mental effect, I think we should.
So do we have separate obesity clinics in various hospitals? I don't.
It's coming up, ma'am. We in Vellore started it about 10 years ago. We have an integrated clinic with psychiatry, bariatric surgeons, physicians, dietitians, physiotherapists. There's a need for such clinics, and there are a lot of people in such practice.
Yes.
Honorable, after listening to both of them, my comments are with a very lighter note. Just take it humorously. That after listening to Khare sir, I was about to going to ask for the refund of my membership with the BAPI.
Why are we here was the first question.
But when I heard him, I again gave a rethought that I did proper thing. Yes. Yes. And friends, what Dr. Khare has presented is the mind of a common man who get influenced with the social media. And what Dr. Kapoor said is the scientific based information. So I usually say that what Khare has presented is the information and Dr. Kapoor has presented is the knowledge. And this difference between knowledge and information is the difference between the social media and doctor. Khare sir, tumhe khoto bolna.
Thank you. That was real paradox of paradox. Any other comment? Because we are seeing so many faces which are, they want to speak something. Because it has to be more of interactive. Neeta, Nitin, Sanjay ला तर किती दिवसांनी भेटतोय? Yeah. Yes, Rajesh is one of the most proponent of fat is fit.
Cosmetic component is there, but I think we as doctors shouldn't really propagate obesity treatment only for cosmetic component, because true, ma'am, but then people with BMI 20, true, people with BMI with 22 will also come and tell that, doctor, I am overweight and you need to do something. So I think we just stick to the science part of it and maybe that will be helpful. But yes, there are people who come only for cosmetic, only for liposuction, but then we know that that's not going to work. That's not medically helpful.
Nitin, I have got a question and opinion from others also. आपल्याकडे गलेलठ्ठ लोक आहेत सगळी, short neck and thick neck. So do we have some standard Indian figures of a neck to height ratio, or for that matter height to neck ratio?
Yes, sir, neck to height ratio and even neck circumference. There are two large studies, both from Calcutta, that have looked at neck circumference cutoff with respect to the prevalence of metabolic syndrome. The values are different for men and women, 37 and 35. It's important for the people who are listening for the quiz. But yes, sir, neck circumference is very helpful, and also it's important because we in the Indian setting sometimes cannot really measure the waist given our clothing, given the time constraints that we have. Neck is easily exposed, but a very strong correlation between neck circumference and metabolic syndrome, and OSA as well.
Yeah, that is mainly in the adolescents. And just like what Moira said, let us relabel obesity as hand, foot and mouth disease, where the hand is taking lot of food to the mouth and the feet is refusing to move around. Wonderful. So obesity is a hand, foot, mouth disease in a reverse way. Okay. Thank you.
Yes, there are two large studies.
We have a cutoff of about neck circumference to diagnose somebody with drawback story to less than 40 centimeters.
Thesis for your students.
So the study that I'm quoting is from Calcutta. It's a large study, very well conducted. They've looked at even body fat through DEXA, and it's lower than the West.
I think there's a lot of material for dissertation, but there was a study where they done the epicardial fat, I think by a well-versed technician on echo, and correlated it with the visceral fat, which was done by CT MRI, and they had a good correlation. So when you're not able to do CT MRIs, you're doing only echoes, which is being done routinely in an emergency for various settings, they could get a good correlation kind of.
So Shri, for the question which you asked, and Jaya's over here, I can't resist asking it to her. In our settings, a neck circumference of more than 40 to 42 is supposed to indicate obstructive sleep apnea along with this thing. So my question is, we saw a lot of data, like reduction of weight by 5% will get rid of this, blah, blah, blah. But Jaya, correct me if I'm wrong, getting rid of OSA is very difficult.
Very difficult.
Even if you lose a hell of a lot of weight, that OSA sala nahi jata hai. No, theoretically 18% is the figure, but I have seen people even after bariatric surgery, usually they can't shake the machine off. You have anything to comment?
No, That's what we have seen, that even though the weight loss is around more than 20% of their weight, we say that 10% weight loss should have a significant effect in the apnea-hypopnea index at least. But usually the apnea-hypopnea index will reduce, but it will not get completely corrected. Although the patient will have significant improvement in symptomatic sleep apnea.
So the snoring, 80% may still get off the machine, 20% may not still. So it's, I think there's a lot.
Is it? The snoring, yes. The partners will not grumble anymore, but they are not able to get off the machine.
Because they don't lose weight, I think.
No, that's what we're saying. Even after bariatrics and all that, somehow the insulin goes away, the OHs go down, the antihypertensive control, that OSS, CPAP machine, difficult.
Thank the organizers for inviting us. Thank you.
Now I request Dr. Vimal Pahuja sir to give mementos to the moderators and the speakers. So the next topic is case scenarios, exercise prescription in obesity. So now I invite Dr. Siddharth Yadav sir and Dr. Anup Krishnan as a moderator on the stage.
No, you can start.
So now I invite Dr. Anjali Bhatt for this case scenario exercise prescription in obesity.
Good afternoon, everyone. After a wonderful lunch and an exciting session on whether metabolically, quote-unquote, healthy and unhealthy obesity be treated, we know that it needs to be treated, and we need to come to the next question, how do we treat it? And we know that exercise and nutrition are the two most important pillars of making somebody lose weight. Let's talk about the role of exercise. I was told to do case scenarios so that we can relate it better to the day-to-day activity, day-to-day practice, because this is something that probably as a physician we have not been taught to prescribe. We have been taught to prescribe medications, we have been taught to see what the medications are doing and what they are not doing, but we have never been taught to prescribe exercise to patients with obesity. And I think it's important for patients that a doctor gives a prescription of exercise. We may not be able to explain them how to do it, we may not be able to follow every step that they are doing, but it is important to prescribe. Now, I think many bariatric physicians over here are prescribing nutrition, even though they're not exactly telling them how to make them into recipes, but I do prescribe nutrition, how many calories, how much percentage of carbohydrate, how much percentage of protein, how much grams of fibers. This is what I write, and then the nutritionist puts it in a recipe format. Similarly, when it comes to exercise, we prescribe what kind of exercise to be done, and then a physiotherapist or somebody who is a physician's assistant can explain how to do it. So it's important that exercise is part of our prescription, and let's see how we make it. So the agenda is case 1, how much exercise and why. Case 2, what type of exercises. Case 3, looking for balance, posture and flexibility of the patient. And case 4, pre-participation evaluation and assessing the physical fitness before you prescribe the exercise. And case 5, potential harms of exercise. So coming to the case 1, a 34-year-old lady, gained weight during pregnancy, irregular diet and exercise regimen. Current parameters, weight 95 kgs, no comorbidities, hypothyroidism controlled on treatment. I think Neeta Di recognized that's me around 5 years back. So case 2 is 34-year-old gentleman, obese since childhood, gradually increased weight. Current parameters, weight 140 kgs, pre-diabetes, hypertension and moderate OSA. Now these are two cases that person who is treating obesity gets dealt with on and off almost on daily basis. Now the exercise prescription for these two people is going to be totally different, and the aim of prescribing exercises in these two people is also going to be very, very different. So what are the recommendations on how much exercise needs to be done for obesity? Earlier the number was 150 minutes per week, and now it is very clearly recognized that 150 minutes per week exercise is not enough to lose weight. So if you need to lose weight, if you are prescribing exercise to obese people, minimum of 300 minutes per week are must. And that too moderate intensity of exercise. So it's important to note that minimum recommendation, which was earlier of 150 minutes per week, is not enough anymore. It's recommended to exercise at least for 300 per minute to lose weight. So that brings it down to 45 to 60 minutes per day of moderate intensity activity to transition from overweight to normal, and more than that probably for people to transition from obesity to normal weight. So higher is the amount of obesity, higher is going to be the exercise required to lose weight. Now, what is the formula behind it? Generally, we expect people to lose healthily around 0.5 to 1 kgs per week, which requires a negative energy balance of 500 to 1000 kilocalories per day. To lose 500 to 1000 kilocalories per day, a man requires to walk 68 to 136 minutes per day, and a woman requires to walk for 72 minutes to 145 minutes per day, with a pace of 5.6 kilometers per hour. Now, how much? This is the recommendation. Now, imagine a 140 kg man walking for 136 minutes per day with a pace of 5.6 kilometers per hour. This is easier said than done, because even if it's going to cause weight loss, it's going to probably cause some joint degeneration. It is going to probably cause some loss of balance, imbalance, loss of flexibility, muscle stiffness, injuries, and more so. And that's why the recommendations of exercise to lose weight have a big caveat when it comes to obese people. And that is why both nutrition and exercise play an important role in losing weight. Even though I have not mentioned in the slide, weight loss is not a function of exercise only. Nutrition, medications, and probably bariatric surgery are also required for someone to lose weight. This is in general. I'm sure we all have anecdotal patients who do vigorous amount of exercise and lose weight. But in general, if we are talking about somebody who is coming to our OPD and we need to prescribe exercise, we must remember that only exercise, it's very difficult to lose weight. But if somebody has lost weight, then the challenge starts of maintaining that lost weight and not letting the patient regain weight. And exercise is the single most parameter that can be considered as indicator of somebody who will not gain weight. So after you've lost weight with whatever medication, pharmacotherapy or bariatric surgery, if you ask that patient, are you exercising 60 minutes per day? If the answer is yes, there is a very high likelihood that the patient will not regain the weight. But if there is no discipline in exercise, then there is a sure shot indicator of regain of weight with whatever method you have lost. So what are the aims of physical exercise, physical activity and exercise? Modest weight reduction, but very important to preserve the fat-free mass and maintain the weight. Promote cardiovascular, respiratory and health and reduce the cardiovascular risk. And as Dr. Nitin mentioned very importantly, that the mechanical aspects of obesity are very important, and promoting the musculoskeletal health and preventing fall and injury. With 140 kgs, your body is not mechanically empowered to handle that kind of weight. So they have more loss of balances, they have more injuries, they have more falls. So for that, preserving the lean muscle mass to carry on what you have is very important. Physical activity and exercise, these are two different terms. Both are very important, both are useful, but exercise as such is defined as a physical activity that is planned, structured, repetitive, purposeful, aimed at improving or maintaining physical fitness. I go in the morning every day to leave my son to the bus stop is not considered as exercise. Though it is considered as physical activity, it is good for you. Increase in the physical activity level will improve your health. But exercise is defined as something which is purposeful, repetitive, and done with a particular aim to achieve. So this is the most important resource that we have for prescribing exercise, American College of Sports Medicine's guideline for exercise test and prescription. And the mnemonic that we have to remember what we need to include in the prescription is frequency, intensity, type of exercise, and duration or timing of the exercise. So, pardon me for this busy slide, but I'm going to take you one by one through this slide. This is American Diabetes Association guidelines for prescribing exercises, and there are 3 types of exercise that we need to consider. One is aerobic or cardiovascular fitness exercises. Then we have, there is no pointer. Pointer? Yeah, it's showing here, but it's not showing on the slide. Oh, okay. Another pointer. Okay, all right. So aerobic exercise, resistance or strength training exercises, and flexibility and balance. Coming to the aerobic, this is the FIT principle, type of exercise, frequency, intensity, and time or duration. Coming to the first type of exercise, that is aerobic exercise. Prolonged rhythmic activities, very commonly known as walking, cycling, swimming, and may be done continuously, or HIIT is high intensity interval training. Like you walk for half an hour with one particular pace, which will make your cardiovascular fitness go to a level that is expected. Or you can do it 10 minutes as a sprint, walk slowly for 10 minutes, again 10 minutes sprint. So either of it is good. Then intensity, moderate to vigorous. Even though there are so many calculators which tell you that if the heart rate goes till here, we call it moderate. If the heart rate goes till there, it's called vigorous. But now it is very simplified and said that if the person perceives it as moderate to vigorous, we take it as moderate to vigorous. Because what is most important is that the patient needs to continue it. And unless the patient finds it his own subjective description, that is something that is acceptable. At least 150 minutes, but more for losing weight, that is up to 300 or even more. Frequency, 3 to 7 days per week with no more than 2 consecutive days without exercise. Someone is exercising for 5 days, Monday to Friday exercising, Saturday, Sunday off. The schedule is not better that way. Schedule is better, 3 days exercise, 1 day gap, 3 days exercise, 1 day gap. So no more than 2 consecutive days without an exercise. So that is about aerobic. Now, as I said, the timing duration has gone up to 300 than 150, which was previous. Now, these are different types of aerobic exercises depending on the baseline fitness of the patient. If somebody is already walking, he can run. If somebody is already running, he can do marathons or he can do sprints. If somebody has interest, swimming can also be included in the fitness exercises. If somebody is already doing some recreational sports, the recreational sports can also be included in the aerobic exercises. So it's important that the patient continues to exercise, and that is why it's important to identify the baseline level of fitness and the interest in the activities. And according to that, aerobic exercises can be included. Either of the exercises acceptable. Coming to the resistance or strength training, calorie restriction with both aerobic and resistance training has been shown to have better effects in terms of not only weight loss, but improve metabolic parameters, and the strength that is needed for aerobic exercise. So aerobic exercise is like an accelerator of the engine, and strength training is going to strengthen your engine. If your engine is not strong, how much ever accelerator you put in, you're not going to be able to do that. If your hamstrings and quadriceps are weak, walking is only going to cause degeneration of the knee and push you towards osteoarthritis rather than making you lose weight. So before doing aerobic exercises, it's important that you make sure that your muscles are strengthened enough to do the aerobic that you want to do to lose the fat that you have. So strength training is an integral part of exercise prescription. We cannot ask the patient to walk for 60 minutes per day without making sure that he has the required strength to do so. So look, that brings us back to resistance training. We all know resistance training in its typical form of going to gym, lifting the weights or working on the machines, but there are different kinds of resistance trainings that can be done at home. There are different kinds of functional exercises that we know, like squats or push-ups or pull-ups or abs or whatever exercise that you can do with using your own body weight. If you are using your own body weight, it is considered as a resistance to your own muscles. So using your body weight exercises are good forms of resistance training which can be done at home without any equipments, or a small equipment like a small resistance band like this, which comes in form of incremental resistance from yellow to black, can be used to give smaller resistance to the muscles and increase the muscle strength so that we can go incrementally to keep on increasing the muscle strength. So either of the resistance bands or small ankle and wrist weights, or you can have a set of 3 dumbbells, 2.5, 5 and 7.5 kgs dumbbells can actually make you do all the exercises that you would actually go to gym and do. Then brings it back to muscle strengthening for older adults. I am sure if we could have girth of knowledge from Dr. Nitin Kapoor about sarcopenic obesity, which is hugely prevalent in India, especially in older people, where they have good amount of fat but hardly any lean muscle mass. And for that, it's important that elder people who are more than 65 years of age should have some resistance training done every day to make sure that their longevity and cardiorespiratory health is taken care of. Whether vigorous or moderate exercise is better. If vigorous exercise is generally causing low physical activity when you are not exercising, for example, if you do vigorous activity for 1 hour a day and for rest 23 you become sedentary, it's better than you do moderate activity exercise, which will increase the day-to-day physical activity level and improve the cardiovascular health. Coming to case 3 of a 68-year-old lady, well-controlled diabetes since 25 years, but has peripheral neuropathy with occasional loss of balance. She has a history of accidental fall with fracture of hip. So we saw aerobic exercises, we saw the resistance training. Now comes to the exercises that can improve your flexibility and balance. Yoga has been officially included in the American recommendations for improving the flexibility and balance. And this is one of the very important component of exercise. Everybody who is coming to your clinic must be assessed for flexibility and posture before you advise any exercises that can actually worsen the imbalance and the loss of posture. So apart from yoga, flexibility exercises like stretching or balance exercises like working on one hand or one leg are important. There are certain exercises that can include all of this together. Functional trainings, or there are coaches who can include all of these exercises together and give you a routine of an hour or so, which includes aerobic, resistance training, as well as flexibility and balance training. So functional training courses which include all of this are also good. We don't have to write separately this much of aerobic, this much of resistance, this much of flexibility. The whole thing can be combined together and a program can be designed accordingly. There are components, of course, we don't ask them to go to gym and start lifting the weight. There is warm-up, there is conditioning, there is cool down, there is stretching. There are details of this. We will not go into them in the interest of time. But the concept that also needs to be used in your prescription is progression, because once somebody gets accustomed to a particular level of physical activity, the basal metabolic rate is again going to get adjusted to that level and further weight loss is stopped. So it's recommended that there is a 30% increase in either intensity or duration of exercise every 3 to 4 months after you become accustomed to a particular set of exercises. Coming to case 4, a 52-year-old gentleman, hypertension on medications and complains of mild dyspnea on exertion. What do we evaluate before we give an exercise prescription? Again, there are detailed guidelines about what all needs to be tested. Earlier, the guidelines were more strict of categorizing patients with low, moderate and high, but now exercise is considered so important that this has been relaxed totally to the new American College of Sports Medicine guidelines, where individuals' current level of physical activity has been considered the most important parameter. If the patient is already physically active and he has no symptoms, there is no need of a physician's clearance or a physician's intervention to give a clearance for any kind of physical activity. Diabetes, though, has considered as one of the risk factor, and if the patient is extremely sedentary, a pre-exercise evaluation in details about cardiovascular as well as musculoskeletal fitness is important. Now, all physicians here, they know what to do, what stress test or stress echo or whatever. You are all experts in knowing whether the patient is physically fit or not. But what needs to be assessed is a fitness for assessment for the physical fitness. What kind of exercise the person that is coming to my clinic will be able to do, depending on which I will be able to prescribe a particular type of diet. So this is a very simple test where you ask the patient to get up from the chair and sit down for 5 times consecutively and see how is the posture, how much time does the person takes to get up and sit, and what is the level of cardiorespiratory fitness that he has. And depending on that, we can prescribe a mild, moderate or vigorous exercise regimen. One of the important method of testing the imbalance or flexibility is standing or maneuvering on one leg. If somebody can stand on one leg, see if he can squat on one leg, and then the exercise prescription can also be decided. Some other tests like, are you able to touch the toe, are you able to squat, or are you able to do the plank? So these are very simple tests that I do in my clinic, ask the patient to do this, assess what the patient is able to do, and then prescribe the exercise according to that. Assessing the posture is very important. The sedentary people who sit for a long period of time throughout the day, they have this anterior pelvic tilt, which is essentially a result of very weak quadriceps and very tight hamstrings that happens when you are sitting for a very long period of time. And correcting this before any exercise, correcting this before giving any exercise is very important, because if somebody walks with an anterior pelvic tilt, it's further going to cause the pelvic tilt to go higher, because the quadriceps are going to be weak and the hamstrings are going to be tight. So we first need to strengthen the quadriceps, release the hamstrings, correct the pelvic posture, and then go ahead with the exercises. So Pilates is one of my favorite exercises which correct the pelvic tilt and provides the essential core strengthening to go ahead with the exercise prescription that we'll be providing. Potential harm, we know gym deaths are happening at a very large intensity. People know exercise is very important, and मराठीत जसं आपण म्हणतात की ऊस गोड लागला की मुळासकट खाण्याची आपल्याला एक पद्धत असते. So exercise is good, so let's start exercising. One sudden day somebody decides tomorrow I am going to take part in marathon, or tomorrow I am going to go to gym and lift 120 kgs of deadlift. So baseline physical fitness is directly related to the habitual frequency and relative risk of acute myocardial infarction. Lower is your regular physical activity, higher is the chance that you will have acute myocardial infarction if you do an unaccustomed exercise. Again, a possibility of baseline cardiomyopathies which can progress because of unaccustomed exercise is also high. Wearable devices, they are useful for people who need an external motivation to do what they're doing and keep a watch on what exercise they need to do. So this is an example of my electronic medical record of how do we prescribe an exercise to a given person. So this is a person who is more than 100 kgs, has absolutely no discipline regarding diet and exercise, is extremely busy. I should not say the name, but he's a minister and he doesn't have time for deciding what he eats, doesn't have time for exercise. So the first thing we did was to start him on intermittent fasting. Tell him to eat, you are supposed to eat only this 8 window period. What you eat, we'll see. Ask him to come back after 15 days, write down whatever he is eating. absolute no exercise and extreme amount of anterior pelvic tilt. So we decided we'll start with only 20 minutes of exercise that will strengthen the core first. So bicycle crunches, Russian twist, sit-ups, one leg bridge, 20 reps, 2 sets, 10 minutes Surya Namaskar. Make a video and see how the posture is getting corrected. Gym or swimming when possible. Then again, this becomes monotony after some time. So how do we break the monotony in exercise? You can't go to gym every day and do the same set of exercises every time. It gets bored. So there are also times, studies that are showing that in winters is a time to gain muscles and summer is the time to lose fat. So swimming is a very good exercise during the summer times, and going to gym will make effective muscle building if you go to gym in the winters. So that kind of exercise break the monotony, muscle strengthening in winters and swimming and fat loss in summers. And when it rains, people don't want to go out, indoor Pilates can come in very handy. So with that, I'll come back to the summary where we started. For case 1, how much exercise? More the better for obese people, but it is difficult without strength training. So strength training is must. Balance and flexibility, yoga, I am sure Nitin Patankar sir is going to elaborate in deep how yoga is going to be useful in these patients. Assessing the physical fitness and then prescribing a safe exercise regimen is probably one of the most important responsibility that physicians have today. With that, I would like to say thank you to Khare sir and Nitin Patankar sir to have me to talk on this topic.
Thank you. I'm orthopedic surgeon, so I would ask one practical question. Do you consider the patient showing app, we are walking this much step every day in your when you prescribe exercise?
Yes. So that's why I wanted to make sure that we understand the difference between physical activity level and exercise. So if the 10,000 steps are occurring because of an increased physical activity level without it being purposeful, without it being directed or aimed at a particular target, then that is not considered as an exercise, even though it is encouraged that they are moving around, they are moving away from sedentary life is what it will mean. But it will not be considered as an exercise if they are not doing it with a purpose, sir.
Second is for osteoarthritis knee, so mostly they are senior citizen. So what is most common question they ask you, how much we should walk?
As I said, sir, if there is any signs of osteoarthritis, walking without strengthening the quadriceps is going to further degenerate the osteoarthritis. And that is why it's important that they first build up the core muscles, that is lumbar muscles, rectus muscles and the erector muscles of the back, which will hold your weight when you are walking. And then you need to release the hamstrings and strengthen the quadriceps, which will also help to reduce the mechanical weight that comes on the knee when you walk. So osteoarthritis patients, first a few months of resistance training, muscle building of the core and the quadriceps, and then they can walk.
Yeah. So my practical answer is when they walk, and everyone has different strength because you said their cores. So when they get fatigue of quadriceps muscle, at that time they should take a break. And then again they can walk. So we encourage them to walk immediately, but as a muscle strength is less, sometimes they walk 5 minutes, then they sit. And gradually with the strength, it increases. So whenever they get fatigue, they should sit down. You are right, when there is fatigue and their muscle is not holding the knee and they walk, then there is the regeneration.
Right.
So this is...
So even 10 minutes of quadriceps exercise before they start walking improves the muscle strengthening. So if they are walking for 30 minutes, I would say 15 minutes spend on quadriceps strengthening before starting the walk, and walk for 15 minutes rather than waiting for muscles to fatigue.
Correct.
Yeah. Thank you, ma'am. Thank you so much for your... No, please wait.
Sorry.
Thank you for...
Somebody sent me a message that time is up and you need to get down. Sorry.
Thank you for introducing my specialty so well. That is sports and exercise medicine. And just 2 points. If you want a one-stop solution for all this, what ma'am has talked about, send them to a sports and exercise medicine specialist. We are a small fraternity, but we do exist. Okay, sports and exercise medicine physicians. That's number 1. Number 2, whenever you want to do any exercise prescription, whatever is your goal, please remember exercise intensity is your friend. you play around with intensity, you can reach your goals much faster and much quicker. Yeah. Thank you, ma'am.
Thank you, sir.
Thank you so much.
Thank you so much.
In fact, a very important message. Anup is one of the minorities. In fact, that's why I took the liberty of inviting him. So, this exercise physiology and sports medicine is one of the most underrated specialties. We definitely want you on our panel. We'll be talking to you. And
Sure, absolutely.
Anup, are there any short courses for physicians like us? Like we can't do a full-fledged MD or something right now. So if you have something, do let us know. We want to include it. We would like you to make some modules for us for BAPI also.
Not a problem.
Because I feel that's most important.
Not a problem, sir. Anytime.
So Siddharth, a question to you. Like, as a obesity specialist, I mean, you send me a lot of patients and all that. So the thing is, have you actually seen a patient with OA avoid surgery after significant weight loss?
Yeah, in fact, for moderate OA, if they lose 10% of their body weight, their pain goes down significantly, 50% or maybe more. So, if they can reduce significantly, especially the moderate stage 2 or 3, less than bone, not bone on bone, they can delay the surgery many times. Yeah.
Delay or avoid?
They cannot avoid it over the period, but it's a delaying, it's a degeneration. So it's time buying. You can delay it. The osteoarthritis can be delayed. The surgery can be delayed, but avoiding it, I can't comment because it's a progressive disease.
Anjali talked about exercises, strength training, flexibility, and cardiovascular exercises. May I be brave enough to recommend something? We know something which involves all three. Yes. Plus which is fun and which also gives a self-defense. I think kickboxing is one of the most beautiful exercises. So it combines absolutely everything. And this nation has suffered for centuries because of stupid things like non-violence. I think it's time we really knew how to defend ourselves. Our history and geography would have been different.
There is a lot of hype about this soleus exercise.
Sorry?
Soleus muscle exercise.
Soleus muscle exercise.
Yeah. Can you elaborate on that?
So, isolating a muscle is a science that is coming up. I agree that they're understanding the different methodologies to isolate a particular muscle and then build it. But it is more recreational, or it may be more from the physiotherapy therapeutic point of view, rather than overall fitness to isolate a particular muscle and then increase its exercise or activity. I would probably not.
Because they claim that you can get a lot of weight loss with that.
So may I answer that? I think you're talking about static soleus resistance exercises. In the context of a sedentary person who is not able to do any other exercises, so yes, it's a very good thing because something is better than nothing. But as an only exercise for weight loss, no, then I will not recommend that. But if it is something which he can do only that, so yes, let him do that.
So will it not be okay for the person who is not at all on some exercise, he starts with soleus exercise and go gradually?
Sir, when you talk about exercise prescription of a person who has not been exercising, after a proper pre-participation physical evaluation, he's generally started on aerobics. And then only he proceeds to resistance. So initially, a sedentary person will start with aerobics only.
Particularly the patients who are not fit for any type of exercise, particularly with the cardiac patients.
No, we are not talking about cardiac patients. We are talking about sedentary individuals. Yeah. Now, when you talk about prescription for cardiac diseases, that's an entirely new or entirely different ball game. So there the things will be different. Now, for a cardiac rehab, you have to prescribe exercises which do not increase the heart rate in several cases. So there is only one exercise in the world which will not increase your heart rate, going downstairs. But so that you have to, mix and match and pick up according to the patient. Yeah.
Is there any particular thinking behind starting with aerobics and not resistance training?
Yes, ma'am. Because you have to improve the cardiovascular fitness first before you think of improving the resistance. So, and aerobics has to be a component, warm-up, aerobics. And
of
then,
course,
yeah.
Of course.
Like that literature you talk about VO2 max and all sorts of, do you have that sort of a lab?
Yes, there is one lab in Sir H.N. Reliance Hospital. There is one lab coming up in Deva Patil Hospital. And a couple of centers are coming up. Yes.
Shall I get down, sir?
Thank you, ma'am. Thank you very
Thank
much.
you so much.
May I request Dr. Rajesh Patil, sir, to give a memento to our moderators and speakers.
Anjali.
Now, our next topic is Yoga in Obesity. I request Dr. Sandeep Rai, sir, to come up to the stage. As we don't have his CV right now, I'll just share a few lines about him. He's a professor and unit head Department of Medicine at MGM Health Science, in charge of Diabetic Clinic at MGM, senior consultant diabetologist at Apollo Hospital, Navi Mumbai.
Let me first thank
Dr. Khare sir for giving me this opportunity. It's a wonderful opportunity to be moderating a session on yoga, and my pleasant duty to invite Dr. Nitin Patankar, who is a very well-known figure in this field, to kindly come and deliver his presentation.
So after the lecture on exercise prescription, I'm going to talk on obesity and yoga. And I am trying to present some different views on yoga or yoga. So this is the agenda. I will first describe what is a Western view of yoga, then Indian view and understanding of yoga. Yoga is not just exercise, it's basically attaining, the aim of yoga is attaining hope, happiness and contentment. That is the aim of yoga. Then novel ancient concept. Why I'm calling it novel? Because it's less known or less believed, but it's an ancient concept of chakras and how it is useful and validated in modern medicine. Then there are different chakra colors. This is again a very novel concept that it has been described that every chakra has got some colors, and I will describe it, how it fits into and how it is proved in modern medicine. Then asanas for chakras. Then some evidence in modern medicine, and then a small note on dharana and dhyan, which is part of yoga. So this is how I am going to proceed. So Western view of understanding of yoga, basically its mechanism by which yoga may assist. This is again presented in American Journal of Lifestyle Medicine. What they mention is mechanism by which yoga may assist in weight loss or maintenance includes the following. It says it causes energy expenditure during yoga session, allowing for additional exercise outside yoga sessions by reducing back and joint pains, then heightening mindfulness, improving mood and reducing stress, which may help to reduce food intake, and allowing individuals to feel more concerned to their bodies, leading to enhanced awareness of satiety and discomfort of overeating. So this is how they place yoga related to obesity or metabolism. Thus, yoga appears a promising way to assist with behavioral changes, weight loss and maintenance. So this is a very mechanistic approach of yoga. So yoga is basically, according to Western science, is involving three things: asanas, pranayam and meditation. That is the dhyan and dharana. So let us look at how Indians look at yoga. So these are the three components of health. Basically mental health with quality of life and performance at mental level. Secondly, performance at the physical level with heart, lung, muscle joints, and sex. And thirdly is a metabolic health where we can measure all the parameters like BP, HbA1c, lipid, and body fat. All these things in combination should give hope, happiness, and contentment. These are the main strengths of yoga. And this is how India looks at yoga, or traditional Indian teachings of yoga. So it involves basically 8 steps. Everybody knows that it is called as Ashtanga Yoga, means 8 steps. That is Yama, Niyam, Asan, Pranayam, Pratyahar, Dharana, Dhyana, and Samadhi. If you look at Yama, Niyam, they are more related to your lifestyle. What you eat, what you should not eat. And I will give you one small example. There is a Yama called as Ahimsa. So Ahimsa is not what Sanjay was mentioning. Ahimsa is not to harm yourself, because yoga is basically very individual, very personal. So don't do anything or don't avoid anything which can cause injury, and in which various diets are mentioned, that don't eat this, or do eat this, because it should protect your body or it should not cause any injury to yourself. So 5 yamas and 5 niyamas are presented, which is very individual and not for a social life. So let us come to novel ancient concept of colors and chakra, its positions and functions. So these are the 7 chakras. If you have heard of this, it's called as Mooladhara chakra, Swadhisthana chakra, Manipur chakra, Anahat, Vishuddhi, Ajna, and Sahasrara, or it is described in English literature: root, sacral, solar, heart, throat, third eye, and crown. Now look at the colors. Basically, it is described as root chakra has got a red color. Then Swadhisthana chakra is orange. The Manipur chakra, or that is around your belly, it's considered to be yellow. Then heart chakra is green. Then you come to shades of blue. So you have blue, purple, and those shades. Now, this is a picture. It is starting from core of the earth to space. So when we talk of root chakra, it is described that it is presenting earth element. So it's a core of earth, which is red. Then if you come to next crust, it is orange. Then you come to next crust, which is yellow, that is the soil. When you come to surface of the earth, that is related to heart chakra, which is green. Then you come to sky, which is blue, and then the purple shades go up. So the body is represented as a complete universe. And there is a concept called as Pindite Brahmandi. So basically yoga is union of all these things. Then there were a lot of years where this concept of chakra was like jested upon or made jokes of. I have heard one Western scientist mentioning that because you do Kapalbhati, there is a lot of loss of carbon dioxide, you get hallucinations, and in those hallucinations your rishis, sagas must have dreamt of these chakras. Now in 2012, this is a lady called as Dr. Candace Pert, who was working on opium and its receptors, and she was the first person to describe there are definitive sites on spinal cord and brainstem which has got very high densities for receptors of emotions. So she called them as molecules of emotions and nodes of emotions, and those nodes of emotions that she has proved exactly match the sites of chakras which are described in yoga. So first is the physical presence of chakra was not found out because these are not anatomical structures you cannot find with dissection. It is basically the receptor densities. Secondly, as I mentioned about chakras, I have shown you a picture of core of the earth to sky, but that is not all the proof. Let's see the real magic. So I will first describe in little detail about that root chakra or Mooladhara chakra, which has got red color. Now, recently, the American Association of Nutrition, they are mentioning that there are macronutrients which involve protein, carbohydrates, and fats, which are involved in diet planning, but there is a huge gap of phytonutrients. So how to plan diets in obesity is one is macronutrients and one is micronutrients. So these phytonutrients have known pleiotropic effects on cellular structure, function, and ultimately resulting in modulation of protein kinases and subsequent epigenetic modification in a manner that leads to improved outcomes. This is by a review article, open access volume in this journal. So now they are talking about micronutrients, but basically phytonutrients, and there is a concept of colorful diet or a rainbow diet for managing micronutrients, and which fit exactly with the chakra system of colors. So diet planning with yoga. So National Health and Nutrition Examination Survey conducted in 2003 and 2004 found that 8 out of 10 Americans fall short in every color phytonutrients, and that they call as phytonutrient gap, especially in the color category of purple, blue fruits. If you recollect, it's basically starting from your throat chakra, Ajna chakra, and Sahasrara chakra. So there is a lot of gap in these phytonutrients, and I will describe you how they are useful. So diet planning, phytochemical index is a new concept that has come up, and it is relatively recent term introduced in the cited scientific literature by McCarry in 2004, and is defined as the percentage of daily calories derived from foods rich in phytonutrients. So this is a concept of phytonutrient index. Now diet planning, over the years, several opinion leading health organizations such as American Institute for Cancer Research, the American Heart Association, the USDA Food and Nutrition Services have advocated eating of rainbow diets that I mentioned. Now let us come to the description of root chakra. Now root chakra is basically at the coccyx or at the tip of the spine, lowest spine, and in yoga literature, they are describing symptoms of root chakra as shortness of breath. Now you will wonder why they are describing something which is related to lungs or heart, but they have mentioned that shortness of breath, sweating, fatigue and lethargy, cough, frequent colds and flu, allergies and asthma, dry skin, large intestine and canal problems, anemia, knee and below knee problems. So these are basically symptoms if the root chakra is affected. Then, what are the organs involved in root chakra control? That is lung, large intestines and kidney, nose, skin, bones and cortex, pungent and sweet tastes, which are again, when we are planning a diet, we never think of planning diet according to tastes. We think of only carbohydrates, proteins and fats. But as I said, yoga describes more colors, what phytonutrients you can use and what taste you can use. And the yoga description that root chakra controls the emotions of grief, sadness, detachment, depression, excessive crying, insecurity, lack of abundance, loneliness, failure in connecting with people and networking. And what are its functions? Works with kidney to regulate water metabolism. So root chakra basically connects with kidney, and we get a lot of patients with like undiagnosed edema. Importance in immune function, resistance to viruses and bacteria, and regulate sweat glands and provide moisture to the skin. So red foods and inflammation, high in antioxidant red fruit carotenoids, astaxanthin and lycopene. I will just go through it because Sanjay is showing me that you have to be fast. So root chakra, the red color, and these are the phytonutrients. This all list of, these are the red phytonutrients, and this is what is described as what they do. They are anti-inflammatory, general antioxidant activity, and immune modulation. If you remember the yoga description of root chakra, what I described, these are exactly that is done by red nutrients or red phytonutrients. Root chakra has got red color and the taste which I described. So tomatoes, reduction in inflammatory markers, reduction in postprandial inflammation, and improvement in lipid markers. Secondly, you have strawberries, reduction in postprandial inflammation, reduction in pain due to osteoarthritis, and again beets. And I will describe that even red color, there is something called as a color index. So there are different kinds of color shades which these phytonutrients have, and they have got different functions. So I will go to next chakra, that is sacral chakra. Now sacral chakra is basically creativity chakra. It is basically related to sex organs. Now look at this yellow color, and antioxidant for fat soluble issues, endocrine modulation and role in ovulation and fertility processes, which are the functions attributed to yellow colored phytonutrients, which is controlled by sacral chakra and which is basically controlling the same organs, and it has got a specific test. So wild yams, again, increases in estrogens and estrogen metabolites, phytoestrogenic activity. Your carrots, we know just carrots about eyes, but carrots can decrease in rate of breast and prostate cancer, phytoestrogen activity associated with estrogen metabolism. And you have got orange fruits, which can delay ovulation, senescence, lower the risk of endometriosis. So again, coming to solar plexus, that we know, this is what obesity or organization is. The solar plexus is basically spleen, stomach, pancreas, liver, gallbladder. These are the organs involved. And if you look at the functions of yellow foods, antioxidant, enzymatic activity, gastric motility and regulation, reduced glycemic impact, role in fostering of healthy gut microbiota. These are the functions of yellow food. Solar chakra described as yellow color, and these are the food: ginger, citrus, pineapple, bananas. You can look at the functions on left side. Similarly, you come to heart chakra, which is green in color, which is again regulating your heart function, thymus function, lung function. And there are various emotions. Look at the green food functions. Antioxidant, it supports blood vessels, it supports role in healthy circulation and methylation. Again, these are related to heart chakra, green color, and so leafy vegetables and cruciferous vegetables. So you have to method of diagnosis of which chakra is affected, and you can plan diet accordingly. Similarly, you don't have all asanas for all. Similarly, there are 7 kinds of pranayamas which are described for each and every chakra. Similarly, there are something called the petals for chakras. So root chakra has got 4 petals, then that Swadhisthana chakra, that is 6 petals, 10 petals. So last 10 years I am working on this, and these petals are nothing but rhythms. So there is a concept of binaural beats. When you chant, there is binaural beats are created, and these are the beat frequencies which are described with these chakras. So there are different asanas for different chakras. So this is for Swadhisthana. So these are some of the reports. So I'm just going through. So the 12-week yoga intervention had moderately strong positive effects on anthropometric and self-reported variables in women with abdominal obesity. Similarly, effect of continuous yoga on body composition in obese adolescents. Again, the conclusion is continuous yoga practice has a tendency to decrease BMI, body fat mass, and increase muscle mass. 12 weeks of yoga and nutrition advice. Again, the results are, they are all shown positive results, and if you do it continuously, it has got tremendous benefits. Then I will just go through Dharana and Dhyan, which are basically, it's not meditation. If you read Dean Ornish's book on reversing heart disease, there is a concept that you hold the image in meditation. And if you can hold the image or hold a concept in your brain, it is translated into your body. And that is called as Dharana. Dharana is Dharun Temna. You hold that concept and then focus on that, it is easily translated into your body. It is something described as an architect which gives a plan, and then all other people come and actually execute the plan. So body executes the plans, and that is basically Dharana and Dhyan. So I think I am finishing in time. So agenda, what we have seen is Western view, Indian view. Yoga is attaining the goals are hope, happiness and contentment, and which is basically when we are talking about obesity or diabetes, unless this is attained, the things never remain permanent. Then concept of chakra, colors and diet planning, asanas for chakras, some evidence I have shown, and Dharana and Dhyan node. So thank you so much for listening to this very different topic.
Thank you, sir, for such an enlightening talk, and I think it's so nice to hear that you are working on yoga in such, such deeply. And Dr. Kharevan talked to me about coming to this session. Basically, I'm into researching on Sahaj Yoga, that is basically dealing with meditation aspect. And he asked me how it will help in obesity, because we are of the opinion that when you are walking aerobic or even Kapalbhati and things like this will help you. But then when I reflected on it, then basically the thought came in my mind that when you have a picture of a yogi sitting somewhere in Himalaya, so I've never had a picture of a very, plump yogi or a heavy fat yogi sitting there. They're always very lean and thin people sitting. They hardly have access to food. And then there was a saying I came across on Twitter that if you are a yogi, you eat once a day. If you eat 2 times a day, you are a bhogi. Bhogi means you are an indulgent person. And if you eat 3 times a day, you are a rogi. It's that you are a diseased person. So the psychosomatic effects of meditation, which we have studied scientifically also, we have MD thesis right from last 25 years. My father was the head of department at JIPMER and then at Lady Harding, physiologist. So we did these studies on meditation, yoga, on Sahaj Yoga meditation, and we found a lot of physiological effects. And then we did on the psychic effects, and we found that it decreases your anxiety, depression. And if you see very closely, obesity, why a person gets obese, is the behavior. The food excess is almost same to everybody. Why somebody eats more? Obesity is mainly overnutrition. Exercise, everybody is doing almost same. Somebody is walking 30 minutes, some maybe 25 minutes, some maybe 45 minutes. That will not decrease your weight. May make your insulin resistance better, not decrease. It is your overeating. And once you start meditating, it causes behavior modification. Satiety starts coming, and the carnal pleasures of the primordial desires go low, like, excessive hunger, sex, all these desires go low because you start experiencing higher pleasures. Higher pleasure in the sense that kind of thing where when you start attaining that higher consciousness or start connecting with the higher consciousness, you are not too much bothered about eating too much or, traveling too much or materialistic desires, all these things go. So there is a great element of behavior modification with meditation. Apart from that, there is a physiological thing going on. We did this study at MGM Institute of Health Sciences. My own PG student, now consultant at Nanavati, he was an MD student with me. I said, will you work on Sahaj Yoga and the physiological effects? He said, yes, sir. And we showed that cortisol levels in those people who were meditating for more than 5 years, much lower than people who were not meditating. Cortisol is that hormone which everyone knows gets released in stress, and that gets your fat deposition, you get obese, you get hypertensive, and so. So physiologically it is helping you. It is getting less of depression. There are hundreds of studies on this kind of meditation which we are doing internationally, which have shown that depression, anxiety goes down. One type of obesity you get when you are depressed, you are eating. One type of obesity you can get when you are anxious and you are eating. The other is totally, we know, you eat, your depression becomes better. The third is overall satiety, as you had shown in your thing. Happiness, satiety, and, contentment. All you start achieving. So Dr. Khare and we were discussing that once he told me that you come to this obesity symposium, I said, sir, I'm more involved with the meditation aspects of the yoga. So you call people who are doing Ashtanga yoga, that will help. But then I reflected that people are getting obese because they are not able to change their behavior. And to change the behavior, the best thing that you can do is meditation, which will take you away from, give you satiety, give you contentment, give you, and give you that focus and resilience and that, that thing that the urges you can control much better. So these we have seen in certain in the studies also, and I think that is what you have also said, sir, as all these things can encompass. So this is the way I think meditation may help. Thank you, sir.
Now I invite Dr. Sanjay Khare, sir, for the mementos to give the moderators and the speakers. Now we are proceeding with the next topic, present and future of pharmacotherapy, anti-obesity medications. I'm calling Dr. Rajesh Shinde sir and Dr. Vimal Pahuja sir as a moderator on the stage.
So we are into the next deliberation, Dr. Nitin Kapoor on pharmacotherapy. It's a very relevant topic for clinical practice because we want to understand how we are going to use those medications which are there and which are going to follow now in our patients and help them better to control the weight and obesity. So over to you, Dr. Nitin.
Thank you, sir, and then happy to be back again. In the next 15 minutes or so, I shall try and keep it really short, but what I will do is I'll cover this topic of anti-obesity medications, and I will can I have the slides. Yeah, so we'll take you through this topic, and what I would do is cover this in 5 very brief domains. We'll talk about why we need anti-obesity medications in our day-to-day practice today. What are the different classes of drugs which are available? What is their target of action? And what is the evidence to support that we can use them? Also talk about the newer anti-obesity agents. And there was a lecture in the morning which covered about GLP-1 RAs very well. We'll talk about the indications of treatment. And it's not only just starting therapy, as we learned that obesity is a chronic disease, how we follow up these patients. And just before closing, very briefly talk about the role of newer drugs which target specific genes and role of genetic testing in patients with severe obesity. So starting with the first topic and talking about the anti-obesity drugs, why we need it. I think we all have heard this all along in the morning. Obesity is definitely a big problem globally. Even in India, we talked about 35 to 40% of our Indian population. This is something that we published 2 years ago. To complicate things further, we know that our Indian phenotype is very different. Despite not having severe obesity, we may have very different fat distribution. Our obesity cutoffs are different, and we also have this phenotype of normal weight obesity. So all this is quite sad to look at, but the good thing is that over the years, our understanding of obesity has also improved several fold. We no longer consider obesity as just somebody's choice. It's a biological problem, it's a medical problem, it's a chronic problem. And today we understand that there are alterations in the hormones in the hypothalamus which reduce appetite, which increase appetite. Their discordance increases obesity. This coupled with adipocytokines, the gut peptides, which play a very important role. And this overall total club together with the environmental, behavioral, and metabolic aspects leads on to obesity. So with a better understanding of pathogenesis of obesity, definitely our understanding of pharmacotherapy will also improve. And this takes me to the second aspect as to what are the different targets of obesity that are available. I think all of us are well aware of omnious octet of diabetes. When I was a medical student, we just had a traditional triad which talked that diabetes happens because of reduced insulin production, insulin resistance, and hepatic glucose production. But today, we know that there are 8 different organs for diabetes, and very similar to diabetes, there's also an omnious octet described for obesity. But probably obesity at this point in terms of pharmacotherapy is the way diabetes was maybe 2 decades ago when we just used to prescribe glibenclamide. Metformin was also hardly there. We just had 1 or 2 drugs. But today we have 8 different targets, 8 different medicines that are available, and similarly for obesity. We have, at this point, only 5 drugs approved by the US FDA from an Indian point of view, and this is from the recent guidelines by the Endocrine Society of India. We have liraglutide, which is not approved for obesity, and we don't have 3 milligrams. We have orlistat, which is approved and available. We have semaglutide 2.4 mg, which is approved but not yet available. So we don't have the other 2. So that's the sad story, but the reason is that over the years, so many anti-obesity medications, some which we have used, have gone off the market, and US FDA is very strict about approving any new medicine for obesity. So for any new medication, US FDA has kept a target that they should have at least 5% weight loss in 1 year. The last US FDA approved drug was only in 2014, and semaglutide has come now, and tirzepatide is likely to get a fast track approval. So of the 5 drugs, 2 which are available in India, we don't have the 3 milligrams of liraglutide. Let's talk about orlistat a little bit. It was mentioned in the morning. Yes, it is available. 60 milligrams or 120 milligrams are the 2 strengths, given twice or thrice a day. So if you ask me whether this drug works or not, when you look at the clinical trial evidence, maybe around 3 to 5 kgs benefit, but I think it practically works only in that subset of people who have at least 20% of their calories from fat, and does not work in everyone. So there are certain communities, there are certain patients who are unable to reduce the amount of fat in their diet because of their familial practices, and in those patients it may help in some weight loss, but overall it's a very weak drug. Liraglutide, some of us at least in the room I know were involved with the SCALE trial, and we don't have 3 milligrams at this point. Again, I think weight loss is to the scale of 3 to 5%, but maybe more for weight maintenance in my clinical practice than for weight loss. But the science of GLP-1 analogs has really evolved a lot in recent practice. We talked about the ominous octet of obesity, and I think the brain as well as the intestine are the 2 big targets that really help GLP-1 analogs work. When we compare this to the other drugs that are available, yes, these are very, very powerful. And this takes me to the third aspect of my talk, talking about the newer anti-obesity drugs which are available or likely to be available. This is a paper we wrote actually 1 year ago, and still we see that a lot of these drugs are either in different stages of development. It was in 2021, March, this NEGM paper published the step 1 results. First time in the history of obesity, we saw results of 15% weight loss. Thereafter, we've seen step 2, step 3, step 4 trials. As we heard in the morning, this drug is not yet launched in India because the global demand is so difficult to meet. This has been a big hit. Talking about tirzepatide, another drug which is there in the US market at this point, approved for diabetes management, even better weight loss, 21%, something in the realm of bariatric surgery. Combining a pramlintide or amylin analog like pramlintide, cagrilintide with semaglutide. Again, if you look at the phase 2 trials, the weight loss is 15 to 20%, but even after 1 year, the graph shows that if we follow them up longer, there will be more weight loss. Very recently, I believe yesterday, we've taken up this trial. So there are oral GLP-1 receptor agonists, which are non-peptide. So we know the peptide agonists, which are semaglutide, but a non-peptide. So it's even easier to take it as a pill. This is coming up. The phase 2 results, again, especially in non-diabetic people, are fantastic. So I believe there are a lot of drugs in the pipeline that are helpful, but whatever is getting already available in the Western world seems to be very effective. At this point in India, what we have is oral semaglutide, not approved for obesity management, used for diabetes management. Weight loss is to the scale of about 5% or 5 kgs. Some of my patients who are already on liraglutide, yes, we can directly switch them at higher doses. But what I'd like to mention is the same drug used in another trial called Pioneer Plus trial, which is just, I think, getting concluded. We were a part of it. There was no placebo in the trial. It's using the same oral semaglutide, which is available in the Indian market as 3, 7, and 14 milligrams. In this trial was used as 25 and 50 milligrams. And believe me, not only in our center, but all the sites in India where this trial has been done, patients have lost significant amount of weight, 10 to 15 kgs. So yes, a higher dose of oral semaglutide is helpful. Talking about the side effects, I would say it's more of idiosyncratic. If my patient did not tolerate it in first month, they did not tolerate it ever, but those who tolerated really did very well. So this is in short about the drugs. But what's also important to know is how we initiate drugs. When do we initiate drugs and how do we follow up these patients? And I think more and more global literature, when we talk of obesity management, has moved away from just looking at BMI as an important marker to assess obesity. Today we tend to redefine obesity as beyond numbers, and one easy way to do that is by using the Edmonton obesity staging system. It does not require any hi-fi expensive equipment. It's a clinical staging system wherein if I may have a patient in my OPD who may have BMI of 35, but severe osteoarthritis of the knee, the lady cannot even get out of the wheelchair, I would directly put her as stage 3. I may have somebody with a BMI of 40, much more heavier than the previous patient, but may have just pre-diabetes. I may just classify that patient as stage 1. and therefore these clinical staging systems are easy. They have been shown to follow up that when we follow up these patients for as long as 2 decades, the Edmonton Obesity Staging System seems to predict mortality of patients much, much better. And in our clinical practice, we do find a lot of these patients who are in stage 2 and 3. And again, as per the guidelines of the Endocrine Society of India, the stage 2 and 3 is somewhere where you should consider medical management. In our clinical practice here in Vellore, you see that about 70% of patients actually fall into Edmonton obesity stage 2 and 3. So in my practice, I would never start a medical therapy on day 1. On day 1, when my patient comes for obesity management, it would predominantly be lifestyle therapy. The dietitian, the physiotherapist, the other comorbidities are addressed, and we ask the patient to come back after 3 months. When the patient comes back, and we are talking about this in the morning, talking about the shouldering effect, when the patient comes back, says, "Doctor, I've lost about 3 kgs, 4 kgs, 2 kgs, and it's not coming down further." And I think that's a good place to add either a meal replacement or medical therapy. But as like any other chronic disease, we need to follow up these patients very regularly. And like in diabetes, if I see a patient who's got an A1C of 10%, I start on medicines. In 3 months, the A1C will be normal, but that doesn't mean that I stop the treatment. The treatment goes on lifelong, gets altered all along, and that's what's recommended for people with obesity as well. So they need good follow-up, even if they are losing weight. There used to be a significant proportion of patients with the previous drugs who were resistant, who wouldn't lose weight. What is the definition of resistance obesity? Anybody who's not losing more than 5% of weight with the drug. But with the current drugs, I think the resistance levels are much low. Morning, this question was asked. So with semaglutide, only 14% are going to be resistant. With tirzepatide, only 9% will be non-responders. Most of your patients should respond. But again, a very commonly asked question in most conferences, once we start these drugs, are these drugs going to be continued for a short time? Probably not. They are lifelong drugs. Just before I close this section, I think another very important topic that we need to tell is that it's just not about giving the anti-obesity medicines. We also look at the comorbidities. We look at the patient with diabetes. So if there's sulfonylurea, I'd like to get rid of that. I'd like to use a drug which is either weight neutral or something that causes weight loss, not only for diabetes, hypertension, contraception. Morning we were talking about antidepressants. So we try and choose the weight neutral or weight losing drugs. If we ourselves cannot do it, we request the specialists handling that to try and give the weight neutral drugs. Again, psychiatric problems are big in this population. And so it's very, very important to look at the comorbidities of the patient and at least choose the weight neutral, if not the weight losing drug. And with this, I move on to the last aspect of my talk, talking about genetics in obesity. And there's always this debate, is somebody obese in the family because nobody runs in the family, or obesity runs in the family? And a lot of data has shown that there is a strong genetic component to obesity, especially added over with consanguinity that happens, especially in the place where I practice in Tamil Nadu and Andhra Pradesh. There are genetic mutations in patients with consanguineous populations. When we looked at our own data from Vellore, in young onset severe obesity, about 16% have genetic mutations. It's become much easier to do this because with the NGS, the cost of these mutations, we do a 35 gene panel for 10,000. But why are we talking about so much of genetics today? Is because there are newer drugs which specifically target patients with these mutations. Drugs like setmelanotide, if I give to a patient who is MC4R agonist, MC4R positive mutation, that patient is going to lose 30 to 40 kgs. That's a huge amount of weight loss for that patient. So when do we ask for a genetic test? When we have a patient who's got a young onset obesity, obesity less than 10 years, which is severe. Family history of severe obesity, history of consanguinity, history of hyperphagia. So if these things are present, yes, it definitely does help to do a genetic test, and if positive, specific treatment can be offered to them. So friends, I think that's all I had to say. To summarize, yes, obesity has reached pandemic proportions. There is a significant role of medical therapy, which comes after initiation of lifestyle therapy. There are several drugs which came and went, some which are there. GLP-1 analogs seems to be the most promising at this point in time. Our indications for therapy are not only based on BMI. We look at the patient as a whole, and there is an upcoming role of genetics in some. I'll stop here, but would be happy to take any questions.
Thank you, Dr. Nitin Kapoor. Any questions from the audience? Or there's one very important signal which is coming up, GLP-1 and cancers, which we saw recent data from French showing signaling that there is evidence of cancers. What do you any comments on that?
Right. So we've been using GLP-1 analogs for a long time. The cancer risk was predominantly medullary carcinoma of the thyroid, mainly in animal models, where because we know that the C cells are much more common in rats than in humans. The human C cell density is 100 times less than in rats. So if you look at hardcore data, I would say still it is too empirical to say that it causes cancer. I don't think there is good human data to support that. We need to wait and watch like for any other newer drug. But having used liraglutide for more than a decade, I think it is okay so far.
To Dr. Nitin, first of all, I would like to thank Khare sir for having such an important conference here. I am a cancer surgeon, and when I see an obese patient, I get scared. Two things, because of two things. First thing is almost all the cancers are like more common in obese patients. So obesity, we always tell them that obesity is a risk factor. Second, I am a surgeon. So I know how difficult it is to operate on an obese patients. Sometimes it's a nightmare. And I think you have given a very wonderful insight into the pharmacotherapy. You said that these drugs are supposed to be taken lifelong, and they're always with the lifestyle modification. Then how do we know that the effect or the drugs are working or not? And it is because of the drugs and not because of the lifestyle modification.
Absolutely.
Because since morning, I think everyone is hearing diet, yoga, exercise. These are all very easy to say, but they're only easier said than done.
Absolutely. So I think very relevant question, and I think we didn't have an answer to this until 2 years ago, but the step 4 trial using semaglutide, what they did was they gave semaglutide, made patients lose weight. After that, they had 2 arms. One arm they followed only with lifestyle, one arm they continued the drug. And those who had only lifestyle, significant weight regain was seen. So that clearly tells us that continuing the drug helped to maintain the weight loss.
But there must be some target weight before which, suppose if I am 90 and I have my target weight or the ideal weight is 75, I have to reduce only 15 kgs. I have to continue the drug till I reach 75. What if I continue the drug after 75? I will still keep losing the weight?
The maximum efficacy.
It will have the adverse or the negative effects?
Not really. So the maximum efficacy for the current drugs is about 15 to 17%. So it's percent and not kgs. So again, that would not really amount to 95 to 70. But the other way of answering this question is that when we have weight loss that happens after using any of these drugs, there would be a metabolic set point that would reach. Your body would try and start conserving your energy. Your resting energy expenditure will go down, and it will become more and more difficult for you to lose weight. So if that 15 kg weight loss I'm seeing, the maximum would be in the first 6 months and hardly any weight loss in the latter half. So I think the body will get to a metabolic set point. But the best analogy to this is like diabetes. When I have a patient with diabetes, I start on a medication which has brought its A1C from 10 to 6. It doesn't mean that I continue the drug and the A1C will keep coming down. I maintain those drugs, the A1C is 6. Yes, if the patient has hypoglycemia, I will reduce the dose. If my patient has had very significant weight loss, which is still not so much with the current drugs, I will reduce the dose. But what basically would be that we will have to continue the drugs.
So the last question about the muscle mass and the weight loss. It's imperative that you lose some muscle when you're losing weight. But there was some signal about more muscle mass with the GLP-1 analogs. Recently they were pointing out there is excessive muscle loss. So what do you think in the long term, does it is relevant that you will lose a lot of muscle mass, or it is you will gain muscle, you can preserve the muscle mass with diet and exercise and can still continue to take the medications?
So very, very important point. Very recently we did a nationwide study looking at the prevalence of sarcopenia, and the results were quite startling for especially the elderly. There is a huge prevalence of sarcopenia and sarcopenic obesity. Most obesity trials have included a subset of where body composition has been done, so we know the sarcopenia levels there. And yes, there has been some muscle drop with any kind of weight loss. I think the key here is that with the weight loss, we encourage resistance exercises, increase the protein intake in the diet, and that will help to generate the muscle. But there are very exciting drugs also in the pipeline for improving muscle mass, not yet in the market, but yes. So once we have those, probably we'll combine. Reducing only fat.
In fact, it got a US FDA right back in 2015 for selective usage in some muscle disorders. This is probably going to get US FDA approval for selective obesity, protecting muscles and getting rid of diabetes.
Sarcopenic obesity. Thank you. Thank you. Thank you.
May I request Dr. Sanjay Godbole sir to share a memento to our moderator and speakers. We'll move forward to the next topic, strategy for maintenance after weight loss. I request moderator Dr. Archana and Dr. Anita Soni ma'am to the stage.
First of all, thanks for the organization for calling me here as a moderator. Since morning, we are all hearing about the how to do the weight loss, and the weight loss is possible with diet and the pharmacotherapy and the exercises. But the most important thing is how to maintain this weight. That is the most important. I think for that, Dr. Neeta Deshpande is going to speak upon how to maintain what are the strategies to maintain the lost weight. So let's hear from her how to do this maintenance of the weight. Thank you.
At the outset, thank you, chairpersons, and I thank the people who are still sitting here to come and to listen to this lecture at the fag end of the day. But this is the topic that actually comes at the fag end because with all the modalities that you've heard from all the various speakers, now you have lost weight. Now comes the next part, and the next part is how do you maintain that lost weight? And all of us know that that is the most difficult thing, and that is what every patient comes and asks you. I've lost weight. How am I going to maintain this? So that is the most important part. But what you need to understand here is that weight maintenance is very, very challenging. I put it just in a nutshell. Diet is perceived by the body as famine, as if there is starvation. So there are compensatory biological changes. And what are those changes? Reduction in satiety hormones, increase in the hunger hormones. Mainly it is that, and reduced energy expenditure. So because of this, there is a tendency to regain weight, and our body is constantly fighting those hormonal changes, which we call metabolic adaptation. Added to this, there are other challenges for weight maintenance, and that is the obesogenic environment. You can see here that everything is conspiring against that person who is trying to maintain the weight. So the world is conspiring against him. So everything. So there's food, different kinds of food, very tasty, very stylish. There were cakes outside, sandwiches and samosas and what have you. You have all of these things. How are you going to maintain that weight? So that is the next challenge. So this is the classic weight graph after caloric restriction. That means you are motivated, you join a weight loss program, you restrict your calories, you lose weight, patient is happy, doctor is happy. This is in the first 2 to 3 months. And then comes the real challenge, and this is typically what is seen. As time goes by, it increases. But you can see here that in this weight maintenance phase, if you're doing something on your own, you stand to increase more weight against if you were doing some personal contact, and I think Nitin also showed this, that if there is face-to-face contact, you are more likely to maintain that lost weight. So, but whatever it is, the trajectory is upwards, as you can very well see here. These are the gut hormone changes. Typically, what you can see here is amylin, ghrelin, PYY, and CCK. Ghrelin is the villain out here. That is the one that you don't want should increase. It's the hunger hormone. That needs to go down. The others need to go up. But with caloric restriction, exactly the opposite happens. And that is the problem. In the morning, if you were there for one of the lectures, someone talked about this particular program called the Biggest Loser Challenge. This was a challenge that happened in America where they challenged patients to lose weight. And what happened was that they lost a whole lot of weight, but look at the regain that happened. And when the regain happened, there was a change in the resting metabolic weight. And the metabolic adaptations, unfortunately, they continue, they do not stop. So the metabolic adaptations that occur after weight loss, they are actually very, very permanent. And that is why we always say that you may lose weight, but you do not lose the tendency to put on weight. The tendency remains. So that is the biggest challenge, and that's the reason that weight maintenance is so very difficult. Leptin levels also change with dieting, and this is the worst part, the energy expenditure. For the same 1 hour that you spent in the gym, you start expending less energy as time goes by, as you have lost weight, as you can very well see over here, that with weight loss, energy expenditure starts to get reduced, which simply means that your resting metabolic rate starts to reduce. So this is what happens. So what do we call physiological weight loss versus non-physiological weight loss? What do I mean by physiological weight loss? Physiological weight loss means that you are taking care of metabolic adaptations while losing weight. So that is physiological weight loss, and which would essentially mean either, of course, lifestyle modification and dieting is there, but it would essentially mean medication and surgery. Why medication and surgery? Because medication and surgery do not allow, or rather mitigate, the metabolic adaptations that occur. So that's why we call that physiological weight loss. You might wonder how giving medication to anyone or doing a surgery on them can be physiological. But physiological is with respect to the metabolic adaptation hormones. And that's why this is what is. So you can see here, so you give treatment after weight loss, and you can see that long-term weight loss is preserved, as against counter-physiological weight loss. That means only caloric restriction. So when you do only caloric restriction, there's physiological compensation and there is restoration of fat mass. And you can see here that this happens if you give only caloric restriction. So that is basically the kind of weight loss. So what I'm trying to tell you here is that you are probably setting yourself up for failure in the long term if you do not take care of the factors that would actually make you regain your weight. So from the very beginning, if you have a strategy in place where you are able to mitigate weight regain at a later time, either by talking to the patient about pharmacotherapy somewhere down the line or surgery somewhere down the line, only then would you be able to have a success story related to obesity treatment. So this is what happens. Caloric restriction leads to a weight reduced state. Weight reduced state is what I talked to you about, where the hormones are going in the wrong directions. So there is increased appetite and decreased energy expenditure. Whereas if you look at effective long-term treatment of obesity, you need to avoid that state called weight reduced state. The weight reduced state is something you don't want, because with it come all those bad hormonal adaptations which I have already shown you over here. So these are all the factors that are associated with long-term weight maintenance, and you can see that physical activity is there, low-calorie diet is of course there. There are certain personality traits, self-help groups, face-to-face or web-based interventions. There are so many different things that are there which can help you to maintain that weight. But let me tell you, it is always a work in progress. It never ends. There is no such thing when patients come and tell you, I've lost weight, now my story is over. It's never over. It's a chronic disease. So you can see here that the metabolic rate that I'm showing you here, it all depends upon genetic background, individual factors, etc. But what I want you to focus on here is that the large blue patch which you see down below, that is very important, and that is something you can't do anything about, which means to say that that is not in your hands because it is basal metabolic rate. All you can do is you can talk about exercise related physical activity, and you can talk about spontaneous physical activity, which is fidgeting or non-exercise activity thermogenesis, which we also called NEAT. So structured exercise, like you go to the gym or you do a lot of heavy exercise, and second is NEAT. So these are the only two things that you can manipulate, and that percentage is so small, as you can see over here. So this is a nice study which talks to you about fidgeting. So fidgeting can actually inhibit weight gain, and this is just a small little study to tell you about that fidgeting basically means that being active, or you can sit at your table and then you have these fidgeting balls and you have those fidgeting devices which you keep doing, so that also expends energy. So that is the reason for telling you this. This was the famous Look Ahead trial. It was done way back. It was a very structured program. People lost weight, but the factors that were associated with weight maintenance in the Look Ahead trial, it has many aspects to it. I'm not going to deal with that. Basically, a lot of people, there were people who were given intensive coaching, and there were people who were just given some standard instructions, two groups. And the people who lost weight and maintained it, they were the ones who had frequent contact with the trial intervention team. They had a lot of physical activity, and they also had reduced caloric intake. So these three are important. To me, the first one is the most important, keeping in touch with the team. So that is very, very important. I'm going to show you maybe some more study about that if time permits. But basically what is important is keeping in touch with your healthcare provider always ensures that your weight is in check. So this is again just a representative slide to tell you that pharmacotherapy is the one that can actually help you to maintain weight loss. This is a 1-year study. So this was actually a comparison between placebo, only exercise, only drug, liraglutide, and the last one was exercise with liraglutide. So you can see here, I think there was a question that was raised just in the previous lecture, which Nitin answered, and that was lifestyle modification combined with pharmacotherapy. What are the effects? And the effects are better than only with drug. So lifestyle modification has its place. I'm not suggesting here that lifestyle modification is useless, not at all. In fact, you can actually out-eat any pharmacotherapeutic drug. And we have seen this. You can out-eat it. Means you're on the pharmacotherapeutic drug, but if your hedonic pleasures override everything else, you can eat so much that you can actually overpower the effect of that drug as well. So you can out-eat it. But exercise with liraglutide had the best. Now this is the step 4 trial. I won't go into it because it was already talked about. So I won't go into that. It only tells you that continued usage of the drug ensures that you maintain lost weight. Now, this is the improving efficacy of anti-obesity medications that you are seeing. Some good news for us. I know it's expensive, but if you look at the history of weight loss drugs right from 1960 onwards, and the maximum percentage of weight loss right up to cagri-sema, that is semaglutide plus the amylin analog cagrilintide, it reaches almost bariatric surgery. You see the green band on top? That is bariatric surgery, the weight loss, which is of course the highest. But you have drugs now that are almost getting there. So, I don't know if this cartoon is visible or not. So there's this woman who's keeping only 1 foot to look at her weight. So the doctor is telling her, please put your other foot also back up. So this was a meta-analysis of 48 randomized trials. Then the largest weight loss was with low-carb diets, because I'm telling you about strategies that you can use for weight maintenance. So low-carb diets had some success, and there's another meta-analysis of 20 studies with 3,000 patients, which showed that anti-obesity drugs, meal replacements, and high-protein diets were associated with better weight loss maintenance. So this is a meta-analysis. So if you're looking at strategies and struggling with weight loss for your patients, so you can try all these. You can try more exercise, better exercise, resistance training, high-protein diet, low-carb diet, and drugs. So these are the different strategies that you can use and try and get your patients to maintain their weight. So this is the famous National Weight Control Registry in the US. They followed patients for years together to see who were the best maintainers and what were the determinants of that weight maintenance. And as you can see, this study tracks indices and predictors in individuals who've lost at least 30 pounds, almost 15 kgs, and have maintained that loss for at least 1 year. And who were the successful ones? The successful ones were the ones who were checking their weight, just like self-monitoring of blood glucose. You do SMBG, you have better results. You do self-monitoring of weight, you have better results. Consumption of low-fat diet, which I don't entirely agree with, because there is evidence for low-carb diet, not low-fat diet. Daily physical activity of at least 60 minutes. It was earlier 30 minutes, it's 60 minutes. Minimal sedentary screen time, consumption of most meals at home. That means you eat out less processed foods, etc. Bariatric surgery, won't go into the details. So calorie restriction, everything goes in the correct direction when you do, this is Roux-en-Y gastric bypass, but we do a lot of sleeve gastrectomies now. But in general, if you do bariatric surgery, you mitigate metabolic adaptation, the hormones go in the right direction, and you are able to maintain weight. This is the mind-body connection. So these are some of the yoga or meditation classes that if you can see the person sitting right at the far end there, that's Dr. Nitin Patankar at our center there in Belgaum, taking, talking about the mind-body connection and doing a lot of these things. And this is extremely important, because weight loss and weight maintenance, I always say, is a spiritual journey, and this is very, very important for that. Activity and exercise, aerobic, then weight training, that is resistance training, and that's me out there cycling, and these are my friends who are dancing. So there some of you may recognize them even. So these are different things that you can do, and there is a relationship between physical activity and weight loss, and that is why I have shown you this particular thing. This is a study where you don't have to look at that. I'll just tell you what it means is that a lot of people lost weight, and then afterwards for 6 months, one group was in constant touch with the doctors, the other group was not. But what was shown that the patients who were just in touch, nothing else was done. They were in touch with their healthcare professional, they did not regain weight, whereas the other group regained weight. So this is the difference between weight loss and weight maintenance. Please remember that. Weight loss is time limited. It's the first phase and it's done with, whereas maintenance of weight loss is lifelong. This requires a negative energy balance. There you require an energy balance at a reduced body weight, where you take care of the hormones as well. Reduced caloric intake is critical in the first phase, whereas physical activity is even more important in the second phase. So physical activity is not required for success during the weight loss period, true to a certain extent, because the caloric restriction itself is so much, and weight loss is common, weight loss maintenance is rare. So that is something that you need to remember. So this is the summary. Obesity is common, multiple complications, modest weight loss can be achieved by multi-component therapy. Weight loss maintenance is challenging, and this is because of the metabolic adaptation. Better engagement with the weight loss program, adherence to energy restriction, high level of physical activity can help maintain weight loss, not easy, and therefore pharmacotherapy may bridge that particular gap. But at the end of the day, it's all about choices. It's all about the choices you make. You make healthy choices and you will be able to maintain the weight. So thank you all very much for patient listening.
Thank you so much. As always, brilliant. We've been hearing you from the PCOS Society. I'm Dr. Anita Soni, a gynecologist, and that's what we have in common from the PCOS Society. And I can't agree with you more. It is easy to lose weight. Maintenance is difficult. It's a battle I have faced for more than 30 years of my life, from 120 to here today. And like just now, one of my girls just asked me, how do you maintain yourself? I said, it's here. And you know, the mind and body have to be in sync with each other to be able to maintain. Obesity now is no longer looked down upon like it's a choice you made. It is a morbid problem, and we're all facing it. The youngest ones, I'm sure you would be, it's the same with you, 8 and 9 years of age. And it is a battle, and it's a society problem. As us gynecologists, like Vimal said, Anita, just give us your bite. And I said, I'm finding it from the adolescent, I mean, even the younger than the adolescent age group, right up to the postmenopausal group. And I'm so grateful to all of you to take the initiative and come up. Please include us gynecologists. We're more than welcome to come and talk and help you in whichever way we can. But we need to fight this.
Thank you, Dr. Neeta. Is there any study which has done in India about the maintenance, as you said, in the US?
Yeah, all these, even the international studies have all, even with pharmacotherapy, they've all had centers in India where many of us have been investigators, even for the Indian population. Yes.
So you are also working
yeah.
on that. Any
So, for
questions
example,
from
the liraglutide trial, I have done it in my center also. It's called the SCALE trial. So many of us have done the studies over here.
Any question from the audience?
I guess we call it today. Thank you so much.
Thank you, thank you.
Now I invite Dr. Ketan sir for the mementos to give it to the moderators and the speakers.
Please come this way. थोड़ा आगे आ जाइए. थोड़ा आगे आओ. थोड़ा आगे. 10 मिनट.
Now we are proceeding with the last topic for this event, clinical assessment of obesity. I invite Dr. Jayalakshmi ma'am as a moderator on this stage.
Thank you for the great sessions today, and I would like to invite Dr. Vimal Pahuja for his talk on clinical assessment of obesity.
Thank you very much. In the interest of time, I'll be very brief because we are getting already delayed. minutes. So we'll be talking about the assessment of obese patient in your clinic, and it's a very important and relevant topic, because when the patient comes to you, how you are going to engage him, how are you going to understand what is wrong with him. Neeta was discussing about weight maintenance strategies, and one of the important thing is to take proper history to understand the why of obesity. If you can catch that and close all the loopholes, you'll be able to successfully give weight loss to the patient and also weight maintenance. So history and gauging readiness, anthropometry, evaluation of systems, diagnosis and staging, and discuss the plan. These are the structure of my presentation. Obesity is defined as, it's a chronic relapsing multifactorial neurobehavioral disease, whereas an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biochemical and psychosocial health consequences. So this is a complete definition of obesity, and we understand there are a lot of issues. It is not just a weight loss, but it's a chronic disease. It's a relapsing. It's going to come back again. Multiple factors are responsible. So we understand that we address those multiple issues. And it's a neurobehavioral disease. We have to have the behavioral changes in place if you want to give weight loss to the patients. And whereas an increase in body fat promotes adipose tissue dysfunction. So it's primarily the adipose tissue dysfunction which is creating the diseases in the body. Just take a case of 55-year-old female who comes to your obesity clinic, the history of steady weight gain over the last 2 years, and she has a family history of diabetes and heart disease, and she's worried that she may get diabetes. So what we should do and how we should evaluate her. So coming to the weight, history is very, very important. You have to look at the onset and duration of weight gain, which is very relevant, how the weight has gone up. In this case, it's a very steady weight gain. Sometimes there's a sudden weight gain, so we have to understand that the weight gain sudden can be related to certain factor or certain situation, which we have to find out and try to curb that. Maybe sometimes it is related to the stress or related to certain medications the patient is taking. Situation leading to weight gain after menarche, change of job, stress or menopause. What are the efforts taken in the past which have worked or not worked for the weight loss? Very relevant, because if you're trying to do something, if that has not worked, probably it will not work here as well if she has come to you. What are the efforts taken in the past and what are the barriers in the journey? And barriers you have to understand, because something patient has tried to do and is not doing, which has been told earlier, the barriers has to be addressed. Problem solving is very important if you want to really have the success story of this patient. And weight ranges and weight timelines with factors influencing them at each point in the timeline also has to be understood. This is a weight timeline. You can see how the weight is going up and what are the factors and what are the situations which lead to the weight gain and weight loss too. So all these things is very, very important. It's useful tool for understanding the clinical assessment and what the determinants of obesity, clinical, behavioral, and the biological. All determinants can be understood from the weight timeline. You have to have a good childhood history about weight gain, what kind of habits they were in, what are the culture, what is the food culture, who prepares the food, who feeds the food to the children is also very important. Milestone, birth history, and the family history of other cardiovascular diseases, and also history of GDM in mothers, because progeny is going to become diabetic or progeny is become obese in the future. What are the medications which were used for the past, whether they have worked or not? Those also have to be assessed, and any other medication linked to the weight gain also needs to be checked. Mental health is very, very important. So how is the patient sleeping or not? Dr. Sanjay showed you the data that 8 hours of sleep, 8 hours of sleep. People are sleeping less. And that's the reason for sometimes for obesity. So these have to be addressed. Anxiety, depression, mood disorders, eating disorders. We have to ask for this close-ended questions to understand whether the patient is eating because of emotional challenges or because of stress or night binging is there or not. All this information has to be there in your history. Then whether there's a readiness to change, whether the patient is ready to change himself, whether the motivation is there and social support is there. Family may be having, there may be body shaming in the family. If the social support is not there, this patient won't do well. And we have to counsel that family members that the support is and empathy, showing empathy is very important for such patients. Psychiatric status of the patient, if you are trying to enroll in a program, if your psychiatric status of the patient is not good, she's not going to do what a dietitian has told or what the exercise person is going to tell him, those things are not going to work in the patient's favor nor your favor. So you have to stabilize the psychiatric disease first. Presence of stressful life circumstances, time constraints, goals and expectations. Reasonable and practical goals have to be set. They cannot be unreasonable goals. People start, when we enroll the people in the program or we ask them, what is your goal? They say, I want to lose 20 kilograms. It could be unreasonable. Your BMI is 38, I want to become 30 BMI, I want to lose 30 kgs. It may be an unrealistic goal. So we have to talk to them about the realistic goals, set a short goals and go forward. There will be a much better in terms of success and happiness. Nutrition history is also very important. Preferred food, eating patterns, and taking into consideration the calorie intake of the food as well as the macronutrient and fiber intake. This has to be a detailed diet recall. Diet diary has to be maintained, and ask for the person who's shopping, who's going, are they reading food labels? Who's shopping and bringing the stuff who's stuffing in the refrigerator or the food stuff? Is he reading the food labels properly? All these things have to be asked properly. Number of times went for dining or takeaways, Swiggy, Zomato, we also have to be considered in your history taking. Any preferred binge days? Sometimes people, they have a good food for, 4, 5, 6 days, they're eating healthy. And Saturday, Sunday, abhi to main aaram se khayenge. Saturday is free, so they go out and eat. And Sunday also is a binge day. So Saturday, Sunday becomes a binge day for many. And this can be also one of the determinants which will not allow them to lose weight. Experiment is a fad diet. Everybody is experimenting. Intermittent fasting, somebody was saying, somebody is experimenting with a keto diet. They are ordering food, very costly keto diets, and there are fat diets going on. The experimentation is rampant now. So all these things have to be in your history. Physical activity is also very important. Exercise, how many minutes of exercise, issues with exercise, whether they've got any injuries, it's very important. Motivation issues for barriers or exercise, any other activity like yoga, dog walk, whatever they are doing have to be captured. And assessment we do generally, a 6-minute walk test is a very formal or simple way of doing the assessment. How many times a patient is stopping, what is the speed of the patient's walk, how many, if he become breathless, all these things we assess by doing a simple 6-minute walk test. Anthropometry like BMI, easiest way to report obesity but has fallacies, and waist circumference, which we know correlates best with the visceral fat. And we know BMI, this is a definition of obesity by the BMI. Asian Pacific cutoffs are definitely we have a lesser cutoffs as Asians. It is 25 kilogram per meter square of BMI, which somebody will be termed with obesity. And so this assessment is also very important. What the fallacies of BMI being, for same weight, women may have more fat mass as compared to men, and muscular individuals may have higher BMI and still less fat mass. So there's a lot of fallacies with the BMI, and that's why BMI cannot be one tool to report obesity. Hence, waist circumference is appropriate tool along with BMI for Asians in your clinics. I'm not talking about the measurements with DEXA scan or the impedance biometry, because those are tools which we will use to understand about obesity, but these are the two clinical tools which we use in the OPD. Assessment of obesity is best made by the waist circumference, and you can see there are two methods. Whether you can have the measurements at the waist level. WHO method is where you measure waist size at midpoint between the highest point iliac crest and lower point at the ribs, and NIH measures the waist size at highest point of iliac crest, and WHO method is much better, which predict the development of the heart disease and diabetes in future. And Asian Indians have a low cutoffs of 90 centimeters in males and 80 centimeters in females. So this have to be kept in mind. Physical exam, everything has to be clearly said, and you can see you do always assess for sleep apnea, which is mostly missed in all the clinics. Patients have a lot of issues, headaches, they have tiredness in the daytime, sleep apnea is rampantly missed. Stop bank score should be used, and basic investigations what we do to see for the metabolic complications, to see for any secondary adiposity or endocrine related disease related obesity has to be also seen. Sleep studies have to be advised, and this is a complete checklist of all the metabolic and the mechanical complications which we have to address. So the whole gamut of tests we will require to address these: pre-diabetes, metabolic syndrome, type 2 diabetes, dyslipidemia. It's a complete list we can go through. So of course, these main complications are pre-diabetes, metabolic syndrome, type 2 diabetes, dyslipidemia, cardiovascular disease. You have n number of diseases which you have to screen, and you have to do n number of tests to find out about each complication whether a patient has, and ultimately we have to understand what we have to treat for each of these components. It's important to stage the patient for obesity, and staging of obesity is very important. Dr. Nitin Kapoor already has told you about the Edmonton staging system, and we use this very often in the clinical practice to stage so that we obtain a therapeutic decision about how to treat this patient going forward. So you can see the stage 2 becomes, if your patient has got obesity, a BMI of 30 kilogram per meter square and has got diabetes, it becomes stage 2 straight away. And the patient's BMI is 40, but there's no diabetes, not pre-diabetes, also it becomes stage 1 or 0. So this is how we stage this patient, because this will tell you what kind of therapy you are going to give this to the patient. And if you see stage 2 or stage 3, straight away goes for lifestyle intervention, pharmacotherapy, and maybe bariatric surgery, if not else. So when this patient, coming to the case which we saw, is this BMI is 34 kilogram per meter square. She's got pre-diabetes, dyslipidemia, anxiety situational, sleep is normal, sleep apnea is ruled out by the score, and why of obesity we addressed. We have seen that he's got motivation issues, emotional eating, and poor food choices. So this is a complete assessment of this patient who comes to you, and obesity diagnosis, we'll say this class 1 and stage 1 obesity for this patient. So this is the way we have to diagnose the patient. We have to understand the issues and work around those issues to give a better results to the patients in terms of weight loss and weight maintenance as well. Thank you so much for the patient listening, and I think I was in time. Yes. Any questions? So we can. We have a complete pro forma which we have to fill out for this patient, like diseases what she has or the family has, how the weight loss has started. We draw a complete timeline for this patient, and then the age of menarche and the history of PCO, everything we have, and the medications she is taking, what are the motivation issues. In fact, before the patients we start with the encounter, we have a feedback form where we tell them, ask them their barriers, what are the motivation, why he wants to do the weight loss, and what are the goals expected. So all these things we get it, and then when we discuss with the patient, everybody sits together. So we have a multidisciplinary team which will be sitting with the patient after the assessment, and then we have to make the plan and give it to them. So this is how we do, but we have a complete detailed pro forma before we go ahead and make a plan. So understand everything about a patient's obesity, sleep, muscle mass, everything is seen into consideration, and then we decide how to go about planning the treatment. See, if you go by the guidelines, of requirement of bariatric surgery, stage 3, stage 4, around 25% of the patients, 20 to 25% may require bariatric surgery when they come to us. But I think hardly 2 to 3 or 5% less will go for bariatric surgery. So preference for pharmacotherapy also is very poor, hardly 5 to 10%. Preference for bariatric surgery is also very poor, hardly less 5% or so. So this is how we see, but generally 25% of the patients will definitely need bariatric surgery at the outset.
And from your practice, how many percentage of the patients actually lose weight over a period of years?
The data we have, whatever we have seen 60 to 70% of people definitely lose weight. 20 to 30 people may not lose any weight, because there's the issues with the follow-up. As Dr. Neeta was saying, the follow-up is a very, very important thing in obesity treatments and obesity practice. If the patient follow-up is very poor, they are not going to lose any weight. In fact, it's much more than diabetes. You have the people in the diabetes clinic don't follow up, they still have a better A1C because they are taking medications. But in obesity clinics, if they don't turn up, it is very difficult to really give them weight loss. So that's a major, major challenge.
Thank you, Dr. Romal. If any more questions are there, or we'll close the session.
Thank you, sir. I request Ketan, sir, to hand over the mementos to our moderator and speaker. Sorry. Okay.
large lamp.
Please look here.
After having a good study session and snacks with chai, let's have a good quiz session. I call upon Dr. Nitin Kapoor sir for a quiz session round.
Right, so everybody in the hall is eligible to participate in the quiz. It's a very simple quiz. You just need a smartphone with internet. That's all.
What do we do?
Smartphone with internet. I'll show the QR code and then with that you can log in. Just an announcement before that.
The executive members and the directors have taken a call. Those who are getting participate for the quiz, we are offering them the lifetime membership of BAPI. So everyone should join in and participate in full attendance.
Can do. We not get them prize. Okay. The top 3 prizes for the people who win. So I was going through the lectures all day, and I think all the answers have been told not once, at least twice or thrice during the day. But there are certain questions which will also test your knowledge on Bollywood, Hollywood, politics, and all of that also. We just have 20 minutes, so I think we'll get started. How many of you have seen Kaun Banega Crorepati? I think everybody. So you've seen that round which happens there called the fastest fingers first. So it's not only important to be correct, but it's also important to be fast, because even microseconds will be taken into account when they choose who's the winner. For each question, after each question, you will know where you stand. So the top 3 will keep changing as we go along. What you need is brain, luck, phone, and internet. And that's all you have. So I think with this, this is what is the QR code. Either you can type menti.com on Google, and at that time you will get a place where you can enter this code, or you can go through this QR code and directly go. I'll give you time so that everybody can log in. Some are doing. But I think still the younger generation will win. It's fastest and smartest. So if anybody is having any problem, raise your hand. Not many people have registered so far. Only 11. 12. For those who still want to join, just type menti.com on Google. The first link that you get, click on that and enter this code 65532387. Anybody having issues? Raise your hand. Code is there on every slide. Even if you get disconnected in between, you can go to the code. Anybody still waiting to connect? Okay, 70. You can play, you'll not get the prize. Anybody who's having a trouble, raise your hand. Everybody's in. You can keep joining. If in between your internet goes haywire, that's not a problem. It's your bad luck. Right. The decision of the quiz will be final, so there will be no fights. We have 20 players. Right. So I think we'll get started. So the first question. The question will come on your phone as well as here. repeated at least 4 times today. No answers. 12 people have answered. You have just 15 seconds, only 5 left. After that, the voting will close. Good. At least more than 50% of the audience was attentive. Let's see who is winning. So, Radha first, some Voti McVote face. Who's that? Okay, great. Second, SMP. Who's SMP? SMP. You have to identify yourself. SMP is who? If you don't identify, it will go to the fourth. So I move on to the next question. SMP. Okay, great. If you heard Dr. Ketan's talk, is there in the program schedule also? I think we can have little more music. Builds up the stress. Oh. So, not many people were listening, but you had the program schedule with you, but you had to be fast also. Prachi, very good. So Prachi is in top 3. Good. Top number 1. Very good. Question number 3. This was also projected in the first slide today, first session today. The IDF criteria, and even I think Dr. Ketan also showed the IDF criteria. Seventeen people have voted, not everyone yet. 4 more seconds. So HDL less than 50 in women is a criteria. In men it is 40. Not a very attentive audience. Right. Rishabh Patel, can you raise your hand? Good. Next question. Again told. This is based on the Indian study. Different for men and women. More for men. Some people were listening. Next question. World Obesity Day was commemorated last month. Very good. No loud answers. Good. I think it was well commemorated in Mumbai. People seem to know. Good. In total, 15 questions. We are on 6th right now. I have to definitely leave at 5:30 for catching my flight, so we have to finish. A very simple question. all medicine PGs should know. Shouldn't take so much time. It's a very simple question. When we were managing obesity, we were saying it's not only important to give the anti-obesity medicines, but also look at the comorbidities and the drugs, correct? 13 people have answered it correctly. The maximum you can get in any question is 1,000 points. Those who are not on the list, don't worry. A single question can change the scores quite a bit because you get 1,000 points. This was also shown in at least my slides. But you have to be correct, you have to be fast. Good. At least majority answering correctly. Okay, Prachi is winning. Very good. Question number 8. This was even in the last talk, so even if you've not listened all throughout, even in the last talk it was mentioned. EOS is a staging system. You want to say somebody has EOS stage 2 and you're looking in terms of diabetes. So not many people attentive there. Only one person will move up. Who's Abdul Ghani? Round of applause for you. Question number 9. So still it can change, the scores can change a lot. Spoke of cancer and diabetes, cancer and obesity, even in the panel. One cancer seems to be less common. Correct. Anybody can say why? Why is prostate cancer less common in people with diabetes and obesity? So diabetes and obesity is associated with a lot more estrogen and causes hypogonadism. Hypogonadism is preventive in prostate cancer. So one of the therapies for prostate cancer is gonadectomy, or giving GnRH analogs to reduce the hormones. So obesity and diabetes have hypogonadism, and therefore prostate cancer is less common. Right? So the top 3 will get the same price. So you can relax your hormones. We're moving on to more questions now, to Bollywood, Hollywood, and less of subject after this. Now this was a very simple question. I think at least 3 or 4 sessions mentioned this. Right? Cagrilintide is an amylin analog. It's got nothing to do with GLP-1 analog, though it can be combined with semaglutide for obesity management. Anjali doing a good job. Right? Now wear your hats on beyond medicine. Oh, this one I showed in my slide. Non-peptide. Phase 3 trials right now. Starting trials in India. Good. People were listening. Who's Mars? Can you raise your hand? Okay, good. Question number 12. This one gentleman increased the sales of this drug. Elon Musk increased the sales of which drug? I think you get the question options in your screen. Or you can type your answers. You can type either the brand name or the answer, both will be marked correct. Spelling has to be correct. The software cannot detect wrong spellings. So spelling wrong, not acceptable. Ozempic would have been acceptable. 11 people wrote it correctly. Right. We're going to see a skit, clippage. One of the movies which reflected about obesity. One of the Bollywood movies. The question will come in the next slide. The whole theme of this movie is based on obesity. The movie name is also here. Dam Laga Ke Haisha. Yeah. So the question is, there were 18 players. So in this particular movie, the actress actually gained a lot of weight to fit into the role. The question is, how much weight gain did she do? She actually gained so much weight to be eligible to participate in this movie. 35. So that's hard. Somebody gaining 35 kgs for their profession. Right. Question number 14, the second last question. Again, this slide was shown. The options are actually better visible on your phone than on the screen. Okay, people were not listening. Hyperphagia is an indication. That will change the scores again. Right, the last question, after which we will know who are the three winners. All of the following Bollywood celebrities have had a bariatric surgery except Google or a magazine. No, they have committed in different interviews that they've had. Okay. Let's see the winners. So Mars, Prachi and Abdul Ghani. A big round of applause, please. May I request all three of you to please come on stage, and maybe I'll request our president of BAPI to please give the prizes. So we have Mars, Anjali and Dr. Abdul Ghani. What's your actual name? Pratamash. Okay. Big round of applause, please. Anjali can come with Prachi. Anjali. Dr. Abdul Ghani. Oh, from Nova team. Okay. Then we can probably give one more postgraduate, Rishabh Patel. So maybe we'll give one more person, Dr. Rishabh Patel. Thank you. Thank you, sir. So I think, as promised, everybody gets a BAPI membership. Please contact Dr. Ketan here and give your details. All those who participated with your phones that you participated, I'll send in the list of the names as well. Right, so I think with this we come to an end of the quiz. Back to Dr. Raman.
So with this we'll come to the end of our first meeting, and it was wonderful having you here. I thank you everybody for attending this first symposium. I thank the management of Apollo Hospital, the residents who have helped us for this event. They have been really toiling hard day and night for last so many weeks. I thank our sponsors, our pharma companies who have been very instrumental and who have been supporting us with unrestricted grant for this BAPI Symposium. And soon, probably next time, we'll have a bigger meeting, and promise you we'll have bigger meeting in next 6 months probably to come up with a 2-day meeting where we have a better scientific content. Some international speakers, and also we are going to come up with webinars soon, so all can attend. It will be labeled as crosstalk webinar from BAPI. There will also be some modules which are going to come up to train the doctors who want to learn the metabolic medicines. So all this is in pipeline. I still urge anybody who's not a member to become a member of the BAPI. Spread this awareness about obesity in your friends, other doctors, other fraternities, so that we have a maximum force to fight the disease of obesity. Thank you.
So just one last message. MMC has granted 2 points for this. Now the certificates, please collect your certificates on way. So you will have to fill up your own name and write 2 certificates. This will be accredited directly online into your central MMC account after 1 month. But we've been granted 2 medical points. So thank you very much.